All right, good morning. Although I am disappointed at this fact, I am not Charles Iberrule. I am Greg Webster. I'm one of the cardiac electrophysiologists here at Lurie Children's Hospital, and although you are all welcomed at the beginning of Grand Rounds, welcome to the Sudden Arrhythmia Death Syndromes Foundation Conference. I'm excited to see everybody here. I also will say that we have a large number of people joining us online. We have an international community and a national community of folks who have chosen to sign on by Zoom. So every sneeze is being broadcast around. I want to say some very specific thank yous. Jen Acevedo, if you are in here, she's already running around. All right. Jen Acevedo has been absolutely instrumental in making this conference actually happen. Jen is responsible for the CME that you all are going to be able to apply for at the end of this, and has been an amazing partner in making this conference work. Her partner, Kathy Nolan, is an important part of that as well. So before I thank anyone else, I would like to thank Jen and Kathy. The SADS team is a big team, and you may have gotten a chance to meet several of them as you came in and checked in. There are more that are either joining remotely or are otherwise involved. But I'd like to thank in particular Alice Lara and Marcia Baker, who have taken the lead on this conference. We're nice enough to invite Lurie Children's to host it, and year after year put on an amazing conference that we are lucky to be a small part of. But feel fortunate that SADS has chosen to continue to educate our community in this way. So thank you. You may see that there is a conference of families that is in the room next door. They will join us this evening for the meet and greet as well. But by all means, please interact with them and introduce yourselves and make them feel comfortable at home. For those of you who know me, please tell them nothing about my own personal care. Some of them are deluded into staying with me, and I'd like to keep them similarly deluded. In any case, I welcome you to talk with the folks who are joining us and to please make them feel equally comfortable and at home. Finally, I'd like to thank the members of the program committee that we're cycling up on the board. The talks you are hearing are put together by that group of people, and the invitations that those of you who are speaking received. Sarah Cherney, Lisa Castillo, Susan Etheridge, Pete Aziz, Alice, Marcia, thank you all for making this happen. As you can see, we are hosted by Lurie Children's Hospital. In addition, the room and all the facilities are intended to be for education, and you may see various house staff and other folks coming in and joining us. But I'd like to thank Stu Berger, who is the head of cardiology, who's here to join us, as well as Estella Alonso and Tom Shanley, who are part of making these types of conferences happen. But most importantly, I'd like to thank my partners in electrophysiology, both the physicians, the nurse practitioners, the nurses, the genetic counselors, the administrative staff, the people that not only make the clinical work happen, but have been instrumental in making this educational process happen today and tomorrow as well. So thank you all. And then when this is all over, I would like to make sure to invite all of you to go to the Thrive Therapeutics sponsored reception that is at the end of this at about 5 o'clock. If we can keep ourselves on time, it will be at 5 o'clock. Otherwise, it'll be at 5:15. That is for everyone to enjoy. The families will be there as well. Please feel free to mingle, and we'll be excited to have everybody together. For those of you who drove here, there is a parking voucher, and you do not want to pay parking in downtown Chicago without the parking voucher, so please stop by the front desk and register for that or grab the voucher itself. Similarly, instructions for the CME are in the syllabus, and there's a QR code, so if you want to collect CME, read the syllabus. Finally, for those of you who are joining us online, there will be an opportunity for questions during the presentations and at the end of the talks. If you want to type those into the chat, I will be monitoring those and either ask those chat questions at the end or slip those chat questions to the moderators. But we want to encourage people who are online to participate in the question and answer, and doing so by interacting by the chat is the best possible way. We are listening and paying attention, and please join us virtually as we go forward. Second to last, the bathrooms. The question that by far is the one that I've been asked the most since the conference started. If you go out these doors all the way to the end of the hallway where the big windows are and turn to your right, the bathrooms will be just onto your right. For those of you who are joining virtually, I'm going to trust you to find your own bathrooms, but feel free to reach out to me if I can be helpful. Finally, I'd like to thank our primary sponsors. In addition to Lurie Children's, Tenaya Therapeutics, Thrive Therapeutics, and Boston Scientific. These conferences can't happen without your help and support. So with no further ado, I will leave this to our first session and leave by thanking the SADS Foundation and our sponsors. Dr. Burrell.
Who will be talking on 2QT or not 2QT? That is the question in neonates.
Thank you. 2 minutes left. 2 left after Greg. Well, first, all right. So I'm going to put this on first for my prop. All right. So QT or not QT? That is the question. Okay, that's as long as I'm wearing before you got the picture. Yeah, that was worth $5 from Amazon. Okay. So it's not a challenge diagnostically to figure out if someone has congenital long QT syndrome if they're born congenitally deaf and a QTC of 600 milliseconds, or if they have 2-to-1 AV block due to a markedly prolonged QT interval, if they have macrovolt T-wave alternans where every other T-wave is going up versus down, or if they have Torsades de Pointes. That's not a clinical diagnostic challenge. But the mother of that, the EKG on the top of that congenitally deaf girl, here's her EKG. It's a little bit abnormal. QTC is maybe 460 or 470, and that's much more of a diagnostic challenge. And we've known from early days, Mike Vincent, the first SADS medical director, put out this beautiful study of genotyped patients from Utah showing the clinical conundrum of the overlap. Some of the genotype negative patients have QT intervals as long as 470, and some of the genotype positive patients have completely normal QT intervals. And so that's really the diagnostic challenge of is it QT or not QT? Dr. Ackerman and group looked at the diagnostic accuracy of the ECG in the first 2 days of life for newborns of a parent with congenital long QT syndrome. So they have a pre-test probability of 50%. And again, you see that overlap, right? Some of the genotype positive patients have a normal QT interval in the first 48 hours of life, and some of the genotype negative offspring of long QT parents have a prolonged QT in the first 48 hours. And so, you can't see that. And so you can see about 17 or 71% of the genotype negative patients have a long QT in the first 48 hours of life. And so here's their recommended algorithm of what to do with those patients, when to get the next EKG, when to initiate treatment with a beta blocker, when to do genetic testing, and what to do about those results. And the group from Germany, a group from Germany, had similar study, birth cohort of patients with long QT interval, not long QT syndrome, long QT interval. And when they got a repeat EKG, most of them had normalized, and if not, they got a third ECG, and 12 of them still had QT prolongation. 10 of the 12 did not have congenital long QT syndrome. So in the end of that 2,600 patient study, only 2 were diagnosed with congenital long QT syndrome. And they show nicely how the QT interval drops over the first weeks or even months of life. And this viewpoint came out from a group of experts, some in the room, looking at how to screen patients with ECG and whether to continue screening based on if it's 450, 460, or 470, and what to do in sequence there. I'm not going through the details of each of these because I only have 10 minutes, and they're all a little bit different, but they all give you their expert recommendations. Now, I'm trying to put in pictures of everybody on the panel today that's speaking in this session. So from P disease, he looked at long QT with 2-to-1 block, like that first slide I showed you, the bottom panel of that first slide, and they show that even in those situations where you think it's more dire because of the severity of the QT prolongation, many of those patients with proper diagnosis and treatment do well and better than expected. And this is not a new question. This paper by Dr. Schwartz in 1982, so 40 plus years ago, looking at 4,000 newborns, they found that 3 of those patients died of SIDS of the 4,200, and they all had a prolonged QT interval. And so that got him thinking, maybe long QT syndrome is one of the causes of SIDS. This is moving on its own, by the way. So he looked at QT in healthy infants and showed that. And then that brought him to this landmark paper of 34,000 newborns, screening basically everybody to look at their ECG, and showed that 34 died in the first year of life, and 24 of those 34 were due to SIDS. And those with SIDS had a longer QT interval than, doesn't show. Okay, I was looking for the arrow, it doesn't show on your screen. But you can see the black bar on the right are the patients that died of SIDS, and in general, their QT interval certainly was longer than those who didn't die or who died of non-SIDS causes. Although look again at the overlap. Many of those dots are below the bar and were normal QT intervals even though they died of SIDS. We kind of questioned that and wondered whether this would have a very cost-effective way to do that. I'm not going to get into that controversy again. It was very controversial at the time, both the cutoff point of 440, which is going to get a lot of normal kids, babies, and the cost of doing that. The cost of doing anything in the United States is more expensive than other countries, and we looked at whether to screen everybody versus just screening those at high risk, those who had a family history or other reasons to get an EKG, and basically showed it's a lot cheaper to screen those, if you thicken the soup, you're going to get a higher yield. You have to look at not just the QT interval, but look at the humps and bumps on the EKG, right? You need to see what's the U wave doing? What's the biphasic T wave? In I think it was 1982, the textbook by Garson and Gillette decided, with no data, that if the U wave is greater than 50% of the amplitude of the T wave, you should include that in your measurement. I've looked and haven't found any data for why that makes sense. So we still do it. It's based on that textbook statement, and the textbook, that statement doesn't have a reference to a primary citation, but that's what we do. And so if the U wave is big, you include it in the QTU measurement, and it ends up being quite long. But if you take that EKG there and only include the QT without including the U wave, it's normal, the QT interval, if you don't include the U wave. So you have to take into account these extra humps and bumps and whether to include them or not. And if you still don't know, provocative testing can be useful. It's a little too soon after the election to put up that slide, sorry. But so provocative testing, stress testing is probably the most common thing that we do with QT. To decide whether there's a normal response to exercise. Lots of data from Dr. Ackerman's group, my group, a lot of the groups around the world to look at criteria for differentiating patients based on their exercise testing. My talk's about QT in newborns, so you can't really exercise newborns. We've designed a thing to exercise toddlers that gets a little closer to the newborn age, but essentially you can't put a newborn on a tricycle either, they just fall over. But so other provocative ways of doing things, you can give pharmacologic provocation, isoproterenol or epinephrine, the ice water challenge, putting your head in a bucket of water and seeing the response to your QT interval after that. But these days, we're doing genetic testing, right? That's going to be your most accurate way, not these genetic tests, but since the later session is going to talk about genetic testing, I'm just putting up these sort of general consumer generic tests. And I have to show a slide from Dr. Webster when he was a fellow on genetic testing in long QT syndrome, because he spent a lot of money making this slide, and so I have to keep using it. At that point, there were 12 known genes for long QT syndrome, and he beautifully created this slide where he separated them. The bold ones are the most common, the pink ones are potassium, and it looks great. But, you know, over time that slide gets outdated. We need to hatch a few more eggs. There's more than a dozen known long QT genes now. And then after fellowship, we co-authored a paper, meaning he does all the work and I put my name on it too, on the genetics of long QT and looking at the molecular implications. It's interesting because phenotype can predict genotype, and in my work of trying to get all my other panelists on the slide, this paper by Dr. Cuneo and Etheridge look at how the arrhythmia phenotype during fetal life can predict the genotype in the neonatal period, depending on how they present, whether they present with torsade or 2-to-1 AV block or just sinus bradycardia, and how that predicts the postnatal genotype. And likewise, genotype can predict phenotype, looking at fetuses and what the EKG is going to look like based on their genotype. And showing here, long QT 1, 2, and 3, and freedom from cardiac event based on their genotype. Came up with this beautiful illustration here of the outcomes of their patients from fetal life to neonatal life and so on. And finally, Stephanie Chandler and colleagues looked at SCNA disorders and when it's not long QT type 3 and different clinical presentations of SCN5A disorders. So is it long QT syndrome or just a long QT interval? It really is the question. And sometimes you get a QTC of 460 and they end up with torsades and sudden death. And we just have to realize that it's not a perfect science yet. Clinical diagnosis, you have to take it all into context, their response to medications, their family history, and their genotype, and it's really a balancing act. Thank you.
Thanks a lot, Charlie. And he set the tone with 10 minutes on the dot, but he's going to put his hat on just real quick one more time for Dr. Answer.
No, because that will show up somewhere.
I know.
I took it off too fast.
Come on, pressure him. Charlie.
Get my $5 worth out of this hat.
Yeah. Peer pressure even works at age 30. I love it. Well, way to start it off for us, Dr. Brule. Second is, when is sympathectomy enough? And Dr. Stephanie Chandler is going to tell us that in Stephanie. We're going to have a 10-minute question and answer right at the end of the 4 talks.
Got to make sure I keep time with Charlie, so set my stopwatch. All right. I'm Stephanie Chandler. Thanks to the organizers for having me. My talk is the title of my talk is When is Sympathectomy Enough? Management Questions in Long QT Syndrome. I don't have to tell the people in this room, but so that we're starting at the same place, congenital long QT syndromes are potentially lethal but highly treatable cardiac channelopathies. There's 3 major forms of long QT syndrome, but they all result in an increased action potential duration, and we appreciate this clinically on patients' ECGs when we examine their QT intervals and their T-wave morphology. When appropriately diagnosed and risk stratified, an effective treatment strategy can be established for almost all patients. For most patients, the management milieu in long QT syndrome consists of one or more of these things: lifestyle modifications, pharmacologic therapy, or surgical and device therapy. But the question in this talk is, when is sympathectomy enough? Or said another way, are there patients for whom the management map could look like this? Before we get too far ahead of ourselves, we'll briefly review what a left cardiac sympathetic denervation is and why it actually works. The first LCSD was performed in 1916 in a patient with intractable angina and cardiac arrhythmias. LCSD is a surgical anti-adrenergic intervention with antiarrhythmic effects. What it does is remove the left thoracic sympathetic chain and paravertebral ganglion from T1 to T4. The mechanism of action of LCSD is two-pronged. Its antagonism of acute catecholamine release from the heart and its antifibrillatory effect on the ventricular myocardium. Traditionally, LCSD has been reserved for an acute subset of patients that you can see there on the right. But if we were going to add to this list of indications LCSD as primary therapy, what would that look like and what would that target population be? I would argue that maybe LCSD as primary therapy could be considered in a subset of lower risk long QT patients. Okay, Chandler, but what does lower risk long QT syndrome actually mean? Many smart and thoughtful people, a lot of whom are in this room, have taught us how to start risk stratifying patients. We know that there are markers that we look at: age, sex, genotype, and then the really obvious ones: patients who've had cardiac arrest, patients who've had arrhythmic syncope, and how long your QT interval actually is. So if we're going to start making a list of how we define a lower risk long QT patient, it might look something like this: patients who are asymptomatic prior to diagnosis, patients who have an incidental finding of long QT syndrome, patients with long QT1, a median QTC of less than 500, and no significant cardiac event. So is there any data for this? Dr. Schwartz and al. First reported LCSD as monotherapy for patients with long QTS who were unable to tolerate adverse events from beta blocker therapy. Dr. Abrams in 2017 reported on an individual case of a young male patient with severe depression and anxiety on beta blockers who was treated with LCSD as monotherapy and who has been without clinical events since that time. And then Nayas et al. Did a retrospective study at the Mayo Clinic of 204 patients who underwent LCSD for long QTS, 64 of whom were successfully treated with LCSD as monotherapy. There were no significant events. There were no significant long QT-related surgical complications, and only 3 patients experienced non-lethal post-LCSD breakthrough cardiac events. Importantly, and if you ask Dr. Ackerman, who's sitting right here, he'll probably tell you that those patients who had breakthrough cardiac events wouldn't have fallen into the lower risk long QT category that we're talking about right now. In addition, we know that the efficacy of LCSD is good, and it's been demonstrated in multiple reports, as previously noted. But it doesn't provide 100% protection. It's not a curative strategy. It's a management strategy, and this is an important distinction for people. Busey et al. Reported in their 2022 paper that 6 months post-LCSD, patients with a QTC of less than 500 are at significantly lower risk of all cardiac events. It's not that there's a 0 chance of a cardiac event, but it's to say that there's clearly a difference between patients who have a QTC of less than 500 and patients that have QTC of higher than 500. So all this is really to say thoughtful patient selection for answering this question is critical. What are the downsides to LCSD? Anyone who's seen a patient with an LCSD will know you can have unilateral dryness, color or temperature variance between the sides of your face, abnormal sweating, and really importantly, neuropathic pain. I think we all know that LCSD, just like any surgical intervention, isn't free. But what are the upsides? I would argue that there's 2 big ones: quality of life and addressing the issue of medication noncompliance. We all know the downsides of beta blockers, but what are the upsides? The downsides: depression, anxiety, fatigue, comorbidities. Antiel et al. Assessed 100 patients with long QTS and CPVT. What are the side effects of depression, anxiety, fatigue? This one's quality of life and noncompliance. Yeah. We all know the downsides of beta blocker: depression, anxiety, fatigue, comorbidities. So if we think about LCSD as a marker for managing some of these things, what do we know about that? Antiel et al. Assessed 100 patients with long QTS and CPVT and asked whether LCSD had an impact on their quality of life. 92% of patients and families were satisfied with their surgery and would recommend it to other patients. Waddell-Smith et al., in reviewing side effects and patient satisfaction post-LCSD, found that the majority of patients were satisfied postoperatively. 86% were happy with the procedure, 75% felt safer, 91% recommended the procedure to others, and 91% felt happy with their scar appearance. So despite the comorbidities, LCSD was reported to have good patient satisfaction. When we think about noncompliance, as early as 2009, the importance of issues of noncompliance were highlighted by Vincent et al. When they reported in a retrospective study that 11 of 12 patients with long QT1 had suffered a sudden cardiac arrest or death were in fact noncompliant with their therapy. And we know that there's a lot of things that factor into noncompliance: age, lifestyle, travel, and family dynamics, and a whole host of other things. So as clinicians, our primary concern is often endpoints and cardiac events, but our psychology colleagues often remind us, how do we manage quality of life and quantity of life, and are we thinking about the right endpoints? How would we do it if we were going to do LCSD as monotherapy? If we're going to start offering LCSD as monotherapy, I would recommend that it look something like this: shared decision-making with families, consultation with clinical surgical sites and centers of excellence, and informed consent all the way. So I'll pose the question to everyone out here because I actually don't know the right answer. Should we be offering LCSD as a first-line therapy for the management of long QT syndrome in a targeted patient population? And how are we defining success in patient care? I'll leave you with those questions.
Thanks a lot, Dr. Chandler. And our third talk is going to be from Peter Aziz. Are there any sports restrictions left in long QT syndrome?
Thanks, Mike. Thanks to SADS for bringing everybody together today. Thanks to Lurie for hosting. We're going to talk about long QT restrictions in sports. You guys can see this hand, which I believe we stole from your hand, so sorry about that. Wasn't my fault. All right, my relevant disclosures are none, and I really like presenting things in the face of patients. How do we see this clinically? So this is a 21-year-old patient that I follow. She is a collegiate athlete, and during sprints running in soccer, collapsed, was not breathing, did not have a pulse. And her coach grabbed an AED and put the AED on her, and as the AED was being turned on, she woke up and didn't have recollection of the event, but obviously had return of circulation, and other than amnesia, had full recovery. And she was brought eventually to us, and I think we don't need calipers for this ECG. The QTC is quite long. And who, in their mind, seeing this vote sign gives me some PTSD from Tuesday, but sorry about that to open up some old wounds here. But who thinks in one day that this patient could return to play again? Raise your hand. So I asked this question in a similar conversation about long QT and return to play and used her as an example. And there was maybe 2 or 3 people that raised their hand, and Mike was one of them. So we've come a long way. So long QT syndrome basics, we all know about this. Leading cause of autopsy, negative sudden death, about 1,000 cases a year. Sure. We know about the repolarization abnormalities. Usually management of potassium is the issue. And torsade tends to be the final common pathway in terms of what causes sudden death. And we use beta blockers, particularly nadolol, to treat. I think we can all agree on that. But long QT syndrome has many faces, and the genotype matters. These are the 3 most common. Everybody's familiar with this. But I'll draw your attention to long QT1. Common triggers can be exercise and sympathetic tone. So sports restrictions, I think, are are, particularly important for the long QT1 group, though beta blocker response is actually quite good. So I think that balances that concern to a large degree. So what do we know about sports participation? We'll all remember this, at least those of us who have been around for a while, the Bethesda 36 conference guidelines, which we were all really married to back in the day. Fortunately, we're not there anymore. But the bottom left was what our patients were restricted to by the guidelines: cricket, curling, bowling, golf, riflery. I don't even have to, it's reflexive to say that. I think it is for a lot of you here. And cricket, I think, is particularly bothersome to our Pakistani and Indian colleagues who know that that is a pretty intense sport, so maybe does not belong in that category, but I wasn't there, so I take no responsibility for that. And Mike, being the pioneer that he is, published data in JAMA in 2012, and this was our first look at what long QT syndrome in sports can actually be. And what he saw, what they found was in 130 patients that they followed, there's one cardiac event in 650 athlete years. And that patient was an athlete, to be sure, but was warming up, not actually in competition, and was also a high-risk patient that was non-compliant with beta blockade. Similarly, this is our CHOP data and mentored by Molly Shaw. We looked at a little over 200, genotype positive patients, and about half of those were athletes split into recreational and competitive athletes. And we found data really similar to Mike's. In 755 patient years, nobody had an event during sports. There was a long QT2 patient that had torsades during an influenza A illness, and a non-compliant patient with an ICD, so a high-risk patient that was running around in his backyard and had torsades and got appropriately shocked and survived. And I think that led into, amongst other studies, I know Boston has a study as well that showed similar findings, but this was the groundwork, I think, for the LIVE long QT syndrome study. Many people in this room are involved in this study. Mike, Rachel Lampert, and Charlene Day were the leads on this. And what we did really is follow these patients prospectively. And what we found, we identified 1,400 patients now and split them up into three categories: sedentary, moderate intensity exercise, and vigorous, and split those patients up into two categories: the non-vigorous and the vigorous. And what this study showed was that the freedom from composite endpoint, which included death, cardiac arrest, ICD shocks, or what was considered arrhythmogenic syncope, and a Kaplan-Meier curve, as you see here, those two groups really were no different. Whether you were participating in nothing at all or you were a vigorous athlete, your composite outcome really was the same, which was favorable. So how does this look like in terms of current guidelines? Again, credit to Mike and Task Force 10 for putting this statement out together, which really gives us a lot more latitude to be able to do what we need to do as channelopathists in the clinical world. We have to assume, and we have mostly very, very highly motivated patients that are compliant, that want to participate, that these patients are abiding by the guidelines, taking their beta blockade, maintaining hydration, avoiding medications that they should avoid, and of course that there's a safety net. This is an important part of the equation, that the coaches, for example, know about the child's condition. There's a response that has been rehearsed and certainly thought of, so that an AED is present and people know what to do. And there's lots of legislation, certainly in Ohio and I'm sure elsewhere, that mandate that AEDs be around, more so than they used to be. Looking at this in terms of where we were and where we are now, looking at the ESC guidelines, the Bethesda 36 and Task Force 10 in columns there, what do we see here? So for a concealed long QT patient, in other words, a genotype positive but phenotype negative patient, Task Force 10 says that those patients shouldn't be restricted at all. If somebody is symptomatic, they should have no restrictions unless it's a long QT1 swimmer. I'll tell you anecdotally what we tell our swimmers. I have a long QT1 lifeguard. This is the job that she decided to take on this summer. And I was like, come on, But I think for a lifeguard where swimming is complicit into what they do in a day-to-day, I think swimming is different. So we live near Lake Erie and the water is not clear. somebody drowns in Lake Erie that's free open water swimming, you're not going to be able to see them. Getting them out of the water is going to be difficult. Getting them dried and finding an AED in the middle of a lake is going to be challenging. Whereas if you're in a swimming pool, I think that equation is a bit different. So we try to differentiate those things when we have these conversations. If a patient has an ICD, thanks, Mike, just says talk to an expert. So we're not restricting those patients. We're saying here's the latitude to make your own clinical decision and do what you think is best based on your conversation with the family. Let's take this back to our 21-year-old college female athlete. She has, I think everybody in the room could guess, based on her T-wave morphology, broad-based. She had exertional syncope. Of course, she ends up with a KCNQ1 pathogenic variant. She has long QT syndrome type 1, and what do? We put her on Nadolol. She was asymptomatic for a year, and through shared decision-making, we allowed her to participate in her senior year of college, which she was forever grateful for. So are there any sports restrictions left in long QT syndrome? To answer the question, and I'll quote Mike, genetic discrimination needs to stop. We need to guide and route rather than just kick them out. Kicking them out is the easy decision. I think we have to be smarter than that, even when it's harder. Thanks for your attention.
Thank you. Our last speaker is Dr. All right, Mike.
Is Dr. Elizabeth Stevenson.
Hi, everybody. Thanks so much. Thanks to the organizers for inviting me. I forgot to do a disclosure slide, but I don't have any disclosures. So I was asked to talk about how much phenotype you can ignore in a genotype positive patient, which is a really, really difficult question, so I'm not sure I'd like to thank the organizers. And also because you've heard a lot already today about this gray area that exists, so I will try not to duplicate too much of that. So first of all, what are we talking about when we describe a long QT phenotype? It's not just the QT interval on a single ECG. So you need to consider repeated measurements, something that Dr. Ackerman has shown very well, that you need to look at this more than once. You need to look at it via exercise testing, not just resting ECGs. And you need to also consider not just the QT interval, but also the morphology, the response and dynamics during exercise, and of course, any associated symptoms that you have. Why do we care about this? Well, it's everything that we've talked about already today. The implications of a diagnosis of long QT syndrome, not just carrying a long QT variant, are medications, typically beta blockers, which we know carry some morbidity, the risk of sports exclusion, because not everybody is as open-minded as Pete, and so you do get a lot of kids who are taken out of sports, and of course, the burden of an ICD in the most extreme cases. We often used to call this concealed long QT syndrome. A patient who is asymptomatic frequently would be identified due to Cascade testing in a family member. QTC less than 440 is what people would often talk about. And about 30% of the population with long QT variants will have either a normal or a borderline QTC due to the low penetrance of some of the variants. So it's not a small number of people that we're talking about that fall into this gray zone. And there is clearly a reduced risk of cardiac arrest compared to a phenotype positive patient, but there is still a greater risk in this population compared to those that are genotype negative. So we can't just write them all off automatically. We need to think about it carefully. Measuring the QT interval is actually hard to do. And there's a study that I'm sure we're all familiar with from Sammy Viskin in 2005 that showed that more than half of cardiologists get it wrong. And even about 20% of EPs tend to calculate it incorrectly. I like this diagram that's from the QT calculator site. which shows the tangent method. They also show the threshold method there, which I find less satisfying, so I'm sticking with the tangent. And you can see that it can be quite difficult, particularly if the morphology of the T wave is abnormal. So it's really important to be thoughtful and to consider the U wave exclusion that Charlie already talked about, so I won't repeat that, as well as that morphology of the T wave. So why is there so much variation in phenotype? Well, there's a variety of reasons for that. One is the variable penetrance that I talked about already. But there are also genetic modifiers that are important to think about and we're really just starting to learn about. So there are very common SNPs in particularly KCNE1, H2, and SCN5A, which seem to be modulating expression, and there's a lot of work going on in this area. And then there are also non-coding SNPs in promoter and untranslated regions, which also seem to alter expression from wild type versus variant allele. So a lot of interesting work going on. And I think many of these, if not most of them, are still unidentified. So I think this is a place that a lot of work is going to be helpful to us going forward to try to understand not just what is your kind of dominant genotype, but what modifiers might some people carry. And Arthur Wilde published an article just a couple years ago, a review that just had this lovely diagram in it, where he describes, you know, you've got your sort of original mutation, which is stretching out your QT interval, but then you have to think about modifiers such as what drugs is the patient on or not on, do you have low potassium, and what other deleterious allele might you carry. And we always spend a lot of time trying to make sure that our patients do not take QT prolonging drugs, but actually sometimes they need them, and then you have to deal with that consequence. And then finally, there are also protective alleles. And so this may be part of the reason that some genotype patients actually are not showing a phenotype, and we don't know very much about those at this point as well. So I think both of those are going to be an interesting place to watch. There are higher risk genotypes, and with these, many of them will present with a clear phenotype as well. So it may be a little bit easier. Some of them may have a higher penetrance, but also, as in almost all rare disease, we see the most severe phenotypes first. So as we learn more and more about a more rare variant, it may not be as bad as it looked when we first saw it. So we learn over time about that piece. But when you're considering your patient, the one in front of you, you should definitely take the specific variant into account and think about what you do know about what that phenotype-genotype correlation might be in that particular variant. Particularly interesting to think about long QT1 and 3 with missense mutations in the transmembrane domain. We know that these are going to be higher risk. And then also some of the variants that we're pretty well established are actually higher risk, even though they're rare, such as calmodulin. So do we have any guidelines to help us with this area? The long answer short, not really. This is, again, from the Wilde article, but it's based on the 2013 consensus statement. And it basically walks you through your QT family, and then it talks about if your QTC is less than 470, maybe a beta blocker, probably, maybe not. So it's not very helpful. So there's something more recent, maybe, something that's going to have addressed this. Well, in Canada, we have a group called HERO, which is an inherited arrhythmia interest group that's really doing some really great work. And there's a consensus statement from just last year. So lots of great diagrams here. But let's find our patient in this, our borderline patient. And what you can see is that you get, I don't know if you can actually read it, but this is a genotype positive proband. You do your clinical testing, you do your genotype, and then the answer is lifetime plus minus pharmacological therapy plus minus intervention. So not really any help. And that's because there is not a right answer here. We have to look at these patients as individuals. You cannot classify them purely based on a single number. And what's great to see here is the HERO group is actually studying this. So one of the things in the flow diagram is please send these patients to us because we want to know more about them. They're trying to enroll into a borderline group, which hopefully will give us some insight into that. So when we're looking at this intermediate range, right, the 440 to the 470, and you saw from some of the older work that's really the range that people tend to say. Some people say above 470, definitely you're positive. Less than 440, definitely you're negative. There's some gray in that, but let's use that as a starting point. So the qtcalculator.org is a website that, for a calculator, I like it a little bit better because you don't put your number in and get like an answer. You actually put your number in and you get this diagram. And so I put in a 13-year-old girl with a QTC of 460, and it tells you how often that occurs in a control subject and how often that occurs in a long QT patient. And it's just a nice extra piece of data to put into your consideration and make sure that in that overlap that we saw over and over again this morning, you are thinking about, well, what proportion of people are on the QT side of that overlap and what proportion of people are going to be on the normal side. So it's a nice additional piece of information. So back to our original question, how much phenotype can we ignore? I would say if you are truly phenotype negative, asymptomatic, QTC less than 440, you can start to feel more comfortable about that group. If you are phenotype positive, greater than 470, think about symptoms, think about repolarization, and both of these really need expert interpretation. And then when you're in this borderline group, we really need to go back to that shared decision-making. It's absolutely essential to understand where the family is coming from. What are they afraid of? Is this somebody who has lost a child and is looking at a sibling? They may be terrified to consider not being on a beta blocker. On the other hand, this may be an incidental finding 4 cousins away, and their mom actually had terrible beta blocker intolerance. So you really need to understand where the family is coming from. It's essential to your successful treatment. And you have to incorporate all the considerations, variant, any known modifiers, the lifestyle of this family, sports participation, required medications can be very challenging if you have a patient who needs a QT prolonging bed, and of course, puberty. And don't rely on that single measurement. You need repeated evaluation, and you need that exercise testing. Thank you so much.
Thank you very much. And if we could turn the lights on, and our 4 speakers were 4 for 4. They were spot on time as requested. And one of the things we desired of this meeting is, unlike so many meetings where everybody goes over and the Q&A session is just used as the buffer time to disappear, it's intentional for there to be this. So the 10-minute talks were really set up to get our conversation started together. And so we have 20 minutes of a dialogue. So if we could have the 4 speakers come on up here, and the 4 speakers, and Bryn, if she wants to talk, and I will address your questions, have a conversation for 20 minutes, and then we'll do a 5-minute stand and stretch to then get started right back on time on the schedule at 10:45. The party started.
Hi, I'm a pediatric genetic counselor, and I've been doing cardiogenetics for 2 years, learning all the trades. My question for Dr. Barrow. So do you think with the advancement of detection for channelopathies that there could be a standard newborn screening that could be added along with PCHD for early detection in newborns?
Challenges that I don't think that's the right time. Caveats to a lot of folks. I don't know why I'm leading into it.
But now it's not.
Thank you. Hi, everyone. Thank you for those great talks. This question comes from a patient that Mike and I actually share together, a patient with long QT2 who was born prematurely and had a quite dramatic phenotype over the first, especially weeks, but then months of life, and it's become much more mild since then. And I learned purely from Mike about the potential effect of the fetal isoform leading to a more dramatic phenotype. And I think it's fascinating. Along the lines of the newborns with QT, is there anything more that you guys could share with us about fetal isoforms, premature babies, et cetera?
I think the clinical observation is pretty robust, and I bet you that would gel with everybody. Patient's longest QT interval is probably what? First one, isn't it? Almost always, unless there's an exogenous QT prolonging factor. So there is the regression to the mean phenomenon, especially in known long QT patients in infancy, and particularly LQT2. So the KCNH2 gene has an isoform switch, and it's probably that the mutation in the context of the fetal isoform has more loss of function than in isoform. And so that might be for LQT2 the particular reason why you see that their very first newborn ECG is always the most dramatic, and then 6 months later it's less. And so often our conversation is, wow, this patient really responded to the beta blocker. It was 530 during the first week of life when I started it, and now it's 450. Well, it probably had nothing to do with the beta blocker. We have moved to holding off and not treating instantaneously, especially in know their risk is intrinsically lower. So if it's sustained, then we'll start. But there's a good reasons to sort of watch and see what's the evolution of the QT. Are we getting natural normalization rather than giving so much credit to the wow effect of the beta blocker shrinking the QT interval? Probably not the beta blocker in that sense.
Another point is that many of the really malignant long QTs that you get in the neonatal period are spontaneous mutations, de novo mutations, often long QT3. But so the family screening is not helpful, right? So screening the parents are going to have most likely have normal ECGs because they're really bad infants. You already know that they're coming from a family of long QT or there's.
Before we go to our online audience and attendees, and we have a lot of them, we'll take that one next, but since the keynote has the microphone.
I was interested in two points. You mentioned that beta blocker doesn't shorten the QT. Now, I've always practiced that and thought that, but then we've seen some data from Peter Schwartz saying that the QT shortens with beta blockers in his population. And, I've always thought that changes in heart rate, but he obviously sticks by it, and I wonder if you've ever seen that in your cohort.
Absolutely, and so but the point is beta blockers don't shorten the QT interval, propranolol does. So not all beta blockers are created equal. So natalol has almost no QT shortening effect. What propranolol does, that's because propranolol has what besides in its chemistry? It's a weak mixillitine. Propranolol is a non-selective beta blocker plus weak mixillitine. Want QT shortening potential, and now that we see how effective mixillitine is in LQT2 and 3, I think the preferred beta blocker to start LQT2 and 3 people on is in fact propranolol.
So you think that Peters was due to because he used propranolol?
Exactly.
I didn't see him
very
specifying that.
You don't see QT shortening data in natalol and metoprolol, and hopefully nobody's using it.
So the other question that I would like everybody's opinion on, if that's possible, is that innovation monotherapy. So the biggest dilemma is for the young female adult who's asymptomatic but has got a worryingly long QT, horrible looking bumps on the T wave, particularly LQT2. When would people, what sort of level of risk would people accept before they then offer a denervation if they can't tolerate a beta blocker?
I don't know. Yeah. I think this is this is the area that I think this question becomes exceptionally challenging. And I think it really becomes a conversation with that specific patient about what risk each individual patient and each individual provider for that patient is willing to accept. Because I think we know from some of the work that Dr. Ackerman's group and others have done that LCSD as monotherapy is very effective for patients who are in the lower risk quartile. But once you start to touch that area of higher risk female, adolescent, getting close to 500, really abnormal 2-week morphology, and we know that that QTC is going to change over time and from specific characteristics of what's going on, I think it becomes a very, very challenging conversation. But that being said, sort of like we talked about in the talk, I think the longer I do this, the more I appreciate some of the real downsides for patients of beta blocker therapy, how it makes them feel. And so I think it's really about a conversation with families about what they want from a risk-benefit perspective, but also what they want from a quality of life perspective.
Peter, from our online attendees, what about non-traditional activities like open water swimming? You mentioned that one with Lake Erie, scuba diving, rock climbing. Do you have suggestions?
Yeah, those are tough. I mean, I think you can consider various recreational sports, even anything that's in elevation, anything that's underwater. I think the concern there is, how do you rescue somebody? So whenever we have these conversations with families, we always say, if the worst case scenario happens, what is the process? What are the steps A through Z that the family or the bystanders are prepared to take? And if it's something like long roller coasters is another example. If it's something where you can't intervene, you can't get to the patient, scuba diving, I would say, seems particularly dangerous. I think they just have to know this is different than the run-of-the-mill kid playing soccer and the reasons why. Most parents and most families, when they hear that, oftentimes will reconsider, because they should. I mean, for something like that where you can't intervene, I think everybody should take pause. Not to say no, because I don't think that's fair, but to say you need to at least understand the risk before we move on with this conversation. And there are definitely, activities like that where intervention is just not possible.
And to follow up with the online, again, Peter, what about cold water plunging after training an athlete? Then I'll take the becoming a pilot one.
Yeah.
Is there any data about the pro-arrhythmic potential?
Yeah, Mike, I'm sure you know this data as well. I don't know many varsity cold plungers, but for those that are out there, I think there's the sympathetic response that happens with recreational swimming. You're doing laps, that increases your catecholamines, and that could be arrhythmogenic, as we all know. But there's something about the dive reflex that also is arrhythmogenic. And what I've heard is that in what we've seen clinically, at least in non-swimmers, but in patients on telemetry, for example, the vagal mediated pause followed by a sinus beat that has an incredibly long QT interval, and then a PVC that it gives you an RNC and develops torsade. I think that's the cold water diving mechanism. It is vagally mediated. So there is definitely real risk in that. But then you fall back on all the things that we've talked about before. What environments are they in? Are there people that are during AED, right? What's the worst case scenario, and can they be rescued?
On the pilot one, we actually have a paper coming out on not just return to play, but return to work for athletes, firefighters, officers, so forth, and aviators. And it's obviously a small series as we're getting comfortable. It doesn't really matter what you and I think with an aviator. It matters what the FAA thinks. And so some of it, and that's part of the conversation that you have to have also with the athlete. It frankly doesn't matter what I think. Once that athlete gets to the university level or the NBA or the NFL, there's then not shared decision-making, but what we call TDM, shared decision-making. Have to prep them so that these kids are returned, but then feel like they got the rug pulled out from under them. We have a few aviators who have returned. I've flown with them, so I have no problem. But the challenge is you won't get an aviator with long QTs to get to start his or her career. But if you diagnose them after they're in a redundant cockpit, then you have a much greater chance with the dated to that redundant cockpit.
I think that's a great point. We're looking, I'm sure everybody in this room is looking forward to a document like that because we struggle with this too. We have a handful of firefighters, for example. We've written letters to advocate for them, but the fire department says that's a hard stop. And,
Yeah.
and
we
can't
just
do much about it.
got our first firefighter reinstated with an intern. First one approved by, but there's not the firefighter organization.
That's right.
So it's going to be one by one, and same thing as in the military. Military is changing. When the lines were really long, part had to be perfect. Now that the lines aren't as long, we're actually meeting with the military and we're putting together a tactical athlete document because they're trying to get more room to enable more people not to get kicked out. So with the obesity issue and now weight issue where you get kicked out, so they're interested in who can stay. But we have a LQT2 individual who's apparently in the branch of the Army that doesn't have a name. It's sort of above all of the above. So after he's been this $2 billion invested fighting machine, then they're like, can he stay with his LQT2? And we're like, yeah, of course he can. And so they're, oh, thank you very much, because that was a huge investment. But starting them off, it's really hard. We're working on with a Marine right now to get reinstated after denervation solo therapy. So we were able to say he is now worldwide deployable, not on a beta blocker any longer. So on a chronic medication is one of the things that nixes WWD, worldwide deployability. Now that he's coming under the hearing to see if it's acceptable for him to turn to the
Hi, Dr. Aziz. I know you talked a lot about exercise in patients. I'm assuming most of those studies included patients who were compliant with their beta blockers. As Dr. Chandler mentioned, there are a lot of side effects to beta blockers. So one thing that I have noticed is a lot of patients not wanting to take beta blockers or not being compliant with beta blockers. To your knowledge, is there any data on adverse events in patients who are not compliant with beta blockers who are not on any therapy?
Yeah, sure. In Cleveland, Ohio, everybody takes their beta blocker. Just kidding, obviously. No, we struggle with this, and this is, as you saw in the data that we presented, both from CHOP and from Mayo, noncompliance is usually the breakthrough event. So the two patients in each of those studies that had breakthrough were noncompliant. And as much as we hammer it, it's an unavoidable issue. So I think falling back on the patients that demonstrate noncompliance continuously that you think have reasonable risk, a sympathectomy is a good fallback in that situation. And the noncompliance, I think we are willing to point the finger at the patient and say, you got to be compliant, what's your problem? What we're not asking is, why are you not compliant? Sometimes it's because they can't get their bleep together, but sometimes it's simply because they have side effects that are intolerable and we're not having that conversation. So if you have that conversation and that's the problem, then you as a physician are not, treating the patient appropriately and you got to pivot.
Don't you agree, Peter? I mean, even though those were non-compliant in the setting, we showed that the recurrence rate was much higher in our former athletes than our current athletes. Into it, we surmised that the athletes are far more compliant. They know the drill. They know that they can't afford a breakthrough because a breakthrough is going to put him or her back into the penalty box. Mom and dad might change their mind as to what's their risk meter set at. So I have found, even though our examples were non-compliant, overall, the athletes are incredibly compliant to the drill. Now, it may be get me off the beta blocker and get me innervation, because not only, because compliance doesn't have to be, I hate my beta blocker, therefore I'm not compliant. I mean, compliance can also be, what other treatment options do I have, because this one is negatively impacting the whole of my life. Law. Marcia, do you have the?
Throw it.
And we are 3 minutes on our clock for this session, and then we'll take the 5-minute break and get panel session 2 ready.
So I see the athletes at the University of Iowa, and there's this paradox of the QT prolongation of athletes. And I think of, Elijah Mabel answers too. There's that study done in the New England Journal of Medicine published in 2018 where their cutoff for a long QT was 500. And, if they didn't have the humps and bumps that Charlie referred to. So, and if you looked at that cohort of 11,000 primarily male athletes with a QTC cutoff of 500, there's only one channelopathy. The most common cause of death was non-cardiac, but there's only one patient that had a presumed cardiomyopathy. And then you have this military study that's done in 2023 showing that just exercise itself can prolong your QT interval. So here's this phenotype positive, and those end up being in the military, genotype negative. So what are you using for your cutoff in these situations? You talk about these athletes that you see. What are you using for your cutoff? Anyone on the panel?
I'd love to hear what Mike's cutoff is. There is none, right? I think we all struggle with this too because we've seen the bell-shaped curve. It's a matter of statistics, and the QTC sometimes is a useless number. You got to look a little bit deeper than that, family history and symptoms, and parents' ECGs, which I think is critical when you're trying to figure out whether a 460 means anything or not. But not everybody, but many patients with long QT syndrome have normal QTCs, and many people that are totally normal have QT prolongation. So I think our reliance on the ECG, I think, is a little silly in some of these cases.
Beth points out that 470 number, but those are the genotype positive people, right? So this is the genotype negative group. We do I got to tell you, they're 480, and there was no one in that European study had genotype testing done if they're 500 or 480. So it wasn't routine. I don't know what's your comment on this, Elijah?
I think, as you said, in that overlap, in that gray zone, we're never going to get perfect. So if you set the cutoff at 500, patients that are over 500 are highly likely to have long QT syndromes, right? So it's going to be quite specific. If you set the number at 440, like Dr. Schwartz did, your sensitivity is going to go up, but your specificity is going to go down, and you're going to get a lot of false positives. So it's that group between 440 and 480 that's still the challenge, and you have to do, as Pete and Beth said in her talk, all of the other things besides just the raw QTC, right? Put it in be a doctor, right? And put it into perspective with the family history, the patient history, the other testing that's being done, and then genetics.
I think the negative genetic test is huge. So now there'll be new data from our group that our yield after 25 years of being diagnosed as long QT syndrome, but having a negative genetic test is now less than 5%. So if you're going to still call somebody long QT syndrome in the face of a negative or phenotypic data, robust, persistent, flimsy, and wobbly, and I think one of Peter Schwartz's greatest papers kind of has gotten missed over, and it's that recent one of the exercise training maladaptive QT response. That the training itself, and we sort of stumbled into that because we've removed the diagnosis in over 300 patients, and almost all of them, many of them, were athletes who got disqualified on their screening ECG, and then by the time we saw them after 6 months of disqualification, their QT was dramatically better, but Peter and Leah Crotty nailed it. And so if that was the context of it, and there's no family history, and the genetic test is negative, well, then they're probably one of those athletic training QT reactors that has nothing to do with long QT or long QT risk. And so if you don't know that paper of Peter Schwartz, that's a great paper. Well, we went into almost our conversation time. We're going to break, stand up, stretch, go to the restroom, but Dr. Webster wants to start on time at 10:45. We'll give you a 5-minute bonus. We're going to start at 10:50 for the next panel. Thanks, speaker. Yeah, I don't like to be trained because you ruin their whole year. So if you know that, know, but when they stopped already, they've already had their detraining, so I don't detrain them further. Yeah. How much is required and how much is you wonder how much is And if our audio-visual person could unlock the computer,
I work here. Jen Acevedo is an echo tech.
so if you get them on there. I got the bullet right there. So you, by the time you see them, you get them, you do the next one. I do. I do just because I want to have as much ammunition as I can. So I feel really good. I really find now that for long this isn't a rule out, but it's getting really close, where you have to say, why am I still going to insist on this diagnosis? When we were frustrated with all these years of offering and health, why are we not finding anything else? Mostly there. It's mostly the common. They get 3 months, come back to you, nothing else. Well, that's a good one. 3 years ago, I would have said yes. Now, yeah. If you don't need it, or the administration doesn't need it, then you have. But I think it goes down to because what I tell them is, look, we're not going to get fooled by a view. It's got to be a slam dunk, right? And then, but I will also stress test them. Right? So if they don't show any maladaptive QT reaction during the stress test, because they could have been training effect LCT1, then they go concealed, but they're provocable with the stress test. But if their stress test is clean, then I think you're almost, now I think
I know, you saw that?
I newly restarted.
I can't do it because of my nails, so.
I guess I have tendency to probably don't do it, but maybe that'll be enough for if ammunition of data has never done it this way. Therefore, now we can say make exceptions on all these things. Now, I don't know how many were in that.
Yeah.
I wanted you to sign back in.
I am back in, and we are on talk number 5, correct?
That's a good question. I think we are.
All right, I just wanted to close some of those other ones out.
I believe you are the next speaker?
No.
Oh.
I just realized now when we see the audience, need a timing change. Can I but if they were over that in the setting that you're describing.
When are you going?
You're over that in the healthcare.
Put it in the Dropbox. Yeah, and I'll get it. Okay.
And in your setting, it's probably a right shift. And why don't we?
This is my
Let me get it after.
Okay.
Part of it is.
Stevenson went already.
Steven, say it again?
this person went already,
Yeah.
Stevenson? Okay, so then we are ready to start with Barnett.
But if there's another reason.
Oh, well, yeah, we still have time.
Could you get that back?
Oh, here, yes. What, sorry, I'm operating off of everybody's last name. Oh, yeah, I'm here. Yeah. Call me Kara. What plan, or are we, like, in terms of, is it a different set of? Oh, okay. We're gonna do, okay.
Let everybody watch. We continue to have, worries about your thing getting signed out. I have a mouse.
Oh, perfect. Thank you. Yes. Just to avoid it. Okay.
Sign into that, and I'll do that really quick.
Okay.
Nope, didn't like that.
Okay.
Okay.
That's okay. This was like the only one time that was, something was gonna,
I'm not sure what's going on with the computer though.
there,
So,
okay.
try minimizing this. Oh, that's okay. Escape. Now we got your, back bar back. Okay.
So, okay, so I'm gonna close that. And then.
About half an hour, right? Half an hour.
What do you mean?
Just, like stretch break.
I don't know. I think it's like 20, yeah. We did a drop down and turned off that. Yeah. There we go. Okay.
I'm just going to do a verbal, if people can start coming back to their seats. We're going to get started in the next couple of minutes here. Those are from the last session. Okay.
Cold water flooding.
No, they did. We didn't. I'll keep there. You might close that. Two quick things. There's no split monitor. And then I'm monitoring the chat and
I could barely see my own slides on here. I had to keep looking up there.
yeah, exactly.
I can see.
Make sure Paris gets up great. Go ahead and play that.
Where you want to do the first and third?
All right, I'm going to get us started on our second session of the day. If everybody can start to find their seats. Exactly. I'll save that for the afternoon sessions when everybody is exactly. All right, thank you all for joining us. I guess this is the third session of the day. I will introduce Dr. Charlie Barul and Dr. Susan Etheridge, who will take us into our first talk with Cara Barnett.
Thank you all. It's been really a great experience so far, and I'm just thrilled that I'm not going to have to invent any questions, that you guys are going to do them all. So let's bring our first speaker up. It's Cara Barnett, and she's going to speak about how Cascade screening changed my management. Cara here. panic there.
Yes. Surprise. Okay. Hello. Thank you all for having me. Very excited to be here. So I'll be discussing how Cascade screening changed my management. Okay. I have one disclosure. It's not relevant to the talk today. So we'll be walking through a case example together. The patient, Sarah Smith, is a 10-year-old female with a recent ventricular fibrillation arrest while at the beach on spring break. She was very lucky that bystander CPR was initiated immediately and an AED arrived after 5 minutes. 1 shock was given. She converted to pulseless electrical activity and then organized rhythm. Return of circulation after 10 minutes and AED tracing confirmed a V-fib arrest. Transported to the hospital, received an ICD, and she had no prior relevant medical history. So, while at the hospital, of course, she received additional phenotyping to help guide further care. And we're going to take a turn away from long QT towards short QT. So an ECG during her admission showed a somewhat short QT between 344 and 357. Exercise testing demonstrated a lack of adaptation of the QT interval to exercise, with a baseline QTC of 361 and a shortest QTC of 353 at peak exercise. And then this is her initial ECG from the admission shown. So where I come in, of course, is taking the family history and discussing genetic testing, follow-up, what results could be. So here's the pedigree we took at the time. Our proband in the middle, Sarah, with a clinical diagnosis of short QT syndrome. She has a maternal family history of atrial fibrillation in her mother, who was reported to have
not able to hear for just for like a couple minutes there.
Okay.
Got it back? Can you hear us online?
Okay. So to catch anyone up online who was not here live with us, this is a case of a patient who had a V-fib arrest and then clinical symptoms of short QT syndrome. The family history was not very informative, and we ordered a large cardiomyopathy arrhythmia gene panel. So now we'll get to the fun part. Okay, so the RYR2 variant that ends up being benign, not a concern. A Titan variant, heterozygous, missense in the M band, also not a concern. And then she has this KCNQ1 missense variant. I've included a screenshot of the Clingen database to show that KCNQ1 does have strong association with short QT syndrome. So when we get the report back, we see this and we say, super interesting, we have a KCNQ1 variant. What other information do we have? So walking through the variant-specific information, this replaces a phenylalanine with a cysteine at a highly conserved residue across species. The variant is not in population databases, so this shows that it is novel and rare. This variant was actually in the literature, and experimental studies showed a gain-of-function effect in the gene. Another variant at this position was seen in association with short QT syndrome with functional data as well. And algorithms suggest it may create or strengthen a splice site, but that has not been confirmed. You might be looking at this data like we were and say, wow, this seems really suspicious. That's kind of shocking. It's uncertain. So let's look more at the criteria to figure out why the lab is not comfortable calling this likely pathogenic, and what are we going to do clinically to help clarify. So our first thing to do is look back at the ACMG guidelines and figure out what codes they're applying. This is something you can ask your labs, and they will tell you what codes they're applying to a test result. So we know for sure that they are applying this pathogenic moderate points for PM2, absent in population databases. We also know that this is a novel missense change at a residue where a different pathogenic variant has been reported. We do have some information about computational data. We don't know if they're applying that. And we do not know at all, the bubbles here that are green, is does this segregate with family members or is it de novo in our patient? Currently, we definitively have one moderate point, maybe two moderate points, maybe two moderate and a supporting, but none of those combinations would get us towards likely pathogenic. You might also be looking at this wondering, well, what about PS3, the well-established functional data? So the codes the way the lab reviewed the two functional studies, which were from different author groups, did not meet their cutoff for PS3. So that was not applied at this time. So at this time, they said, this is truly uncertain. What next steps can we take? And as a clinician, the next best thing we can do is to look at the family history and determine, can we get additional points towards pathogenicity by testing family? So circling back to our pedigree, we have our patient here in the middle. I've included the positive plus sign just to help us follow through, but this is still an uncertain variant. And we want to test her parents to see, do they have this variant or is this de novo? When we test the parents, the dad tests negative. And this is how the case stood for about 3 years because we did not have access to testing or talking with the mother. So for a while, we only had this uncertain result. The dad was negative, and our team proceeded with recommending clinical screening for family in the area to see, does anyone else have a short QT? We don't want to miss something by overcalling this variant too quickly, especially if we might end up with access to the mom at some point. You'll see that the maternal uncle was present from the start, and him and his children had normal ECGs. So we were pretty reassuring for them and gave them a longer follow-up window. Eventually, we do get access to the mom, and she does also have this uncertain variant. So at this time, say we don't have any additional cardiac workup for the mom, all we know is she also has this KCNQ1 uncertain variant. That doesn't really help us resolve this variant because we don't know, could she have short QT? Was it not seen on previous ECGs when she was a kid? Did she not have symptoms then? We really don't know. Luckily, our EP team was willing to do an EKG on the mom, and she also had clinical suspicion for a diagnosis of short QT syndrome with a QTc of 327. So at this time, we are really suspicious that this is truly the answer. We feel more confident now that we have some segregation info, but still just having segregation in two family members, this was technically uncertain in the family. We worked very hard and finally can test mom's parents, and they end up being negative. So this is a de novo variant in the mother, as well as then her daughter inherited it. It's notable because you could maybe be a little tricked by the AFib, right? We're like, oh, maybe the maternal grandmother also has it, but she doesn't. And that's why it was important to still, if we can, get her tested to confirm. We now have ample evidence to say that this is a likely pathogenic variant. We have a diagnosis of short QT syndrome, they meet guidelines, and we can be reassuring for the paternal half-sister, the father's side, and the maternal uncle and his children. So no one else needs further clinical follow-up. You might also be noticing and remembering, oh, the proband's mother is also pregnant. So this is very helpful information for her during a pregnancy to help coordinate accurate follow-up throughout the pregnancy, delivery planning, and test that child at birth. So if we're looking back at our ACMG criteria, we already had absent in population databases, and now we also have de novo in a patient. So this is referring to the mom. So just those 2 points are enough to consider this likely pathogenic. I like to bring that point up because say we didn't have any of the case data for this variant where we actually had stronger suspicion, even without that, if I had presented the case, we still could have done family testing and ended up upgrading this to likely pathogenic. But we also do have additional criteria we can apply. So we are confident this is a pathogenic variant and it meets the criteria in multiple different ways. So the main reason for showing this case is just to highlight, yes, family testing. I think a lot of us in this room are already thinking about that, but also it's important to know have family had clinical evaluations. That has also been touched on extensively today, thankfully, which really goes hand in hand because if we had tested the mom but could never get an EKG on her or never have further workup, we probably still would have been in this gray zone. Maybe we would have become comfortable calling it likely pathogenic. Maybe it would have taken us a few years. I don't know, that's not what happened. We were able to clearly upgrade this. But when testing family, it's important to think about how many family members are there? Will they be willing to have a clinical evaluation? Are you willing to interpret the results of their evaluation? Do you have a great EP team who will work with you? And what will that testing mean for us and the patient? And that is my case review. Thank you.
Great. Thank you very much. So the next speaker is Lisa Castillo, and it's how variant-specific data changed my management.
I know that's why I'm like. Oh, yeah, there. Yep. Lovely. Thank you. Oh. All right, thanks. Hi, everybody. Thank you for the opportunity to speak. So I have the topic of don't throw the VUS out with the bathwater, how variant, how variant-specific data changed my management. So how do I? Oh, I see. Okay, fine. Okay. So we talked a lot about long QT, and I'm going to just do some genetic overview. You guys have seen this in the last few slides. So I'm not going to focus so much on channelopathies and the genes associated with that. You guys have that, I think, under control. These are just a couple quick genes that go along with arrhythmias and that also go with cardiomyopathy that you guys might be a little bit less versed in. For instance, lamin is one of kind of the oldest genes for cardiomyopathy that we know of that goes with dilated cardiomyopathy, AFib, conduction defects. SCN5A you know of as a long QT gene, but it also can go with dilated cardiomyopathy and ventricular arrhythmias. Lindsay is kind of a new player that can go with cardiomyopathies as well as ventricular arrhythmias. And DSP2 has been a long gene associated with ARVC, but more recently has been associated with left ventricular decline in function. And so I just kind of wanted to orient us a little bit on it's not only the long QT genes that can cause sudden death, but it's also those genes that can go with cardiomyopathies that can cause sudden cardiac arrest as well. So, you know, I know there's lots of opinions in terms of how to do genetic testing, what to do, what type of panels to use. You know, for many, many years, I would go based on the patient's clinical diagnosis. So if they had a cardiomyopathy, I would pick a cardiomyopathy panel. I would always pick the biggest cardiomyopathy panel, not just the DCM or HCM, but pick the biggest one. But that's because I've been doing cardiac genetics for almost 20 years, and I'm totally comfortable with variants of uncertain significance. Or if they had a long QT, I would pick an arrhythmia panel. But we can also do the combined, kind of like what was just talked about in doing a larger type of panel. And so I was kind of picking just those specific cardiomyopathy arrhythmia panels until I was asked to take part in an in vitro study with their sponsor testing program that they had over 4,700 patients that they did a large panel on. And once I saw the data, I was like, oh, I should probably go a little bit bigger, because we were finding that of those people, if you were to go broad, you were picking up about almost 11% more positives than if you were to go very narrow and doing disease focused. And so that data kind of changed my mind and going even bigger. And we're going to talk a little bit about some of those implications. Now, of course, when you go big, you also get those variants of uncertain significance. I completely realize that. And in this study, we found about 50% of people had variants of uncertain significance. And it was typically even in people who had a cardiomyopathy indication and an arrhythmia indication, that about 50% of the time you got a bus. The one thing I do want to highlight from this case study, because I know the population I'm talking to in terms of postmortem cases, so they had we had 190 decedents who were also in this, and by doing this broad panel, they ended up getting a positive in about 9.5% of the cases, which is pretty much where we were laying when you had given your talk, Dr. Bear had given his talk in terms of around that 10% point. And, you know, again, a lot of these patients, almost 50%, we didn't have a diagnosis in. This was self-report by whoever was ordering the test. So we don't know if they had an autopsy, if they had negative autopsy, like that data we didn't have that data to analyze. But in any event, like still around that 10%. And so the good thing is that of those 10% that were found to be positive, then they were able to do Cascade testing. And so, you know, there were 18 family members, again, who went through that, got a positive result, who now you can actually screen and alter medical management based on that positive. So, you know, this is a VUS talk, and so I recognize that VUS is certainly cause anxiety and uncertainty. What I kind of want to throw out as a consideration that with appropriate discussion about that VUS, I think that a lot of, you know, I've seen a lot of patients who are very comfortable with it if you actually put it the right way, right? So you're still going to end up following them based on the recommended guidelines out there for their disease, whatever that is. And it's not that we're necessarily going to change their management based on the VUS, it's that it's an additional finding that we have information and we're not necessarily going to do, like, change your management based on that, but let's see what we may be able to learn from it. Same thing with family members. You know, we're still going to screen family members appropriately and make sure that we're following the guidelines to screen, irrespective of what that VUS is. So I want to show two quick cases. One of them is a 37-year-old who presented to the ER with syncope at 34. He had had 3 months of syncope, like weekly, and then it started to get to be a couple times a week, and he finally decided, gee, maybe I should go get this checked out. Had an LVEF of 30 to 35%, and cardiac MRI showed, you know, a clear transmural pattern, but and non-ischemic LGE. He also ended up having an angiogram that he did have significant CAD on. Got 2 stents to the RCA, LAD, but after that point, he continued to have quite a bit of VT to the point where he needed a sub-Q ICD that was placed a year later. And then since then, he made many lifestyle changes, diet, moved to Chicago, ended up coming to see us, which is how we got involved in the case. So this is his family history, because of course, he came to see me, so I take a full family history. And interestingly enough, he's telling me about his dad. Well, you can't see the little pointer. I'm like scrolling on the pointer, you can't see that. Anyway, his dad died at 42 suddenly. He did have a history of dilated cardiomyopathy. He had arrhythmias that his mom couldn't totally remember what they were, but he had a defibrillator. And then he's got a paternal aunt who had heart failure diagnosed in her 50s, has an ICD, and then importantly also his paternal grandfather died suddenly at 65 of, we don't really know of what. So, when he came to see us, you know, we were talking about genetics, and he was like, yeah, nobody really offered it. Everyone was like, this is the CAD, and like, that's just what it was. And we were kind of taking a different route because we're like, well, yes, I agree, you had a bunch of CAD, but you also have had recurrent VT along with LG on MRI, and let's consider doing genetics. So, of course, I ordered the big cardiomyopathy arrhythmia panel and ended up coming back with a Lammin pathogenic. So this isn't a bust, but for people who don't know what Lammin is, I kind of just figured it can also cause sudden death, which is why I wanted to highlight it here. So laminopathies can certainly cause dilated cardiomyopathy with conduction system defects, AFib, and VT. It can also cause a couple different forms of muscular dystrophy, Emery-Dreifuss limb girdle. It causes lipodystrophy. It can cause Hutchinson-Gilford progeria, early aging syndrome. Lammin can do a whole lot, which makes it fun but really confusing. And, you know, the alterations are really or the variants are distributed throughout the gene. Really the only one that is consistently seen as the Hutchinson-Gilford progeria. That's the one mutation. Otherwise, it's pretty much scattered throughout the Lammin protein, or the Lammin gene. But why I want to highlight it here is that we know that people who have pathogenic Lammin variants certainly have an increased risk for malignant ventricular arrhythmias, and typically it can be when an LVEF is normal or just below normal. And so therefore, Lammin got put in the guidelines, as you guys have already kind of seen how these guidelines work, but it is in there saying that people who have 2 or more risk factors, including NSVT, LVEF, less than 45%, which is different from what you would normally do for an ICD guideline, a non-missense mutation, and males, that they should actually be considered for an ICD earlier than other people would be. So this guy already had a defibrillator because he had a whole bunch of VT. But yes, in between the time that I gave him the Lammin diagnosis and we saw him back, he had an actual appropriate shock. I hope it wasn't from me giving him Lammin. I don't think so. And then, you know, we were looking back in his chart, and his LVEF had been 49%, at least shortly prior to the shock. So good thing he had this defibrillator. That was helpful. We have been in the process of doing Cascade testing in the family. You know, I offered I'm like, let's just test your mom. I know it's coming from your dad, but let's just obviously make sure. Obviously, mom was negative. She's fine. Coming from dad, which is absolutely what we had anticipated. And then the rest of the family can get testing. So quick second case. This is a lady who had a personal history of DCM, left bundle branch block, NSVT, diagnosed in her 50s. She has a sister who was diagnosed at 47 with DCM, an LVEF of 8%, and their mom had a heart transplant in her early 60s. So again, I think it's something going on that's familial. We did the genetic testing in her, again with the big panel, and had a Flynn-C variant of uncertain significance. Kara did a great job with this. I'm not going to go into ACMG classification. Awesome. And she also did a great job laying out how we analyze these variants. So I'm not going to go into that as much, which is great. But we looked through the same stuff that Kara looked through. What do we think about this variant? These are some of the different sites that we use to analyze variants. And we kind of had the same thought that Kara's group has, right? Like, you've got a patient with a gene that causes the same phenotype that our patient has, dilated cardiomyopathy. There were a couple publications out there, not enough to bump that up to a pathogenic classification, but we're like, yeah, we're kind of sort of suspicious about this. We ended up testing her sister, and she also had the Flynn-C variant. Again, can't really change medical management because it's only a variant of uncertain significance at this point, but it was something where I'm like, I want the sister to know if she has it, because that is one more line of evidence in the future if we have enough to bump it up. as we were kind of going through all of this, this paper came out with that variant in there saying, yes, it causes disease. So as soon as this paper hit, it got upgraded to be pathogenic. Lindsay also is in the guidelines, similar to Lamb, that says if you have a pathogenic, you should get an ICD, or you should get recommended to have an ICD if an LVEF is less than 45%. So this can significantly change our patient's medical management because she didn't have an ICD. So it's something that we absolutely recommended, and we now have other family members that we can go ahead and test to see who else is at risk. At the same time, we were doing work in our lab, looking at cell lines and the fluency pathogenicity of this variant, which, you know, kind of came out a little bit after the other publication went out. But one more little topping on the cake that, yes, this is pathogenic. So VUSs can matter with appropriate thinking about it, considering it, talking to genetics experts if you yourself are not a genetic expert, you know, obviously still medically managing people based on their diagnosis, but something that kind of keeps rolling in the back of our minds on what to do with buses. And then lastly, I just want to do one quick plug for people who haven't heard. Myself, as well as Greg Webster, who you guys have all met, and our partners, other partners here within Northwestern and Jackson Labs, created 3 educational modules through our American Heart Association SFRN grant that are free online for cardiogenetics, teaching about how to identify red flags for inherited disease, interpreting positive results, and interpreting negative and bus results. I have flyers out at the desk. We're really trying to target people who don't know genetics, like all of us know the stuff in here. This is basic stuff for people who know genetics, but it's really for those cardiologists, cardiology providers, who we want them to think, who should we test? What should we do about genetics? Who's really appropriate? And that's really where we're trying to get the word out. So take as many flyers as you want. Big plug for let's get more genetic testing going and try and help more people. That's all.
That was great, thank you. And our last speaker is Melanie Kerr. Melanie is going to speak to us about policy, how Clingen gene-specific classifications changed my management.
Wonderful, and is just move it forward? Yeah. Okay, perfect. Hi, everyone, thanks. I'm so happy to be here today speaking about perhaps a little less about how Clingen, yes, it changes my management, but how it impacts case management. The work that Clingen is doing in terms of some of the gene disease curation efforts impacts how we work with our patients and interpret results for them. That's not working. Oh, there we go. Okay. Yep, okay, perfect. So we all, it's not moving for me on here, which is not awesome, but, you know, I can work with it, it's okay. Okay, we're gonna have to work with me on this here, because I can't see the slides moving over here. Okay. So we all know that we have a lot of difficulty with variants of uncertain significance, right? They are difficult for us as clinicians in terms of what the clinical relevance is and how we do communicate that information to our patients. But I think we also need to be thoughtful about what it means to have, for a patient to see something in black and white, a finding on a genetic test result that says uncertain. And as clear as I think we can be in our communication, that's really important, as Lisa highlighted. We also have to recognize that it's there in front of them. And these people are often, in these circumstances, really desperately seeking answers for what's happening with themselves and their families. And so not to discount that as well. We all have toolboxes, right, when we're looking at variants of uncertain significance. They include, oh, I'm going back the wrong way, guys. First. Okay, there we go. I got it. Okay, yes. Okay, no. It's honestly, this is bizarre. Yeah, can I don't know what's happening. I'm pushing the same one every time, so I don't know what's happening. Is it in the right mode here? Like, can we put it on slide mode?
Do that. Lost our cursor. It's going from bad to worse.
This is the entertainment of the morning, guys. It's all good. This is all just to make us all feel better. It can happen to anybody.
It is moving up the screen, okay, well.
Yeah.
Oh, that's
see yours, but the problem is when I'm pushing the button, it seems that.
Oh, that's even weirder. So now we have your slides here and Lisa's up there. Lisa, do you mind coming back up to give your talk again?
I do have technical challenges sometimes, but I swear, this one's on.
No, you're clean on this one. Yeah, Susan, could you come up here and? Yeah, he's coming.
But he won't be able to,
Hang on, we're.
Talk amongst yourselves. Talk amongst yourselves for a few minutes while we sort out the AV issues.
Yeah. So I'm just gonna close this.
We're good. We're good. We're good. It's coming.
Okay, so now what I've done is I just changed it so you can just use the arrow key.
Now it's perfect.
And you
Oh,
should,
wonderful.
so,
Okay, and now it's advancing.
the
So
mouse is doing
perfect.
something strange.
I'm not going to use the, no, I'm not going near it. Okay, so like I was saying, we all have tools, right? We have a toolbox that we use when we're evaluating variants of uncertain significance. And yes, it includes things like the detailed phenotyping that we do. It includes our clinical experience in evaluating this in the context of family history. But what we really need to do, and our starting point, is always going to be the evidence. And we've spent some time, some really nice presentations preceding this, talking about variant level evidence. However, it's really important that in order to start looking at that variant level evidence, we have to take a step back and ask a broader question. The first question we have to ask is the variant that we've identified in this genetic test in a gene that actually has evidence associating it with disease? What is that gene level evidence? And so we're going to talk about that today a little bit in the context of a story. And for the cardiology purists in the room, there are scant clinical details here, so stand down. That's not the point of the exercise. You'll also notice that there's a typo in the age of the proband. But again, for the broad story, it's not important. What we have here is a scenario I think that any one of us could encounter in our clinical practices on a daily or weekly basis. We have a patient who presents with a new diagnosis of non-ischemic cardiomyopathy. And when we start to evaluate the family history, we see something that begins to emerge as a potentially hereditary condition. And so I think it's fair to say in this room, most people would offer this individual genetic testing. As Lisa alluded to, what that genetic testing looks like is going to be very different depending on whose office they walk into. Is it going to be a very targeted panel? Is it going to be a very broad panel of genes? But I think we can safely say that there will be a large number of genes of some variety under some umbrella that's tested. So this is just an example here of a common, up-to-date, large cardiomyopathy panel offered by a clinical testing laboratory. And what I see here, certainly if you scan this gene list, you're going to see a bunch of heavy hitters. You're going to see a lot of our usual suspects that we know, we understand them, we recognize them, MYH7, lamin A, DSP to a point. But what you're also going to see are a number of genes that really are quite obscure, right? They're genes, if you look closely, maybe you've seen them once or twice, maybe you've never seen them. I can't say that I'm familiar with every single one. Okay, we're going to go again. All right. That's okay. This one's going to be okay. Okay, perfect. Yep. Okay. No, it's okay. I'm just going to leave it as is. We're good. And the other thing is that the more genes that we sequence, the more likely we are to get lists on test reports of variants identified as uncertain significance. And when you oh, it's gone again. I'm I'm not, if I need to be in presenter mode, I'll be, but it's not advancing. It's just not advancing. Anyway. Okay. Nobody's had the AV trouble, I have to say. Anyway, the more genes that we test, the more genes we test, the more likely we are to see these rare variants. And they aren't necessarily going to be in those heavy hitter usual suspect genes that we're used to, right? And so it's not uncommon for us to get a result where we can see 3 or 4 genes that, or variants in genes that none of them can obviously account for the phenotype that we see in our family. And so when this is back up and running, what we're going to see is a potentially,
This is which slide?
yeah. Yep. Okay, so we'll see variants in genes that we aren't comfortable with. And so the very first question we have to ask is whether or not these genes are relevant in the context of the phenotype that we are seeing in our patient and their family, right? And for us in our clinical space, there we go. Okay, so here's an example of a variety of variants that we might identify on a genetic test result. And the first thing that we have to do, and that I have to do, is ask that very basic question: is this gene causative of a disease phenotype, whether that be the phenotype of the patient in front of me, or is it a disease-causing gene at all? This is a labor-intensive process, right? For me to do that, I have to scour the literature. I have to look and see what kind of patients that these variants, not these variants, but any variants in these genes have been identified. So it's labor-intensive, and with the volume of patients that we see, arguably untenable on a case-by-case basis. So we're fortunate.
Or not fortunate.
Okay, so there we go. Is the gene relevant? What is the clinical relevance of the gene? Never mind the variant. What's the clinical relevance of the gene? Fortunately, Clingen's been doing some of this work for us. And back in 2017, Clingen published a framework. And the purpose of that framework was to allow us to assess the evidence necessary to determine whether a specific gene causes a particular disease. So pay attention to that, whether a specific gene causes a particular disease. These are disease-specific gene curations, and we have to keep that in mind when we're looking at the information from that's published by Clingen. And what it's done is develop standards for us for these gene curations to allow us to define the types and the amounts of evidence required to support those associations. Now, I want to speak to this just very briefly in terms of what that framework actually looks like. And let me be very clear, this is a distilled down version of this. These are complicated guidelines. There are complicated SOPs that are put in place, still very difficult for you and I to do on a one-on-one, like on a case-by-case level. But the groups that are doing this, which are subject matter experts, can apply various levels of evidence. And so at a very basic sort of level, what we're talking about here are 2 types of evidence. Genetic evidence, which has to do with in well-documented patients with well-documented phenotypes, what variants have been reported, what are the types of the variants, are they de novo or inherited, they show segregation, and that level of evidence is weighted more heavily than the experimental evidence, but that is also important to our biochemical studies, functional studies, animal models. And then from there, there's a point system, and they're applied into the rubric to provide a number of points per piece of evidence to come up with a numeric value, ranging from sort of definitive or strong level evidence all the way down to limited or disputed. So a number of these have been done in the cardiovascular space, in the channelopathies, Brugada syndrome, long QT, short QT, as well as the cardiomyopathies. And I'm going to focus on the publication in 2021, which was the Clingen group looking at dilated cardiomyopathy gene curation, because I think it tells a story that is fairly consistent across these disease phenotypes. And when you look at, in this case, 44 genes that are commonly found on cardiomyopathy panels, less than a third of them actually have strong or definitive evidence for disease association. About half of them, about half, are in that limited or disputed evidence space. And the question that I think we really need to start asking is, what value are we doing by putting these genes on commercial test panels? Are we being helpful by providing variants of uncertain significance in genes that actually themselves do not have strong evidence for disease? Or are we hurting the process in a general way? I mean, I think that these are questions that can't necessarily, we have to answer them for ourselves clinically. It also has to be brought to the attention of potentially commercial genetic testing labs, right? They're the ones that are making these panels. So again, we have these 12 genes. I wanted to just speak, oh my God. Anyway, I want to speak very, very briefly about the moderate level genes, because moderate level genes are not all created equally. What you'll see is a range of evidence that puts something into that moderate level category. And so those genes for which reach moderate level because of genetic evidence, I think have to be looked at a little bit differently than genes that only get there because of functional or biochemical studies. Those are two different types of things. And this all has to be looked at under a critical eye every single time through the lens of evaluating the patient that's sitting in front of you, right? And you have to come back to that. This is not a perfect system. There are no perfect systems, but it does give us a baseline from which to work. And I think that's important. So let's, look at one of these genes that came back on this particular result. And just by show of hands, so this is a searchable database that Clingen has put together that is actually very helpful. And it's something that I use on a daily basis, in fact. But just by a show of hands, how many people not know Clingen? I think lots of people, and everybody knows Clingen, but this particular service of searching a gene to look for disease gene validity. How many people are familiar with this or use it regularly? Okay, so it's a few, but it's not half the room, I wouldn't say. So I would say put this into your regular rotation, because it's really, really helpful, especially when you get a result in a gene that is not one of our heavy hitters or usual suspects, right? Those are a different story. A couple of things you want to think about or look for. This particular gene has been curated in a number of clinical phenotypes. Ours, for this purpose, is a cardiomyopathy phenotype, and as you can see, there's limited evidence. It doesn't mean the gene itself has no value or no clinical implication. In fact, when they looked at it in terms of a skeletal myopathy, there's definitive level evidence. So this might be something that you want to keep in the back of your mind also when you're seeing a patient follow-up. Do I need to ask about some of these other features? But in the absence of those, what is the value of following up on this kind of result in a family like this? These are questions we have to ask ourselves. No one's going to have the same answer, I don't think. So looking back at our results, no, not all of the USs are created equal. With these three genes that were identified in this particular test, two of them by the dilated cardiomyopathy gene curation fall into limited evidence category. We can never say never. Evidence changes. It evolves over time. We always have to keep that in mind. But for now, there's not great evidence that these genes are associated with disease. This one, however, shows a moderate level of evidence. Moderate is not definitive. Moderate is not even strong. It doesn't mean that it's the answer, but what it does is it sets us a baseline of something that we can use for our follow-up in terms of targeting what findings perhaps we can look towards to try and get more answers for our families. Ultimately, again, in my experience, these are families and people that want answers to understand what's happening to them. And this allows us to use an evidence-based approach to target further genetic evaluation follow-up. It also helps us to communicate to patients the rationale for why perhaps we're not focusing on a list of 15 variants. This is the one we're targeting. This is why. This is a group of experts that has come together to give us the background and the baseline to say these are the more likely to be the potential contributors in this particular scenario. So, in summary, I think that Clingen has provided us a framework and a strategy for the objective evaluation of evidence about gene disease associations. It doesn't take away the necessity of looking at all of this information critically through a case-by-case lens and all the things that we do every day, but it gives us a really nice baseline, and it is one useful tool in our toolbox in the evaluation of these variants of uncertain significance, which again, depending on what test you're doing, you could be getting long lists of variants of uncertain significance. And as effectively as we are able to communicate, and I think we do often do a decent job, we have patients with lists of black and white findings on test results, and they often, no matter what we say, will sort of cling to that as possibility and risk. And so these efforts by Clingen can be helpful tools also when communicating with patients about which variants might be more important and more impactful than others. So I'll stop there, and happy to have discussion about this because I think that there are there's lots of opinions in the room about all the types of testing that are done and how we evaluate those variants. But I think, again, how people use this also varies from person to person. Thank you very much for your time. Sorry for all the AV issues.
Would all the speakers come up to the table?
Better forget the microphone just for the online. Might as well go shot and we'll. There you go. We got a mic.
Is this thing on? There we go. So it's a practical question about variant curation by the clinical team and how you manage the frequency, how the severity of the phenotype, and how AI is going to inform curating those variants over time. Do you say, I want to see this again in 3 years? It's a good, so for instance, we use it as a reminder to basically formally curate the variant and revisit whether there's new data, because in the interim, we don't watch. And as you know, the commercial companies have variable responsibility for that. So I just thought that was an important topic, and I also wonder how AI is going to evolve that.
Good luck.
I think that, I mean, there's no question AI is an important tool in this space, right? Because it is an ongoing regular curation of the literature. I probably a bit of a traditionalist in the sense that I think that AI is, again, going to be a tool. It's one tool to help. I think it's really important as we move forward in this field that we continue to put human eyes and a clinical cognitive, put it through that lens of our clinical experience, because I don't think wrong, and you know, I'm too old to look at AI as sort of the be all and end all, but I do think that as a baseline it's good, and then we should continue to put that through our clinical lenses.
I agree. I think it's also important to distinguish if AI will be useful for just notifying us to recurate a variant versus part of variant curation, which is actively happening at commercial labs, versus like, do we employ it in any way in our curations? Like, there's multiple levels, because part of curating these uncertain variants too is just the manpower, the timing, and who's notifying you. And I think my view is almost like the biggest limiting step right now is being notified to review these variants. Is that the family's responsibility, the labs, kind of where do we fall? And AI definitely is a tool we should use. I think how it's employed will be important.
Yeah, I mean, I agree. And I think even every clinic has different ways of how they reinterpret variants. You know, I mean, for us, if we tell the patients every 3 to 5 years, come find us again, and we'll reanalyze your variant, we'll retest you, we'll figure out if retesting is appropriate, whatever. I mean, I think it would be interesting, I don't know how on earth it would work, but if you somehow use AI within like a healthcare system to curate the variants that are in Epic or something, to say like, is there a way to integrate AI that way and have something on the back line reanalyzing as you're going, and have it alert the provider who ordered the testing to, hey, maybe reconsider this variant at this point in time? Wouldn't that be totally cool? I don't know how that would work, but I agree that eyes have to always be on it. Human eyes have to be on it, because we've even gotten some reports back from a clinical lab calling something pathogenic that we then look at and we're like, how'd they get to that? Like, I'm not seeing how that's pathogenic, and that doesn't actually go with what my patient has to begin with. So I feel like there's always that clinical correlation, phenotype correlation. Does it match? What do we do with it? And so, yeah, I don't think we'll be put out of jobs anytime soon with all of that, because humans still have to look at it. That's a great question, though.
Hi, everyone. Hi, I'm Cindy James. I'm a genetic counselor and researcher from Johns Hopkins. And thank you so much for those really nice talks on the challenges of variant curation, particularly in the context of families. And so my conversation, or the question I wanted to have with you, the conversation I wanted to have with you
is the utility not only of Clingen's gene curation expert panels, which Melanie, you nicely described, but their other major mission are the VSEPs, the variant curation expert panels, which are also made more complex by the fact that the ACMG is revising the Richards guideline for variant classification. So you guys have all been doing this a long time. I'm really curious to hear what you think regarding the utility of the VSEPs, of that effort, the strengths and the weaknesses. Just what's your opinion? Hello. So I am on the KCNQ1 VSEP, so this is a timely question, exciting. I think there's definitely room for discussion around like the timeline of setting these up right and also sustainability. So my perspective has been, I'd say it took us maybe 2 years to submit pilot variants, and then we've been waiting for at least 8 months to get feedback. And that's not to say anything like, that's just, I'm sharing the fact about that. And then once we get those pilot variants back, we have to review them, make revisions, submit again before we can start sustained curation. So I think there's definitely an importance to it, and it could be helpful. I think it's complicated by the changing 2015 guidelines, and I think my uncertainty is about the sustainability, like how will this work long term, especially since also like the clinical labs have access to different proprietary tools that Clingen doesn't have access to, that they weigh differently in how they're applying them to.
Little bit to this, because one of the challenges I think with genetic testing and genetic test interpretation is that a lot of the commercial labs, they're ordering cardiac tests, but this is just one area that they are working in. And so I can promise you that they are not all experts in our genes, right? So a lab scientist who is reviewing a genetic test result of an MYH7 variant, they might be looking at MYH7 together with a whole lot of neurodevelopmental genes together with kidney disease genes, and they're just doing checklists. What I find really important about the variant curation expert panels has to do with the fact that those teams are looking at ACMG guideline classifications in the context of a gene that they are an expert in. So I can trust that, right? I can say, okay, you know what? I do use ACMG guidelines. Obviously, again, there's nuance to that. But if I can look at an MYH7 variant through the lens of an MYH7 VSEP, not necessarily what they've put in Clingen, although yes, I do feel very confident in that also, or ClinVar, I do feel confident in that also, but looking at the changes they've made to those variant guidelines allows me to know that those are people that have thought about this critically in the context of the disease that I am seeing, and that is very important to me. So that's what I see.
Incredible session. I've loved it, and it brought to one thing that was really refreshing to see among the genetic counselors was you did VUS testing of first-degree relatives, because that's been taking forever. It's been entrenched out there among the genetic counselor community of thou shalt not test relatives for a VUS because it's called a VUS. And I have felt that's been a colossal mistake. It's one of the most important things we can do in the detective work. But I do think that we're still, the 2015 rubric, those are not Mount Sinai tablets. And we have put too much emphasis on those. That was the one-size-fits-all exercise, whether it's cancer, whether it's colon, whether it's neuro, whether it's whatever lesion, and it pays lip service to the power of the phenotype. At the bottom row, right in the center. And an example is your case, which was awesome, that you presented on short QT. That did not need the testing of the dad, and then 2 years later, the mother, and then another year later of the grandparents to establish it as de novo. That could have been upgraded like that day to the disease-causative variant and have skipped from VUS to pathogenic. And I think we need to remind ourselves the genetic test companies do their best, but that's just their label. We're the ones responsible. So I don't need to wait for an amended report before I guide the family that, yes, the company called it a VUS, but we are taking it as the disease-causative variant, which in that case, that could have been done instantaneously. And so so we have to, just like GE Marquette on the ECG machine, they do their best. They give us a label across the top. How often do we look at that and say, that's not borderline? That's a slam dunk QT prolongation. And so I think we stay paralyzed on a lot of VUSs way too long and feel like, well, we can't move it until the company moves it. No, we can move it that day. Well, I mean, in that case, it was the power. The phenotype gets no point. And in this case, the patient had short QT. The mutation was a gain of function variant, never seen in NOMAD. Well, the problem, yeah, well, it's gonna take time.
Publish it, and then that
Four
helps
years
to
later.
But see, that's like you said then, the 8 months to curate this, the time lag, and in a way, the time lag doesn't matter because all that matters is our family. It's for the family with that VUS where you're saying.
About the other families in town.
It eventually will get there, but it won't get there until the companies want that feedback loop and know how to incorporate that feedback loop. Because if we stop calling them up. We used to say, I know you called it a VUS. This is a slam dunk LQT2 mutation, short QT1 mutation. Take it to the bank. They say, yeah, thank you. Because they also don't know. They don't know that your phenotypic strength was able to be the thing that moved it over the level, and not all phenotypers are the same. And so a company, they're constrained, but we're not. I mean, and we have to communicate that to the families because they can come back and say, yes, but it says a VUS. What do you mean? We have to work a lot harder on this.
Other interplay that, like, other states.
Yeah. So the
lag time top.
The short QT case specifically is published, so you can look it up. But we did, it was honestly a hard time finding an uncertain case because we are pretty aggressive with our calls if we're confident. So for that family, we had done a one-time screening on relatives until we got mom, and then we had released them. So over those 2 years, we hadn't done anything else. So it is a really important point to have clinicians on your team who are comfortable making that call. It could definitely be a genetic counselor. It could be the genetic cardiologist. It could be someone else. But it is really important that ACMG isn't the end-all be-all with the cure.
Because I think it's really important. What you say, Dr. Ackerman, I agree with entirely. We do a lot of that in our center as well. But I also want to put out a word of caution that those are the kind of designations that should be made by experts who understand the phenotype. The people in this room, absolutely, but we've got to be very careful about putting that message out to the general genetics community, to the general cardiology community, actually. We know that phenotyping isn't done well. Never mind phenotyping, we know that the interpretation of genetic findings isn't done well. We've told them for years about the risk associated with misattribution. And that is the risk we run when we start that. So I also don't go personally by an ACMG classification that comes out from a lab. They don't have that patient in front of us. Expert cardiologists that I work with, together with years of, that's when that messaging can start to change. But we do need to be cautious about putting that out to the whole world, I think. That's my bias.
We're at time, but we'll take there's two last questions in the room, and 2 questions, then brief answers.
And mine will be real quick because it's a continuation of what we were talking is, what are your comments or suggestions for a lot of people thinking that exomes and genomes are going to, be the, the one test, know-it-all kind of situation? Because again, classification with exomes and genomes are going to be different from panels. And so when you do exomes and genomes and you see a specific phenotype, your thoughts on repeating a panel-based testing specifically for that indication versus just depending on the exome or genome interpretation of those variants.
Back to the clinical phenotype. If it's a really strong phenotype and you haven't found anything, repeat it in a targeted way. I think that's what you have.
I think it's also really important to understand the lab you're ordering from's protocol. A lot of variability in lab pipelines, and you never hesitate to go back to a lab and say, these are my top genes. What was the coverage? Because I had a case coverage was very poor. Well, guess we should have done a panel because we would have found it a lot sooner.
Yeah.
So there definitely needs to be that balance of caution, but also there is a lot of benefit to moving towards it. I've also had Titan variants that came up, and it's definitely a balance. How it works at the lab you're ordering is really.
Well, it's more sort of a comment. So I think the way to do it is to actually have the lab in your multidisciplinary meeting with you, and that is again a virtue of a national genomic service. is that the multidisciplinary meetings has laboratory scientists who are adjudicating your variants in the meeting, and they have specific meetings to go over that. Having said that, I still have lots of fights, because I'm the one who says that's a bifid T wave with pause dependence or side the plant. That's not a KCNH2 BUS. That's already likely pathogenic because of the phenotype is that close. But and I do also have fights with my GCs about that, because they're very conservative compared to me. So I apologize for British GCs versus my.
Okay. I own my conservativeness too. I'm also conservative. I have fights with the cardiologists I work with too. It's okay. But I think that's the beauty of the discourse, right? But I do agree. I do agree with that.
Yeah. So yeah. Sorry, Mike.
Thanks, everybody.
Thank you all very much.
Thank you all for being here this morning. There is lunch outside. You can have the lunch there. There are a few armchairs and places to sit around the corner, or you're welcome to bring it back in here and eat in small groups here as well. We will reconvene for the afternoon sessions at about 1 o'clock in the afternoon. For those of you who are interested in sneaking a look at your computers, which I'm sure no one has done during the sessions, there is a Lurie Children's guest network. You do not need a password in order to sign on to it, and you're welcome to access that as well. I'll see you all at 1 o'clock. Thank you. Yeah, I'll talk to our AV guy and figure out who we recently hired.
If we find, I had the same problem he had on mine. We'll find it.
High floating meeting. There we go. Okay.
Yeah, that's easy to do.
I think it's like
Yeah.
I know I'm that guy.
This whole computer is not functioning particularly well, so PM. Okay. From Yeah, let's do this. I'm gonna flip through here. You flip through your slide just so that you're
so far
the
it's looking
clicker.
great.
I'm gonna finish checking with Dr. Stevenson, and then can I find you? I think we need to talk about how we keep the afternoon to kind of being a replay of the morning. But I'm sure we can. I'm in the middle of a conversation with her, but I think we gotta.
Let me just test a couple things really quick
That sounds great.
and see if I can make it, there's a simple fix to I think the big issue is that some of these PowerPoints that are open don't have presenter view selected.
Well, I think the thing that I would say to you is, I've
do
been
them one at-
watching
just do them
multiple
one at a time.
people now struggle to make it work, and we've now gotten to the point where we've interrupted multiple sessions and thrown people off, and we need a different strategy.
Okay.
I am not worried about the presenter view.
Okay, cool.
I think you are more worried about presenter view than anyone else in the room.
Okay.
So what's important to me is that the functioning starts functioning normally.
Okay.
What is not important to me is presenter view.
All right, well then, here's what I'm gonna do.
I will warn people, that's perfect. I love that idea. And then the other advantage is then we can just quickly turn off the sharing from there too.
Yep.
if we need to. That's great.
And, yeah, I would just say, the only issue there is that people, if they have notes, you know, they're not
I
gonna be able
know,
to see them.
but I'm not worried.
But if that's not the priority,
That is
then,
not the priority.
then don't worry about it,
Yeah, that's great.
Cool.
Perfect. Thank you.
Do you want me to open up the rest of the notes so they're all just preloaded for the rest of the day?
You know, I don't think so. I think each individual talk is relatively small, and I think it's easy enough for the person up here to just open up the talk.
Okay, yeah, I mean, all they really have to do is just, you know, they should be able to hit
Just
escape.
and
And
go to this,
Yeah, go to this,
and then just open up the PM. You can close the AM.
name one. Cool. Yeah, and then find theirs, open it up. Has everyone that wanted to check their presentation been able to check it?
I think so.
Okay, cool.
I think so.
All right.
And I'll touch base with presenters in the afternoon meeting, make sure they know how to do it. There's nobody. Thank you.
Yeah, of course.
Appreciate it.
I'll make sure I understood it before I moderate. So they'll be up here.
Mm-hmm. So, I have, right now we're in presenter mode,
Yeah.
but, sorry, this thing keeps popping back up. Wait, hold on. That escape. There. So I have everybody up and ready to go. So in order of last name and presentation. Start with 8, 9, 10. Wait till we finish.
Okay, so we'll just we just click on that, it'll come up.
Mm-hmm.
And then,
I'll get rid of this one when it's time to start. That's just a welcome slide.
okay.
Okay?
Thank you so much.
Of course. Other than
And then so when the next one comes up,
They can just, if they just go escape, one escape is going to bring this back on. Unfortunately, there's nothing we can do about that one. Then, so like if we're in presenter mode right now, I could hide this if I just go more and hide floating meeting controls.
yeah.
And then we're live in the presentation. But then when we escape, it brings that back up first, escape to get out of this.
And then it closes down and shoots.
And then, yep, you don't even have to close it, you could just pop the next one open.
Oh, wow.
Okay?
Thank you.
Of course. I think the most important thing is this one. Once you go escape, just hide floating meeting control to get rid of it.
And so every time a new one loads up, it'll have that.
Yeah, because the default function is push escape to bring it back up.
Oh.
And then escape again to get out of that. Okay?
I think this is for this, but just, if anybody asks, they're not gonna find it. I doubt it. I will monitor the staff, All right, if everybody can start to find their seats and find a way back. I hope everybody enjoyed lunch, and it looks like everybody got through the build your own taco line. So thank you for your patience for the people who were in the first part of the line. The second part of the day is as good as the first, and I'm really excited that we have another 3 sessions to go. I want to thank everybody for being here with us, and now I will turn it over to Jeff and Sarah. Thank you so much.
Hi, everyone. I'm Sarah Cherney, genetic counselor here at Lurie. Thanks so much for everybody joining us this weekend. Our next session is our phase 2 of awesome genetics details. It's called All About the Ohm, and we're going to start it off with Lisa Wilsbacher, who is one of our experts from Northwestern.
All right, good afternoon. Thank you. So thank you so much to all the organizers, to Greg for inviting me to speak at this amazing conference, to the SADS Foundation and Lurie Children's. I'm very honored to be part of such a great group of speakers. So for the idea of next gen, is it the final gen? Then what we'll do here is, I'm going to start by putting the orientation that I give for all of my patients in clinic, that the human genome is made up of 3 billion nucleotide pairs. Of those, about 3 million are different from one person to another. We estimate that about 20,000 of those variants are in exons, and we believe that up to about 300 could be in loss of function variants. Now, when we put this into context, this is going to look very familiar to everybody who was at Grand Rounds this morning. What we're looking at is the x-axis has the allele frequency, where out here these are the more common alleles. Y-axis has that magnitude of effect. And what I'll tell our patients is that in the cardiogenetics clinic, we are really looking at those very rare variants off to the left, where it's a single variant and a single gene that's having a large impact on the phenotype. Generally, these are monogenic or Mendelian conditions, and this is what we can test for now in the cardiogenetics clinic. Within that, then, I'll tell the patient, we're going to collect a sample. It'll be blood or saliva or a cheek swab. Then the DNA will be isolated. Then it will go through sequencing. Your sequence will then be compared to the reference genome, and further analysis can be made from there. But when we're talking about sequencing, and next-generation sequencing in particular, what exactly is that? Next-gen sequencing is also known as massively parallel sequencing, and it's a technique that has brought the cost of sequencing down so significantly that now, as you all know, genetic testing is something that we can offer in the clinic. It's very, very cost-effective. So it involves first library preparation, that the genome is fragmented, and then there are adapters that are put on each end of these smaller fragments of the genomic DNA. From there, those adapters are used to hybridize to a chip, and then it creates a kind of an island where that small fragment of DNA can be amplified, many, many copies of it made, and then we have islands throughout the chip of DNA that has the same sequence. The next phase then is the sequencing itself, where we're using nucleotides that have a fluorescent probe on them. And as we're building a copy, each new nucleotide is added, and then there's a picture that's taken with each nucleotide. So what you're looking at the bottom there is that data collection. It's the snapshot of the chip. And what the DNA nucleotide is coded based on the color. From there, then, the sequence is generated for a gene. It's aligned, and contigs are made to create your whole gene. Then all of these genes are then compared to the reference genome. So next-generation sequencing is what we use every day. I want to put it now into context of a clinical case. So this is a gentleman that I met a few years ago. He was diagnosed with dilated cardiomyopathy and met criteria for a defibrillator. The defibrillator saved his life. He presented 10 years later in VT storm, was in our CCU, and his overall the thought was, could this be cardiac sarcoidosis? And so the image to the right I'm showing you at the top is the CT scan, and in the middle is the PET imaging, where the arrows are showing this increased uptake of the PET tracer. That shows areas of inflammation. And then the bottom portions are his cardiac MRI, where there's late gadolinium enhancement at the same areas of the tracer uptake. So this means that he has a region of his left ventricle at the apex and the apical lateral wall that are highly inflamed. And these are the reasons that he was in VT storm. This gave him a provisional diagnosis of cardiac sarcoidosis, and the standard treatment there is steroids. But the clinicians taking care of him had a very low index of suspicion for a potential genetic etiology as well. So referred him to the cardiogenetics clinic, where we did find a variant in DSP, or desmoplakin, that led to a premature truncation. So we have sequence now. Is it the final part? Of course not. We all know that the next phase of sequencing is the analysis. And so when we talk about is next gen the final gen, I would say that the generation of variant analysis, see what I did there, is what we use for being able to understand what this variant means. We have a lot of tools at our disposal. These have all been talked about already this morning. Our last session was fantastic. Kara went through those standards and guidelines that were generated first in 2015 by the American College of Medical Genetics and Genomics. This is our starting point for variant analysis. We use NOMAD, the genome aggregation database, which now in version 4 is over 700,000 exomes and 76,000 genomes. Clingen, which Melanie went through in some fantastic detail, is that expert panel curation of gene to disease and how they can be linked. And finally, ClinVar is what we use for individual variants that different genetics laboratories have identified and then can distribute into this database for other users to be able to find and use in their analysis. So we have a sequence, it's a desmoplakin gene, but the question is, if we turn the clock back 15 years, isn't DSP an arrhythmogenic right ventricular cardiomyopathy gene? And this patient had left-sided disease. So this is where the real, I think, evolution of variant interpretation comes in. And this has also been discussed in the past sessions that we've had. What I like to do is to go through three aspects of that evolution. The first is reassessment. Reassessing, does the gene contribute to a broader phenotype than we originally had suspected? And the second could be, is there any new evidence for strength of pathogenicity of these genes? And so for that top point, I think it's really well understood, especially by people in this audience, that there are several of those ARVC genes that are now well understood to be contributing to left-sided disease, to the point where a lot of folks call it arrhythmogenic cardiomyopathy, just as a broad characterization. As another example, we've heard a lot about long QT genes today, and as you're all aware, it's a very long list of long QT syndromes and many genes, but an expert panel were put together to look at this data in detail several years ago and really found that our original 3 genes, the KCNQ1, KCNH2, and SDN5A, are still the ones that have definitive evidence for pathogenicity in long QT syndrome, and that only 4 other of those genes had strong evidence of pathogenicity. All the rest of the genes for long QT syndrome are, we've got some variation there. There can be limited evidence, there can be disputed evidence. And so reassessing that strength of pathogenicity is an important thing to do over time. Reinterpretation is also very important. For buses, as we heard already, there's a strong role of using segregation to better understand if a particular variant could be associated with the disease, and then trio analysis for de novo variants. And what we do in our clinic is that when we see a patient in follow-up, we will run their variant through our analysis pipeline again to understand, is this now been reassessed as benign or pathogenic? And then finally, retesting has a great role, in my opinion. As we know, these panels are getting larger, and Melanie at the last session talked about a lot of genes here where the strength of pathogenicity may not be so high. But every now and then we do get a gene that comes out that does have strong evidence of pathogenicity. Filament C is a great example of that. And so we will often have patients come back to the clinic who had gene-elusive arrhythmogenic cardiomyopathy. We'll retest to see if maybe they have one of these genes that we have strong evidence of pathogenicity for. But in the cases where we don't find that, there is the opportunity for whole exome and whole genome sequencing. So how do these compare? With panel-based sequencing, there is first the whole genome is fragmented, but then there's a step called target enrichment. With this target enrichment on a panel-based testing, we're using either hybridization or PCR techniques to only pull down those exons and a little bit of the flanking intronic sequence around each exon. This leads to a smaller amount of DNA that goes through this massively parallel sequencing, so that the sequencing depth is huge. It can be more than 500-fold, the cost is low, and the turnaround time is fast. For exome sequencing, it's a similar pipeline, except for that the target enrichment step is now all of the exomes in the whole genome. That accounts for about 1 to 2% of the entire genome. The coverage then is a little bit less, 50 to 100-fold, and the cost is higher. And then finally, whole genome sequencing now eliminates that target enrichment step, and it's the entire sequence where then by definition the depth is going to be less and the cost is going to be higher. So when we use this, we have to keep in mind that panel-based and exomes do have some limitations. There is the possibility of a variant that's deep in an intron that could lead to a new splice site, might cause a frame shift mutation and loss of function, and that would never be captured in a whole exome or in a panel-based sequencing. Furthermore, the target enrichment step, it can be biased. There might be exons that just don't get the coverage in the sequencing phase, and it could be missed. But whole genome sequencing, since it's eliminating this step that could be biased, eliminates that process. And as a matter of fact, the group from Broad very recently showed that moving from a person who had panel-based testing that was gene elusive, that there could be a role for whole genome sequencing being the next step rather than exome sequencing. There had been many studies indicating that the cost was just not worth the yield on this type of testing, but this group from Broad looked at 822 families where there was evidence of a monogenic rare disease that had not been able to get a genetic diagnosis. We found that 29% of families were able to get a genetic diagnosis using whole genome sequencing. And the panel to the right indicates the distribution of what was found. Many cases were new genes, but we also had cases where it was a known gene that then got promoted to likely pathogenic, structural variants, which of course we cannot find with exome sequencing, and then the coding variants that had poor coverage with exome sequencing. So it's worth debating whether whole genome sequencing and its cost could be ultimately cost effective. And then finally, since this is all about the ohm, it brings up the question of whether next-gen sequencing is really the last in the say. I would say that we could use proteomics. Now, it's still very much in the research phase, but the group from Eckhart's group looked at the inward rectifier potassium channel, and they did top-down and bottom-up proteomics to identify 6 novel phosphorylation sites that they actually showed had massive effect on the channel's function. And just so to summarize, next-gen or massively parallel sequencing, it can generate a large amount of genetic data at relatively low cost, but the sequence alone is not enough. And you really need to use the generation of variant analysis to truly understand your variant. That variant analysis can evolve over time. And so I encourage everyone to reassess, reinterpret, and retest, and that other omics can be used as a complement to next-gen sequencing. And with that, I'll take from there. Thank you.
Thank you, Lisa. Fantastic talk. We're going to save our questions for discussion at the end. So we'll push ahead, and our next speaker is Adam Gordon. And the talk is Put Me In, Coach, When Should a New Rare SADS Gene Be Promoted into Commercial Panels?
I'm afraid to touch it.
Yeah.
Yeah. I'll bend over.
Okay, great. Oops. All right, maybe the mini bar will go away. So, thanks everyone for the invite to speak at this conference. I've really enjoyed all the talks so far and learning, and what I'll learn this afternoon as well. So I was sort of asked to give a talk on how do new genes get added to panel testing. I don't have anything to disclose. Really, the one thing I do have to disclose is I've never worked for a panel testing company. So I can't actually tell you exactly what happens in the room where they decide, what goes on gene panels. But instead, what I'm going to tell you about today is gene curation, something that's come up a lot already today. I think it's a really important process. And what I want to do really today is dive really deep into the weeds to hopefully teach a little bit about how does it work, demystifying it a little bit, and also showing that really in those weeds, there's a lot of relevant information. It's not just weeds, but there's flowers looking in there that we can get from the, that's left over essentially from the curation process. So just to define specifically what gene curation is, it's the iterative standardized process synthesizing current evidence to assess the validity and strength of the association between a gene and a disease. I think that's really important. We don't just curate genes. What we curate is gene-disease pairs, right? You've seen this panel already as a good lead-in, but these panels, there's constantly expanding, and the primary panel has about 100 genes, but there's also this kind of add-on preliminary evidence gene. So how to decide which is in which category? We've heard a little bit about this today in Melanie's talk. So what we're going to walk through is who curates these genes, where can I find this information, when are genes added to panels, why are some genes preliminary? And what kind of evidence underlies these decisions, and how is it all combined? I think really the meat of it is in that last, that how. Who curates genes? We've already heard a lot about Clingen today. Clingen is this NIH-funded resource, or the Clingen, the clinical genome resource, that develops and executes gene curation along with variant curation, as well as clinical actionability curation too. Genes are curated by these gene curation expert panels, or GCEPs. They're organized by disease category and clinical domain. So there's usually these Clingen loves acronyms, so there's these CDWGs, clinical domain working groups, for example, that might be cardiovascular, and then underneath it, there's different subdomains for diseases. Though GCEP's organization can be grant funded, a significant amount of this expert curation is volunteer driven. I think that's really important. These are people who are donating their time at all levels. There's researchers, clinicians of all types. Where can I find curations and evidence? My homepage on some browsers is clinicalgenome.org. And as we've seen a couple screenshots already from this site, if you search a gene, for example, MYH7, what you'll see is a number of different tabs. Can I use this as a pointer? Is that working? Yeah. Let's make it a laser. There we go. Okay. So, so when you search a gene, for example, MYH7, what you'll immediately see is at the very top, there's this gene disease validity space. Below it, there's the other types of curations that I'm not showing, like dosage sensitivity, and down here, cutoff is clinical actionability. This is cut off for this talk, but I could give a whole other talk on the clinical actionability. Don't ignore that section. As we've already seen in this gene disease validity section, this gene is the same, MY7, but what we're doing again is this gene disease pair. So this is basically saying this gene was curated for this disease by this group on this date, and this is the classification they came up with, right? Same view here. So when are genes added and why are some preliminary? As we've already seen from Melanie's talk, there's quite, it's not quite cut and dry that only definitive and strong genes end up on the core panel and only limited genes end up on kind of this preliminary panel, although that's sort of a bit of a rule of thumb. If I give you a gene on a preliminary panel, it's more likely to end up in this limited, moderate, or even sometimes disputed category. The core genes are more likely to end up kind of in these three categories, although there are distinctions, of course. These are the official Clingen definitions of this category. Notably, definitive means no convincing contradictory evidence. It's something really important, that the strength of the evidence might differ among definitive and strong, but in definitive, there's no convincing contradictory evidence at all. Same with strong, right? Having contradictory evidence doesn't just bump you down to strong, it will bump you all the way down to disputed, right? I think that's important to remember, that when you see the disputed tag, that means there is actually contradictory evidence. Something that's limited or moderate just means there's evidence, but it's not quite strong enough yet. We're going to talk a little bit about what that evidence actually is when I say strong or weak. So here's two examples, right? Filament C, we've already talked about. Thank you, Lisa, for the lead in on filament C. So this is one that's on most of the primary panels these days, although a newer addition. And when you look at the gene disease validity panel for this gene in Clingen, you'll see it's been curated for 3 disease pairs here on 3 different dates by 3 different groups, right? These are overlapping but not the same groups of people. So you might imagine that sometimes, they might consider evidence differently. But notably, this is definitive in all 3 cases here for DCM, for myofibrillar myopathy, and myofibrillar myopathy 5. If you look, for example, I just picked this one at random from an add-on panel, a gene that I don't actually know a whole lot about, ANKRD1. When you look at this one has been, again, curated for congenital heart disease, DCM, and HCM, limited, and disputed on these dates by some of the same GSEPs, but not all the same. So this can give you, as you've already seen earlier today, a bit of an overview quickly of why this gene might be on the preliminary panel, right? We've got limited evidence for a couple of phenotypes and disputed for one, versus this gene, even though they're kind of the same age, right? This is the first curation for myopathy here was in 2017, but the more recent curations were in 2020 and 2023. Similar here is 2020 and then this year in 2023. So the age of the gene isn't really all that different. It's just the evidence that's stronger in one case. So what kind of evidence goes into curation? Melanie already kind of gave me a good lead in for this. There's 2 main categories, genetic and experimental. I wanted to actually, zoom in on the specific Clingen rubric, I think because it often seems very mysterious and very complicated, but in fact, it's quite accessible, I think. So the kinds of genetic evidence that go into curation that folks review the literature. Oh. You know what? I'm not going to go there. Oh, there we go. Okay. So the kinds of evidence that go into the genetic evidence, that is, are variants de novo? Have variants been detected? This is at case level data, this bar here. In cases, have variants been detected, in trans, at least one de novo, or 2 variants, that are also with gene impact in trans. Segregation evidence at the case level here with different LOD scores or strength of the segregation evidence. Then, case control data is the second half of this genetic evidence, which can come in the form of single variant analysis or aggregate variant, meaning burden testing across many exomes of many people. And what goes into assigning points for this case control criteria are things like statistical power of the study, what was the variant detection methodology used. The other category is experimental evidence, falls into functional alteration and models and rescue categories. These are the subtypes here, but I'll point you over here that there's actually difference in strength of all of these different kinds of functional evidence, right? The weakest kind of functional evidence is just this biochemical function. If we have a gene product that we're pretty sure is involved in disease, and gene product A is pretty similar in the same pathway or very similar, that's weak evidence. Or the function of A is consistent with the phenotype of an affected individual. We have some functional evidence. Stepping up a little bit in strength, is it expressed in the relevant tissue? Are they, A and B might interact with each other, and we know that one of these is involved in disease, for example. Even stronger than that, I should say, it's this functional alteration category. Geneticists, how do we find out what something does? We break it and see what happens. That's this alteration category. Function is demonstrably altered in individuals with candidate mutations. When you knock out gene product A or alter its function, you get a phenotype. Similarly, function is demonstrably altered in engineered cells with candidate mutations. If we have patient iPSCs, or we, CRISPR invariants for cell lines, do they, give a function we would expect to be consistent with disease phenotype? And then the strongest, according to Clingen, and remember, this is just a bunch of folks in a room coming up with this rubric. So there's no necessarily definition for why this is the strongest other than that we assign it to be that way, is model systems and rescue, right? So if we engineer a model system, an animal model system that has this defect that we've described up here in this category, can we essentially rescue it by putting back in the wild type version? The same thing for cell lines. That's kind of evidence that goes into curation. How does this all come together, right? There's all these different pieces of evidence, and one of the things that the GSEP spends most of the time doing is just, exhaustive review of the literature to find things that could fit these different categories. And then there's just a point system. So they go through all of the evidence that they've accrued, and they say, they use this point system to say, well, take a look, for example, at this de novo row here. The max score notable for all genetic evidence, you can't go above a 12. So at some point, you don't have to keep accumulating, points beyond 12 if you've already hit 12. So for every published instance of a de novo variant in this case, in an autosomal dominant disorder, depending on, details about the study, was everyone assessed? Do we really have clear trio data? Was it a full genome so we know there aren't other variants involved? You might assign 2 points per study. You might assign like 0.5 to, or 0 to 3 really for any of these studies. And then you go through this whole rubric and you assign for all the studies that you found. You collectively agree on a number of points to assign each study. You put it in this category, and there eventually you'll total it, either 12 or lower. Same idea for this experimental evidence, right? We're going to look for studies of biochemical function. If we find one, the default is going to be 0.5. It will assign that it's 0.5 amount of evidence. It's unitless arbitrary scale. But it can be 0 to 2 depending on different qualities of the study itself. You can only actually go up to 6 for experimental evidence. So I think that's important to note that the scale goes when you total both of these together, 12 plus 6, goes to 18, but genetic evidence has a significantly greater influence. If more genetic evidence is going to contribute more to the strength, the overall, disputed or strong status, then the experimental evidence is allowed to. And again, how does this all come together? You've already been alluded to this wonderful, really landmark publication of a bunch of people in a room got together and came up with this unified framework to do this across all different clinical domains. I think that's pretty cool. What you basically do is sum these points together, and you end up with your ultimate result. You basically, if you're 1 to 6, that's limited. 7 to 11 is moderate. 12 to 18 is strong. If you're 12 to 18, and there's been evidence over many different years and many independent studies, that's how you get the definitive. So it's just strong plus replication. Yeah. So now let's walk through an actual example, right? That was all very arbitrary. But one thing I want to make sure people take away from this talk is that this information is all extremely accessible. Clingen, the benefit of Clingen is not only coming up with this one word, definitive or strong for all of these genes, but they've made all the information that they use to make this determination immediately accessible too. So I want to really encourage people when you do, not only to look up stuff on Clingen, right? But when you do, click this button. For example, if we're interested in filament C and how it's associated with DCM here, we know it's definitive and that it was reviewed in 2020. If we click this button here, we get the actual full report. What does that report look like? The first thing you'll notice is there's kind of a text description, if you want, I'm not going to read this whole paragraph, obviously, but there's kind of a written up description by the GSEP of how they reached their decision. But more discreetly, what you'll see is these different tabs up here. Notably, you'll see this genetic evidence tab, that's up at a 12, and there's a little star there, meaning that hit maximum, right? So there's 12 points of genetic evidence went into filament C's determination. Only 4 points of experimental evidence. So right away, we can sort of see that this was really pushed by genetic evidence. When you actually click on that tab, you click on genetic evidence, what you'll see is very clearly each study, and this table's organized by probands, right? So there might be probands across one study. But you can look at the proband level of how much each proband contributed in terms of evidence, maybe some of what their clinical features were, whether or not there was segregation, and ultimately how many points were assigned for this individual proband. So here, this proband contributed 0.1 to the overall score of 16 for this. And this is a really long table. I'm only showing you the first 2. But if you're interested in basically seeing hey, where can I find all of the probands that have been found for filament C and what they look like, you don't have to go scouring the literature. Clingen already did that and made it pretty accessible. Similarly, on the experimental evidence tab, you'll basically see the same thing, right? Okay, how are these 4 points derived? Well, there are these independent, really strong model systems. And here are the publications that they exist in. Here's the explanation. That's what they found in the actual model system, and in a pretty small synopsis. And this is what this point was scored. The default for a model system was 2 based on the rubric, and each of these got 2. There may be more. Again, re-review might add additional studies to this. Even though we're already at definitive, when Clingen goes to reassess these genes, what they might find is additional evidence, that would push it to the 6 up here, also not beyond, although they'd still be listed here. They don't just stop looking once they find the third one. This is, and not only that, on that page, the kind of the top page of when you click the report, you will find the actual full rubric for each of those genes too. You can see exactly how many points went in for each of these categories and how it adds up to definitive. So again, the goal here is really to just demystify this process, even though it seems that it's really in the weeds to do this. For the people who spend a lot of time instead of assigning it, they've left us with kind of a trail of breadcrumbs to follow their path of how they got there. And if this sounds like fun, if you're like a huge nerd like me, and this sounds like a lot of fun, like Clingen really is volunteer oriented, right? And Clingen has expanded rapidly over the years. Clingen is not just cardiovascular stuff. In fact, I'm not even involved in any of the Clingen cardiovascular efforts. I do cancer stuff and eye stuff, a whole bunch of different things because I'm like a big genome nerd. But like, take the survey. Donate some of your time, because this is the kind of thing that only runs on experts and expert volunteer time. And they're always looking for new people to reassess genes. It helps when there's new blood reviewing genes that have already been reviewed, right? Because you might know different pieces of the evidence, or might know where the evidence might be going and where to look. Or again, you might be able to see where the gaps in the studies are and generate your own evidence, start publishing your own case series that might end up in this gene reclassification process as well. So that's all I really had to say today, and thank you all for your time.
Next, we're going to welcome Carlos Prada, Dr. Carlos Prada, Director of Genetics here at Lurie. He's going to talk to us about the intersection of genetics and the newborn screen.
Well, thank you for the opportunity and the invitation from Greg and the organizers. Yeah. Well, we get the slides. I think Greg probably picked the time of the lecture right after lunch, or the circadian, yeah. I'll be talking about newborn screening, yeah. Just bear with me, yeah. Thank you. The newborn screening, out with the assay and with the genetics, yeah. And raise your hand if you like genetics here. Yeah, that's my group, yeah. I see my fellow there, yeah. So disclosure, so this is probably one of the reasons I have not been able to join Clingen. I always in conflict, yeah. And I'm pretty biased to my divisions. I do need to update the picture, but we have a fun genetic groups here. So we have learned a lot about genetic testing, and really has evolved over the last 40 years, but it has really exploded in the last 20, yeah. So when I started genetic, not in the 90s, yeah, but the deal was, and we heard that in the grand rounds early this morning, that maybe the deal was less than 1% or 2%. That used to be the case. 1 out of 20 or 40 kids that came to clinic, we actually make a diagnosis. But today, sort of the expectation is actually really getting close to 4 out of 10 children we're able to make a diagnosis. So what has allowed this? The evolution of genetic testing, increased with diagnostic yield, and then the decreasing cost of testing. Now at Lurie, I like to make this graph. I just point one thing here. Before Carlos, we were doing about 100 exomes, per year, and now we're doing way more than that. So we're probably approaching 700 per year, which is great, yeah. So we are really increasing access to our patients, yeah. So we heard a lot about genomes, yeah. So if you like, not Game of Thrones, I like that one too, but Lord of the Rings, yeah. So it seems like the test that is really integrating now in the inpatient care, but outpatient, yeah. So we're kind of moving into a single test, potentially to do lots of sub-analysis. Of course, not a single test is perfect, yeah. Now, moving into newborn screening, so we have, which is the goal of the presentation. Make sure I keep on time. So this is a really important public health measure that started in the 60s, yeah, and it started with PKU as a single test, and then has been expanded as the technologies have increased, yeah. And now we have in Illinois, which is our state here, we have around 65 different conditions that are included in this newborn screening program. Babies have this heel stick test or the pulse ox or the hearing test, but a lot of these are biochemically driven, yeah? Now, there is a recommended uniform screening panel that meets and sets the standard on which conditions should be included for every state, but also every state is a little independent in which conditions they want to screen. So that allows for some flexibility based on legislation and patient advocacy to really include more conditions at every state level. Yeah? So lots of children diagnosed before symptoms and then implementation of treatment. So these were the initial kind of recommendations and requirements for a condition to be considered as part of the newborn screening. Serious impact to health, that there should be a reliable test that we can do in the dry blood spot or some sort of alternative technology as pulse ox and hearing screening. And also that there's a benefit actually making a diagnosis in terms of therapies or in terms of additional management recommendations and prognosis. Yeah? And then this is taken into account by this recommended panel to make a vote if that should be included or not. So this graph is just to show the amount of newborn screening publications has really increased in the last 10 years, and we'll keep going. In 2024, I probably don't have updated data. It's not that we're suddenly not interested. Yeah. This is just to show the evolution of what we have been including, but also the evolution of technologies. Of course, it's important to mention the human genome because that's what allows now to move into a genomic era of newborn screening. Yeah. All right, so here's an example. So I mentioned in the 60s, so we have PKU, in the 70s, then hemoglobin electrophoresis. So every time we add a technology, the enzymatic analysis, some other metabolites that we can check and hormone levels, yeah. Then we have mass spec coming into clinic, and then suddenly we have 20, 30 more diagnoses included. And then recently genomics, SMA and others have been integrated into what we do for newborn screening. Now SAD, since we're in SAD, so maybe this again is a set of conditions that they maybe not biochemical markers, but then there's a possibility of now looking at genomic markers that can actually create an impact in this population as well. So this slide just to highlight what could be the potential benefit, yeah? So to be in with the genetics, yeah? So probably the biggest expansion will be conditions that we don't really have metabolic biomarker, so for which mass spec is not the right technology, and genome or some sort of sequencing technology is the answer. Of course, keeping the principle that there probably interventions that make a change for the newborn or their family here, it's a lot of secondary and redundancy to the current screening that probably having some sort of genome-based screen may decrease the rate of false positives as well. But that, again, has limitations, but that could be another benefit. Now, Lisa really explained well the evolution of genetic testing from single variant testing to exome and genome. So single variant testing, we could probably store our data in a Nokia. Anybody still has one of those? Yeah, I remember them well. Yeah, but now you can probably store your trio genome in one iPhone. Yeah, so 120 gigs is the probably small capacity. But if you have teenagers, probably 120 is probably not enough for their life. Yeah, so keep that in mind. Yeah. But also the technology is improving so much also in time. So with these recent publications that show that they can actually sequence a whole genome under 3 hours, yeah? And that's really impressive. So if you have a child that you're concerned about a specific risk, it can be done today, yeah? And this actually was published several years ago now, yeah? It's still, when we do outpatient testing, can take weeks, 2 months, yeah? 3 months if you have to wait for insurance authorization, yeah? Nowadays, we're doing a lot more rapid testing, but the technology is here and really can be impressive. I probably sometimes don't get an ammonia level this fast, yeah, or something when I'm waiting in the middle of the night, yeah? So, which opens the possibility for actually, can we actually do newborn screening using rapid whole genome or some of these new technologies? And there are several studies ongoing at the moment in different countries. I want to highlight this one. So, Maria Paula, my postdoc, actually helped me with this slide. She actually went to the Guardian Update lecture, which I think is very important for this discussion. So, I want to highlight a couple of points. One is current newborn screening, we don't consent. Every child that is born has the heel stick test. So you actually will have to opt out, but everybody's basically automatically opt in the screening, and that's what has been really successful as a public health measurement. For this study, they present the information to the parents in the third trimester, and then when the child is born, they go over the consent. They use the same sample or the same filter card that the dry blood spots, so there's not additional sample collection. You can see on the right kind of what they're looking, conditions that have early onset, that are highly penetrant. They have two groups, the condition recommended and additional, but you can see the numbers. So Illinois, I show 65 conditions here, and 158, and then an additional 100. So we're talking about over 250 conditions that we are expanding in this pilot study. So there's a lot more to go through. You can see the timeline, so it's not quite as fast as we would like to have a newborn screening, which is typically 7 days. In this, 5 to 7 days, depending on the metabolites. And then include dominant and recessive conditions. So for dominant X-linked, they will only report pathogenic and lightly pathogenic. And then for recessive, then there will be consideration for a BUS if you have another likely pathogenic or pathogenic that is suspicious. So this requires also an additional infrastructure, because then we have to, if we have a positive test, then that triggers subsequent confirmation with another confirmatory test, or even parental segregation to know if this is incest or in trans in order to make the diagnosis. So lots of, and then kind of the follow-up will be similar to what we do, early treatment if it's a true positive, or if it requires additional testing or additional follow-up in order to clarify, then we'll go into that bucket. So Guardian is one. There is over 9. I just highlight 9 studies. Sorry, it's a small print. There's several studies here in the U.S., Australia, UK, or countries in Europe. They're looking at implementation of different technologies of either genome or target panels. And I highlight on the right or left. I have troubles with that. Some of the cardiac conditions that are already included, and some of those are arrhythmogenic conditions, which is relevant. So this is actually feasible, and then some of the recruitment goals for those panels. So we will be learning about some of the outcomes of these studies soon, not only for decreasing the need for secondary testing in the current panels, but actually expanding the conditions outside what we have traditionally screened. So anticipated challenge, so I mentioned it really takes time under the current system to onboard new conditions. So you have to go through the legislation, and then you have to go into the test validation, and then the implementation. So it can take 3 to 10 years at times to actually go up in the number of conditions. The advantage of this is a one test. It's just a different variant or condition that will be included. So it may be actually faster to implement than our traditional screening technologies. But it still brings a lot of different questions. Ethical questions, implications. We learned from Adam all the BUS burden, and others during this lecture. So there's a lot of uncertainty, and also are all the ethnic populations represented to actually be informative for some subgroups. So lots of challenges, but lots of excitement at the same time. Why did I put Fabry here? I do like Fabry disease and has a lot of hard features. But I wanted, and this is Ali, a genetic counselor working with me, and Joel, who was the former director for the division a couple of years ago. And so just to highlight one variant here. So we have newborn screening here in Illinois. probably when it was passed was to try to identify patients that had classical disease, and patients that had late onset disease, which is much you typically not during childhood, But I just want to highlight two things here. One is we have a lot of variants of uncertain significance, and this is not using genomic screening. This is using biochemical screening that flags as abnormal and then do genetics after. So you see 18% is uncertain, and this variant A143T is 35% of the screening we do, which is actually the variant that was reported in the initial family that the condition was described, but later on they realized that this was not the causative variant on this family, it was a second hit, but it's a controversial variant in the literature, So how many of those A143T are we gonna find once we move to genome? It's gonna be hard to know. And if we do the biochemistry, which is a functional study as part of what we use to try to understand variants, those patients actually, here's the threshold, most of them are gonna be below, So the biochemistry potentially is not gonna help you for some. There may be some that will be in the same range that late onsets, which maybe that's still maybe a risk, a predisposition variant, Now, so I wanna finish with, are we ready, or there's still a lot of challenges, and that will be good for our panel discussion, And finally, so we do see about 800 patients that come from a normal newborn screening. Very few are actually true positive, which is good. That will be following in our metabolic program. And I want to highlight that because outside of doing the test, we need to figure out how we're going to provide care for these patients that are identified early. So with 65 conditions, we already have a shortage. I mentioned the total number of geneticists in the U.S. Genetic counselors, thank you, because you guys are going to be getting a lot of calls, And then the average time in the U.S. is still about 6 months. So it's going to be challenging if we have lots of patients diagnosed early that cannot access care, 2014, I always mention this, I like the humbug well comparison that was in danger compared to geneticists. 2024, humbug wells are not longer in danger, but the geneticists are still in danger, I have a picture of one of my young faculty, Dr. Baker, who is also, like me, a biochemical geneticist. So we're 1 in 2 million, which is like, was looking at a similar animal in danger, different species. So the Amur leopard in northeast China is about 150. So we're probably 160, so that's pretty good, pretty close. So I don't know if the SAT Foundation will let me have some stickers so you can put in your cars, And thank you all,
Thank you, Carlos. We're going to move on to our last speaker for this session. It's Dr. Andrew Landstrom, who will speak on bricks, not blueprints, why RNA-seq matters.
Thank you, Jeff, and thank you to the organizers, including Greg, for the opportunity to talk about RNA postprandial in a room without much natural light, which is going to go really well. But I think actually, if you would consider a second title, I actually think of RNA as an overlooked nucleic acid with a lot of untapped potential for SADS conditions. So I have no disclosures except perhaps to say that I kind of ignore RNA a lot. I'm a genetic cardiologist. I think of DNA a lot, and I think of the affected proteins a lot. But I usually think of RNA as sort of the thing that makes the message that goes between the two. And that's sort of stuck in this central dogma of biology, which is not wrong, but I think kind of a myopic view. There are lots of different types of RNA, and this sort of flow chart just kind of goes to show there are lots of different roles for RNA. So its role in the cell is vastly complex and is beyond just a simple messenger. And I think understanding this is actually really quite important, because if we can get our handle on this with all the other omics that are going on, whether it's genomics or proteomics or metabolomics, I think we'll be in a great place to be able to talk about new etiologies for diseases that remain persistent among SADS conditions. We've heard a lot about from Lisa and from Carlos about the rapid acceleration of genome sequencing, which has been driven down by cost. You could say the same thing for RNA sequencing. And so, whereas it was quite expensive to do RNA sequencing, now it's really quite cheap. And what this has allowed the scientific community to do is to do this in massive parallel arrays. Now you can do a whole transcriptome on a single cell and do hundreds of thousands, perhaps millions of cells at a time, which then allows you to actually ask new questions that were not answerable earlier. And so when I think of RNA sequencing, I think it kind of boils down to the three big sort of platforms of experimentation. The first is bulk RNA sequencing, where you just take a piece of tissue, in this case maybe a piece of the heart, with all the constituents of that heart tissue, you grind it up, you extract the RNA, and then you sequence it, and you say what RNA species are there, and if you sequence them a particular way, you can ask how many of those RNA sequences are there, and you can get an expression analysis of that bulk tissue. But now, because of the low cost of RNA sequencing, you can do this at a single cell level, which just basically means you take that piece of tissue and you pull it apart to its constituent cells. So some of them might be cardiac myocytes, some of them might be cardiomyoblasts, some of them might be resident dendrites, or dendritic cells that are hanging out in the myocardium. But you can pull all these apart, put them through a pore, which allows only one cell to go through at a time. You label that cell, and then sequence that cell's entire transcriptome, and you do that times about 150,000. You can arrive at a transcriptomal analysis of all the different cells in that heart muscle, and that allows you the informatic power to actually ask really, really cool questions, which we'll talk a little bit more about. And then, now, you can actually keep that spatial relationship of those cells intact by doing something called spatial RNA-seq, which means you just cut the tissue, and you sequence each cell in situ in a given location in the tissue, and you can get a beautiful transcriptomal evidence about how disease progresses. And so I would say if we can start to leverage some of these tools for SADS conditions, I think it could actually be really quite powerful. And so really at the end of the day, I think RNA sequencing has tremendous potential. Greg gets it. Nernst potential. There's some electrophysiologists here, maybe. Okay. Postprandial. Tremendous potential for SADS conditions. Okay. It's a dad joke, so it's not meant to be funny, but if you groan, I think that's part of it. Okay, wonderful. So many of you might have heard of the ENCODE project, which starting in 2012, started asking what's all that junk in between the exons of our human genome. And what they found is that 99% of the human genome is not coding. At least 80% of that non-coding genome actually has a functional role. And so this has actually really empowered the genomic nerds to be able to ask, what are those? What does that do? And can we identify variants in those non-coding regions that might be part of the explanation for those patients who have clear-cut disease or their gene panel negative? This is one example of where the ENCODE project meets RNA sequencing. This was in last month's issue of Circulation, work led by Roddy Walsh, who essentially found in an endemic population of individuals in Thailand who have Brugada syndrome that there was one variant sitting deep in one of the introns of SCN5A that's different than control individuals. And what that non-coding deep intronic variant did was actually throw off a binding domain for a transcription factor that SCN5A needs to be expressed. And they did this through a genome-first approach where they sequenced individuals, saw the difference in this allele, turned to RNA sequencing, found a loss of SCN5A expression, gene-negative Brugada syndrome. And so this is one example of how RNA sequencing mixed with omics might actually allow us to determine why individuals who are genome negative, or excuse me, SCN5A negative, but still have disease, what the cause of that disease might be. There's a limitation to this. You need lots of people. You need to identify an endemic population and say, okay, who's got Brugada in this population? And then you have to sequence them and find this variant. So wouldn't it be great if there was a way you could do this at an individual level, where you need one person to ask this question? And the answer is yes, it would be great, and there is an approach, and that's allele-specific expression. And to my knowledge, this has not been applied to SADS conditions, but I think it's ripe for the taking. The basic approach here is that if you understand all the genomic landmarks, all the genomic variants in a person, you use the ENCODE project to ask, do those variants land in regions that might alter expression of genes that we know about? Then you use RNA sequencing from tissue to say, okay, now we might know the changes that are occurring in that individual's heart muscle. We might be able to find these non-coding variants. This has been applied to rare genetic disease that's not really cardiac, but I think if you look at potential applications, allele-specific expression for identifying single individual non-coding variant causes is ripe for the taking. What about single-cell RNA sequencing? This is a wonderful paper from Sean Liu out at Stanford. And what Sean found was that if you take induced pluripotent stem cell-derived cardiac myocytes, right, so iPSCs made from a person, and then guide those into becoming cardiac myocytes, and you do single-cell sequencing, you can actually define that population of cells, and you can define all the transcriptional differences that got that cell population to become a cardiac myocyte. Well, that's wonderful. What if you actually apply that to something like arrhythmic cardiomyopathy, where there's a problem with the differentiation of cells and the maintenance of that cell state? You might actually be able, at the single cell level, to determine the transcriptional drivers of that disease process and then target molecules that might actually ameliorate that developmental defect. Here's one example. So this is spatial transcriptomic RNA sequencing of one individual who had their heart explanted for very severe disease. They had their heart sectioned and spatial transcriptomics done of their heart. And to kind of boil down a very complex paper, what they found was that at the transition state between normal myocardium of his heart and that sort of fibrofatty remodeling, which we would all agree is not what we want our heart to be like, that in that transition zone, there's very specific markers, in this case, one called ZBCB11. That was a key transition point for that development. And by the way, if they suppress this marker, the iPSC-derived cardiac myocytes no longer have an ACM phenotype, which I think is pretty neat. This is one additional application in a very complex disease state, which I think, again, highlights the possible role for RNA sequencing. So this is work out of Deepak Srivastava up at the Gladstone. This is not a SADS condition, but this is bicuspid aortic valve, which I sort of thought of as, I have no idea how that happens, and we can't do anything about it. What Deepak found using iPSC-derived valve tissue, as well as a mouse model of bicuspid aortic valve, using single-cell RNA sequencing, and then layering on top of that AI, because why not? Just throw some AI on there. You can actually identify transcriptional hubs that are really critical for making those cells bicuspid, for making them pathologically remodeled. And you can target that with small molecules, in this case, a small molecule called XBT790. When he gave this molecule to the mice, the pups never developed bicuspid aortic valves. Amazing. That's amazing, and I think a case example of what's possible with single-cell RNA sequencing. And then, this is just RNA. What if we started to incorporate genomics into that? What if we started to incorporate proteomics? What if we started to incorporate metabolomics, the exposome? There's all kinds of omics these days. And now you can start to arrive at an individualized sort of picture of how somebody's DNA interacts with their RNA, interacts with their protein, and this is really quite powerful. And at a tissue level, these efforts are already underway. So people are taking normal human tissue, taking their single-cell genome, their single-cell transcriptome, their single-cell proteome, their single-cell metabolome on serial slides of that same tissue, layering it together, and they're going to make it publicly available for all of us. And that's absolutely wonderful. So I think the door is opening for this multi-omic approach to SADS conditions. And just in case anyone's particularly inspired, here are a number of publicly available resources for you. The Human Cell Atlas, I think, is actually really quite excellent. So for our GCs out there, if you're ever wondering, is this protein I've never heard of actually expressed in the heart? Here's where you can go. If you don't like that, here's the Heart Cell Atlas version 2, which I've heard is much better than the first version that came out. But if you're interested in this actually has beautiful single-cell data in situ. If you want to know what the transcriptional arrangement is of certain cells in the heart at the cell level, this is your website. And then, if you do any RNA sequencing from the NIH, you're obligated to put your transcriptomic data online. This is sort of the default biorepository for all that transcriptional data that's been ever done and funded by U.S. taxpayer dollars. It's called the Gene Expression Omnibus. With a little bit of a registration process, you can go here and you can download all the transcriptional data you could ever want. It's a free and open access resource for anybody. Back in 2023, they had 200,000 samples, 200,000 studies with 6.5 million samples. So a great resource if anyone's interested. And so with that, some take-home points. RNA sequencing has rapidly accelerated, allowing for high-resolution cellular and spatial approaches to the transcriptome. Allele-specific expression, I believe, opens the door for identifying non-coding variants in SADS conditions. If properly leveraged, I think transcriptomal analysis can yield therapeutic targets, particularly when merged with other omic studies. Arrhythmic cardiomyopathy in particular, I think, is ripe for a multi-omic interrogation, and there are growing numbers of publicly available data sets and biorepositories for anybody who might be interested. So with that, thank you very much for your attention.
We'd like to invite all of our speakers back up so we can have our Q&A session. Got it all at once.
Okay, hello. When thinking about scaling up RNA-seq proteomics in a clinical setting, we already have limitations just getting people testing. How do you see these things being paired? How do we expand that?
Well, I think right now, the role of transcriptomics, clinical evaluation of SADS patients, I think the domain for these kinds of assays is really in the research space. There are scalability problems there for sure. I think that world right now is a little bit separate from the clinical community. I think the benefit of kind of getting over some of those scalability concerns, at least film has taught us, and I think it's made me very humble in the complexity of human heredity. Brugada syndrome, for example, not a straightforward Mendelian. I think genomics gets us there. I think transcriptomics really helps get us there to describe this disease in the nuance it probably deserves. And so I think overall, there's a lot of possibility there. I think scalability remains a concern. And I think if we can get there, it can help those patients. Not too distant.
Really fantastic talks by everybody. I could actually ask all of you questions, but then you'd be very bored. But just from the transcriptomics point of view, we published a year or two ago small comparison of Brugada versus control samples looking at RVOT tissue undergoing RNA-seq. And we found reduced expression of SCN5A, IRX3, and IRX5. Loci that are affected, and that was irrespective of whether they carried SCN5A variants or not. It was a very small experiment, but we're surprised that it popped that out. Very nice, but those cases had also undergone quite detailed in histopathology and showed fibrosis. And so I was looking, well, why aren't we seeing disturbance of fibrosis and collagen-associated pathways? And then it sort of dawned on me. We've taken the snapshot, and unfortunately these are tissues that come from deceased people at their time of death. And these are conditions that have evolved over their whole lifetimes. And we think that there might be some congenital aspects to why Brugada syndrome develops in the RVOT particularly. And so we take that snapshot, but we're not actually necessarily seeing how we got there, and therefore what the true mechanism of the disease is. We're just seeing a reflection of what it's like at that point in time when we've done that comparison compared to other sudden deaths that are non-cardiac. And so I just worry that there's also maybe a limitation to transcriptomics from actually getting to the mechanism, that maybe we need to skip it to the protein in more detail and further downstream from the genomics to actually see how the GWAS loci polygenic risk scores actually influence the downstream field. So that's my one anxiety about this being spatial. And it's 4 samples at about $30,000, $20,000, $30,000. And that's just that's 4 slides. Causing me pain just doing a pilot study. Yeah.
Right. I think certainly transcriptomics has limitations. for all the reasons you just discussed. And I think something that happens when something is so cost effective, it loses some of that. I totally agree. I think transcriptomics are helpful these days more than ever times. I agree. It should not be interpreted to understand kind of that transcriptome. I also think your findings are really quite impressive, and that if you have an end-state disease that is unified by the phenotype, pattern on an ECG, loss of function of SCN5A, transcriptomal level, it almost gives you clearance to say, okay, now let's look at all the things that got us there. That kind of study, I think, needs.
So is there danger, or can you comment on the danger of utilizing genetic testing broadly for newborn screening when you have diseases with variable or incomplete penetrance and psychosocial burden that might?
Great question. We're already doing that without going into the chemical conditions. With a lot more attenuated, I will not cause childhood onset. So, as a child, actually develop plans that are a little less overwhelming. Our balance, and we already deal with that for I anticipate it's going to be the same challenge to move. Not unusual that even for classical.
I was interested in your table. So I'm involved in the generation study, and I was involved in the working group for choosing clinicians as a sort of cardiovascular representative. I always have done doing a lot of work in sudden infant death syndrome with Mike. I'm struggling. We had a lot of debate around the principle of using even LQT13 or IR2 as genes for predictive utility. I'm quite surprised that the other cohorts are really opting to use those, because there was a lot of angry debate around it, whether there was any reason, any way we could actually report that without really understanding true penetrance of even the variants that we think of as being nailed on. Maybe if you're in a founder population and you can say, yeah, that variant is going to cause disease in that newborn because of their genetic background. But yeah, there was real resistance against even thinking about reporting it in the phase 1 of the study. So I'm surprised that others are leaping to it already. And that's 100,000 newborns. Still the biggest study of the lot at the moment. Will be. So I'm interested to see what your thoughts are on that.
Huge challenge, because
functional translation of. That's why I mentioned the capacity. So driven for all these things that we know and have interventions, yeah. I thought this has happened even like and gets implemented. Have to come out with plans to how do we actually couple newborns. I have a feeling we're going to be in the same. It's just going to, yeah.
There's a lot, yeah, and we got to the point of saying this is the process we're going to do on a variant-specific level, that we're going to agree that these variants are the ones that we would report back before we'd even found them, and this is 100,000, so you may be going to find 100 variants across the long QT genes that you think, individuals that you may actually report out of 100,000 people. Nice.
Yeah, no, I challenge you. I mean, the way that they're designing this is focused. I can reanalyze everything.
Functionally expressive, but you're only functionally expressing that allele out of context. And you just don't understand that, the haplotypes that you risk.
We love this conversation, but yes, we do need to move on to our next session.
I'm all for doing it, but I think it needs to be proper research. It has to be research. It should not be driving a clinical service, which is where we got to. We were talking about which pediatric centers would see the patients that were predicted as having risk. And then everybody came back and said, hold on, what are we doing here?
I do think there's an important conversation about where the line is between what is clinical and what is research in many of the conversations that we've had in the past, several hours today. So we'll just set you up for SADS next year. Thanks, everybody.
Let's take a 5-minute break, but just to keep us on schedule for the end of the afternoon, let's get started at 2:20 for the next afternoon session.
Check. 1, 2, 1, 2. Check 1, 2.
Never do. I have me every day.
Check 1, 2.
They're right here.
Test. 1, 2, 1, 2. Check 1, 2. 1, 2. Check 1, 2. Check. 1, 2, 1, 2. Testing 1, 2, 1, 2. Thank you. Check. 1, 2, 1, 2. Nice and clear. Thank you. Check. 1, 2. Talking into the podium mic. Check 1, 2. Oh yeah, I guess.
All right. I'm just going to. Now. Yeah, no, actually, so he's done. Oh, this is, sorry.
Over,
That's the one I'm trying to hear. So 11 is done. And, yeah, that's done. Okay. And then we should have Chelsea.
I think that's the next one.
Yep, Zimmerman, Abrams, there. Yep, perfect. I just wanted to clear up some of that.
Yeah, totally.
Okay, so we'll go here, here.
Make sure you share again.
Yeah, so do share, screen, share.
I'm gonna get rid of this thing.
Yeah, and so did you see what I was, so like right here, escape, so then when I want to get out of presenter view, I have to push escape.
You have to do it again.
Yeah, escape, so. Fine. But, yeah, the audience is really good, so, I mean, you could hear me over the mic.
Yeah,
So,
really about how they speak.
yeah, no, I mean, all the way right now.
I know.
It's insane. Okay, so we're good. All right, so that's Sammy.
Oh, that's fine with me too.
Oh, you yeah, okay, so I've got Sammy.
Blacked out.
Yeah. What is in there that you're gonna black out?
That's tricky. That's at 2 o'clock, so we have a rule in Iowa about
Okay.
Friday in Iowa, yeah.
So Sammy's already queued up and ready to go. However, when you go to the next one, you have to go escape. That reactivates that toolbar, and then you go escape again to get out. Sorry. Right. Let me reactivate that. There. Escape, and then it will. So then I have everybody queued up, so Frank would go next. And then if you wanted to start Frank, you could do that. And then right here, this guy hides floating meeting control. But every time you push escape, you reactivate it. So it's like kind of like if I go right there to get out of Frank.
Well, the nice thing is toggle it. Wouldn't it be great to just toggle it on?
I know. It's a Zoom function, so.
Can you fix that?
I got nothing for you, but. All right.
I was told by Greg, I'm just a pretty face, so.
Pretty.
Good. Because it took a long time to get this whole thing going.
I love that. Okay. So it sounds like the sound is way up, and we're good.
I thought you were going to be close
Okay.
I actually trained at University of Michigan, but I'm Columbus born and bred. Oh, right. I went to Michigan in 2007 to 2009. Okay. By yes. Well, and then my boss is Hugh Hawkins, who was on the faculty at University of Michigan in like the late 80s. I do entirely different structure. Been boss for a long time, so I've been with Happy about that. Yeah, we have to add this thing. I have an army of research fellows, but yeah, it's, calculator was built and then validated in a few other populations, and then now the decimal plaquing calculator is out, so now we're working on
Hello, everyone. Welcome back from break. We're ready to get started with our next session, if you are. Fantastic. Well, thanks for everyone coming back. I'm really excited about our next panel, and we're going to be talking about my favorite thing, arrhythmogenic cardiomyopathy, and we have a really great panel session for you. So first, we're going to invite up Sammy Chooky to give us a little talk about some cases.
Good afternoon, everyone. Thanks for having me here. I'm going to be talking about a specific patient of mine, and I hope to hear some good feedback from everyone because I need a lot of help. So I was tasked with giving a talk called "The Rhythm Is Going to Get You." Where did it? Let's go. All right. So this starts off with an initial presentation at 15 years of age. So this young woman showed up in my clinic, or actually in a different cardiologist clinic at first, after developing some postural dizziness and dizziness with activity. She was a pretty active young lady. She was a cheerleader and never had symptoms before, but this had been something that had been developing over the past year. The initial cardiologist did an EKG on at the visit and saw some isolated PVCs. At first, the cardiologist figured that this was just benign PVCs and ordered a Holter monitor. But when that Holter monitor resulted, there was almost 10% ventricular ectopy. And the ectopy was present as isolated PVCs, but there were also up to 6 beat runs of VT, at times appearing a little bit polymorphic. So this concerned the general cardiologist, who ordered a cardiac MR and an exercise stress test. So this is what that presenting EKG looked like. You can see overall just low voltages everywhere. The T waves don't look too crazy. The axis looks not too crazy either. We see isolated PVCs here. There's a slight difference in morphology, maybe due to fusion, but on Holter there are clearly different morphologies present. The cardiac MRI showed mild dilation of the left ventricle and of the right ventricle, and both had depressed function in the 40% range, and both showed delayed enhancement. And they described the RV as having a crinkly appearance with brightness on stir imaging at the apex. While this MRI was pending, the cardiologist did a stress test and was reassured that as the patient exercised, her PVCs suppressed, which I think a first take-home point, I think, for our general cardiology trainees and general cardiology folks is this impression that if PVCs go away, you can feel good about the results of that stress test. This is an example where that is not the case. So because of the abnormal MRI, this patient got referred to electrophysiology, and as they were arriving, they were started on a heart failure regimen by the primary cardiologist as well as Nadolol. So now she's my concern. We have her on heart failure treatment. We have her on Nadolol, but she's got these abnormalities. And so we started with genetic testing, just given all these abnormalities, and arrhythmogenic cardiomyopathy was at the top of our list as far as phenotype. We found that she had a pathogenic mutation in desmoplakin, and there was a frame shift in the rod domain. It led to a truncated protein. All labs had reported this as being pathogenic or likely pathogenic. This was about 5 years ago. So I think this is a slam dunk pathogenic mutation. Oddly, she had cutaneous findings in woolly hair that go along with Carvajal syndrome, which is a recessive desmoplakin finding. And she did have a VUS in desmoplakin as well. Now, at the time it was reported as a VUS, there was not much information about it. But in the literature, which was published after this diagnosis, there is one patient that's been described as being a compound heterozygote who also had a truncation mutation in desmoplakin, who had a pretty significant arrhythmogenic cardiomyopathy phenotype. It's a pretty rare allele when you look it up, and our genetic counselor went through all the processing of everything that we've heard about in the previous talks to find that this is probably going to push into the likely pathogenic to pathogenic allele. So we did cascade testing to figure out what was going on and found that her mother had only the pathogenic mutation, which indicates that she's probably a compound heterozygote as well. Her older brother had only the pathogenic mutation, but her younger brothers both had both alleles. So just a quick aside, and I know Dr. Abrams is going to talk a lot about desmoplakin cardiomyopathy, so I'm not going to dwell on this, but it does typically present as more of a less dominant arrhythmogenic cardiomyopathy. It's often characterized by recurrent LV inflammation. She did have recurrent chest pain that I didn't mention earlier. It does come with a significant risk of cardiac arrest. And some people would suggest that the risk of cardiac arrest occurs even at higher ejection fractions than you would expect with non-ischemic dilated cardiomyopathies, even with people with completely normal ejection fractions. And I just have here a kind of a timeline from our very first description of desmoplakin in 2000 to more recent, and we've really had a lot more data come in about this protein in the last 5 to 10 years. So as far as the patient goes, despite the Nadolol, she continued having polymorphic ventricular ectopy, nothing longer than 4 beats, not particularly fast, but she was starting to have lots of presyncope, hypotension on her beta blocker, and then started developing more and more frequent ventricular ectopy that was associated with chest pain and worsening presyncope. And at the time, given her borderline function, we thought it would be reasonable to start her on Sodolol and give her an implantable loop recorder. The dizziness got a lot worse, and Sodolol, as we probably are all aware, does tend to act as a pretty strong beta blocker, especially at lower doses, and her hypotension seemed to worsen, and now she was even more bradycardic than before. Her loop recorder, unfortunately, just like her surface EKG, had such low amplitude QRS complexes that we were having a hard time sensing even her normal sinus rhythm. So with all this happening, I'm going to ask you, when we do the panel, would you have changed your management at this point, or would you have continued to watch this patient, which is what we did with some intervention. So over the next 3 years, her LV function did decline into the 30% range. As she developed these symptoms of heart failure, worsening function, when she was still kind of in the 40% range, she was having more non-sustained VT and polymorphic ectopy. We did give her a dual chamber transvenous ICD, dual chamber, so that we could pace her a little bit faster given her significant bradycardia. That marginally helped her feel better, being paced faster, but she continued having lots of symptoms of hypotension, lots of presyncope. That was not thought to be related to her arrhythmias. And this is kind of where we started having to think outside of the box. How do we make her feel good while treating her? And because she had an ICD and her function was kind of borderline, we got her back into the 40s. We thought it would be reasonable to in a very controlled fashion, start her on flecainide to see if that could be a better antiarrhythmic for her with less side effects. And we dropped the nadolol to kind of a low dose background. That helped her significantly, but she continued having hypotension. And after lots of discussion with our heart failure team, did something that might be controversial, which is start her on midodrine, so increased her SBR despite her being on all these SBR decreasing medications to help with her heart failure, which did help her feel a lot better. However, over the next year, her LV function continued to decline despite her goal-directed heart failure therapy, and she ended up having to be started on home milrinone, and her ventricular ectopy continued to worsen to the point that it was over 35%. The heart failure team started getting concerned, as did I. Everything was non-sustained, and given her acute decompensation, we decided to try mechanical support, but her small stature did actually preclude the use of any LVAD options. Ended up getting listed for transplant. My questions for you guys is, anything you would have done differently? And I have an opportunity to try new things with her younger siblings who, by the time of their age 5 and 7, are starting to have some ventricular ectopy. So the older brother, who had the pathogenic mutation only, was not diagnosed until after graduating high school by Cascade screening. He played competitive soccer through high school, no symptoms, normal function, normal MRI, and I asked him to try not to avoid vigorous exercise and referred him to adult cardiology for long-term management because he was in his 20s at this point. The younger brothers were asymptomatic at the time of Cascade testing with no arrhythmias, normal function, normal MRIs, and we restricted them from competition, but by ages 5 and 7, they're starting to have ventricular ectopy, not a ton, but more than 500 in a 24-hour period, up to triplets, and I've started them on beta blockers. Now I'm just watching. So just to summarize and to put some questions out for everyone, desmoid plaque and cardiomyopathy is a unique etiology of arrhythmia and dysfunction. Data are still needed to understand the natural history and to identify specific risk factors for patients. But I think it's still up in the air what pharmacotherapy is best, if any. When do you implant an ICD in these patients? And what do you do with the genotype positive, phenotype negative patients? I'm going to leave it.
You had to come back up again.
Greg has mandated that because this is a panel rather than a session, that we can take your questions now.
Just for the audience, you mentioned that they went right to a cardiac MRI, and the number of times I see CBCs on an EKG or a Holter, and I jump to an MRI, I'm assuming they did an echo first or not?
Yes, they did an echo, and it was not particularly revealing.
So the function was down on MRI.
Yeah, it was borderline. It was just, when it comes out at about 55%, and people call it out as low normal. So it wasn't really jumping, nothing was really jumping out on echocardiogram at initial diagnosis.
Thank you. Question in the back, yeah.
Maybe I missed it, but this condition is characterized by cycles of inflammation, and MRI is a good way to detect that with some uncertainty about how and what to do about it, so on. Any thoughts or comments about that in terms of further natural history?
As to the etiology of the?
No. I mean, the DSP cardiomyopathies, they come in with a myocarditis kind of picture, and then there's questions about immunosuppression and if and what and how, and then they go off.
Yeah, this patient in particular had a history, but she never presented with those kind of acute cycles, but I think we have seen those patients. I think.
Yeah, and the LGE on the MRI wasn't particularly compelling for acute
No,
inflammation.
it was, yeah. At the time, I think it was thought to be just her baseline. It was reproducible on future MRIs.
Looks like you had significant trouble with managing
the VT with the medications, right, and the side effects. Did you consider epi-endocardial ablation to modify the substrate at some point? You had findings on your MRI that, and, you know, the voltage map.
The consideration, it had come up on a few occasions, but it was, but the polymorphic nature of this and just the data out there that you get rid of one focus and it's just going to reappear. By the time we thought a little bit more seriously about it, her function had gotten so bad that we knew she was going to get listed anyway. We thought that the potential risk of doing the ablation outweighed the benefits, since we were probably going to end up in the same place.
I mean, what was the VT burden by the end?
35%, but nothing really more than about 6 beats in a row. So there was no sustained VT. I did sports restrict the boys, so just until further notice. I feel like this is an entity that, this situation is uncommon, and these two boys have such a special circumstance that I don't know where this is headed. Right now they're 5 and 7. I think as we learn more and see more, I'm open to changing that, but right now, you know, from what we know about arrhythmogenic cardiomyopathies, probably avoiding vigorous exercise at least might be helpful for them. And I don't know if the vigorous exercise in their sister is what led to the very early presentation, or if it's just that was going to happen to her.
I mean, it's an incredible case. I personally would be putting those boys on flecainide. I would be treating them with Nadolol and flecainide. There's some really beautiful data of Mario Delmars that is emerging, and best in PKP2, but there is a emergence of desmosomal cardiomyopathy where the cellular calcium mishandling starts to mimic CPVT quite a bit, irrespective of where the ectopy is coming out during the stress test. In fact, the desmoplaquins, their ectopy actually is greatest in the recovery phase of the stress test, not during the stress testing. So I suspect it came back. And so we titrate the flecainide to the normalization of the stress test. And this 5 and 7-year-old already has ectopy that you could be using flecainide. We would do cytochrome P450 2D6 genotyping and make sure are they a fast or slow or normal. And then we typically, for CPVT and the desmoplaquins, you get nice ectopy suppression with flecainide in trough levels around 0.4, 0.5, rather than our range in our lab is 0.2 to 1. You don't need to push it to the 0.8 and higher levels. Typically, you get nice ectopy suppression at much lower trough levels. And so that's what our approach is with these desmosomal, where they have ectopy like that.
Yeah, I've seen some of those data. I think for the sister, I guess we'd already missed the opportunity because we did start her on flecainide, and maybe there was marginal improvement, but I think it was too little too late, even with.
And with implanting the ICD, I think I would have probably been tempted to implant the ICD earlier than you did, but obviously it didn't make any difference. But yeah, my threshold for EF with SCAR and with complex arrhythmia and seeing double variants. I would have been putting in that.
So
EF
what would your threshold be then?
I think if you were getting below 50%, yeah,
so the minute they got the MRI, you would have put the ICD in?
So I think the initial MRI, with the complexity of arrhythmia you were starting to see, I think I would probably started the ICD before you hit 30%. So but it made no difference to her clinical course. But I think I would have been implanting it at sort of below 50. But that, I think a double hit like that is really, some of the missense variants, you get a dominant negative truncation.
Right, and I would just agree that our desmoplaquin risk calculator that's online now would agree that she was very high risk a long time ago. But thank you for all your input. We'll wrap that up there, and we'll go on to our next speaker. Thank you. Now we're going to move on to Dr. Frank Zimmerman, who's going to come up and talk about everyone's favorite topic of the sports restriction in arrhythmogenic cardiomyopathy patients. Thanks, Dr. Zimmerman.
Only job up here.
Thanks, Ian. Thank you, guys. Thanks, everyone. This has really been a great conference for me, and I really appreciate all of your insightful comments. I was going to present a case of a 14-year-old boy who initially was detected on a ECG screening exam to have an abnormal EKG. He was completely asymptomatic. You probably have heard this story many times, he was a lacrosse player, a big weight lifter, real healthy looking guy, exercised regularly. This was his EKG on the screening that showed, several abnormalities, low voltages, and the abnormal T waves. So he was kind of flagged as needing further evaluation. His exam was normal. Family history was pretty benign. His echoes just showed some mild RV enlargement. Holter, minimal amount of PVCs that were monomorphic. And ultimately, I'll tell you the story why he came to an EP study, but I just threw it in now. That wasn't like the first thing we did. But ultimately, but it could have, no. He had no inducible EP, VT with programmed stim and high dose isoprel, had some polymorphic, non-sustained stuff. So based on his initial evaluation in EKG, he actually underwent a cardiac MRI, which showed pretty moderate RV enlargement, some hypokinesis, some wall motion abnormalities that was a little bit more suspicious for the diagnosis of arrhythmogenic cardiomyopathy. He also had a reduced RV ejection fraction. So he underwent genetic screening and was found to be positive for the PKP2 pathogenic variant. I don't need to explain this to you guys. Thank you. Okay. So then we went on, we had the genetic diagnosis, and this was just to kind of also confirm kind of like how far along or what was his, phenotype, how severe was it. So we used the task force criterion shown here. And he had essentially 3 majors and a minor, which puts him into like the definite category from a phenotypical standpoint. So he was genotype positive and phenotype positive, although really completely asymptomatic at that time. And of course, the first question on his mind and his family's mind is like, can I continue to play sports? And I think we, all know here how sports interacts with this disease, and especially vigorous endurance activities. And based on the 2019 consensus statement from the HRS is that the individuals with ARVC should not be allowed to participate in competitive activities. And this is kind of what we were counseling the patient at that time. This is a study that came out. So he presented about 8 years ago. So some of these studies have kind of come out since that time, and I thought they're pretty reflective for this kind of scenario. But this was a study looking at exercise dose and the hazard ratio for developing sustained arrhythmias in people with known, phenotypically known ARVC. And as you can see, as you increase the dosage, this is in METs per week, as you increase the dosage of your exercise, your risk goes up accordingly for development of ventricular arrhythmias. So then, of course, the next question is what is this patient's risk for ventricular arrhythmias? Now we've kind of brought in the diagnosis to fruition. What is his risk for ventricular arrhythmias? And so I thought the use of the ARVC risk calculator would be perfect for this patient. According to the international guidelines, a risk of greater than 15% over 5 years usually indicates the recommendation for an ICD. When we plug his numbers in, it's pretty staggering. For a boy that is asymptomatic, really with like very minimal activity on his Holter, his risks 5 years range somewhere between 25 to 44%, which was staggering. So of course, you know, after having this kind of conversation, along with the 2019 guidelines, he kind of fits into a 2A category based on those guidelines, but certainly the risk calculator makes your eyes kind of pop out. So we did go ahead and recommend an ICD. The family's fantastic, and they were all over this, and so he ended up getting a ICD. Unfortunately, he failed like the screening for a subcutaneous ICD, and so he ended up getting just a transvenous typical ICD. Then his next question is, what about my siblings? So I apologize to all the genetic counselors out there, but here's his family tree. He does have, don't kill me about this. So that's why I failed genetics, I think. But he did have two sisters that were genetically found to be gene positive, and then a father, completely asymptomatic. They all went through like an extensive cardiac evaluation. They didn't go through EP studies, but cardiac MRI and all that testing, completely benign. So they are, I think, what you would consider genotype positive, phenotype negative individuals. And so the question is, how do you manage those individuals? And there is some guidance through the 2019 consensus statement, which shows that, which states that clinicians should counsel these individuals to potentially avoid competitive, high-intensity endurance activities. And again, some of this data that I'm showing now came out sort of after we had met this family. But this was one study, I think, that kind of nails that point home, which basically shows that in individuals that are genotype negative or positive but phenotype negative, that the amount of METs, this is METs per year now, the amount of metabolic or activity per year actually could precipitate the clinical diagnosis of ARVC as well as the appearance of ventricular arrhythmias. So in this study, they basically showed that even in those genotype positive, phenotype negative individuals, that sports or vigorous activities could really accelerate this disease. So then the next question would be is like, well, how much can I do? And what's like a safe amount? And when you look at the studies that I've shown you, the safe amount is somewhat between 12.5 to 15 MET hours per week. So let me put that in perspective, and I'm going to show you a little bit about what that week would look like for this individual. So he could wash the dishes, he could mow the lawn, and then on the weekends, he can do a little bit of Wii bowling and light salsa or swing dancing. And I picked pictures with individuals in my age bracket because, you know, like when you're talking to a 16-year-old, they're looking at you like you're crazy. So it's a little tough to have these conversations. I'm looking forward to hearing like what some of your advice would be for these individuals. There is a little bit more, detailed information about sports and metabolic equivalents, and you can give them a little bit more guidance, especially for the athletic individuals, about what or they can and cannot do and how to kind of fit that into their lifestyle. And I'd certainly like to hear more about your opinions on that. So as far as the follow-up, he still remains asymptomatic. This family is like absolutely wonderful. This isn't really a nightmare case. It's actually, they made it so much easier because he did come out of sport. He does a little bit of weightlifting. He's been doing great. He is on metoprolol and lisinopril, and I'll talk a little bit about why, what we should do about that. He does have some more PVCs on his Holter, although really not a lot of sustained arrhythmias, and his RVEF has stayed somewhat stable. And maybe one of the reasons is because he has kind of refrained from sports, and there's some data to show that there could potentially be some remodeling in those patients. But he is starting to show some non-sustained ventricular arrhythmias on his ICD. So the conversations are kind of now basically like, do we have him on the right medications? Clearly, I think that there's some room to make some improvements with the medication choices. And then, you know, again, how do you counsel these families? And the study that I showed you for the genotype positive, phenotype negative patients that do get worse with activity, the part that I didn't show you is that 50% of those patients never progress. So how do you talk to families that are genotype positive, phenotype negative, and say, like, I think you should avoid sports, but you have a 50% chance of being fine, you know? So these are tough conversations. And so I appreciate your time, and I look forward to your advice. Thank you very much.
While we're waiting for questions, you said he screened out of a sub-Q ICD. Had you considered an EV ICD?
Well, this was 8 years ago, so there was just a little thought in your brain at the time.
No. So has anyone put an EV ICD in for an ARVCD? Got a couple people, yeah. And actually, it sounds like the data would suggest that is able to pick up the signal, unlike the sub-Q ICDs where the signal's so small that you're at risk, so.
Hey, Frank, can you show his ECG again?
This is the EKG. Tell the medical students or the fellows, don't miss this EKG because this is...
I put the arrows in.
Thank you. Does that help, Peter, with the arrows?
I mean, it doesn't scream ARVC. It does. This kid, he was 14 at the time, you said? Yeah.
Well, this is a great point that you bring up, is that, you know, you could almost see how this could maybe be missed.
That's right.
Because
that was my
he's
point.
14 years old, and depending on what screening EKG guidelines you're using, sometimes they use the cutoff of 16 years, sometimes 14.
Right.
But if you use the task force criterion, this is 14, and this would be abnormal.
I think when you get V4, V5, I think you have to raise a flag.
100%. I think, did this patient have an echo first and then get an MRI? Yeah?
Yes.
And the echo was abnormal?
The echoes just showed some very mild RV enlargement, but the MRI was really pushed for because of this EKG.
Yeah, right. It's the point is that this is easy to miss on ECG and on echo. So kudos to you guys for digging a little bit deeper and doing an EP study.
Not in that order. Sorry. Yes.
So my question is about the risk calculator, and you know, there's risk calculators for all sorts of different disorders. And as you were kind of reading along, I think many of us were probably kind of mentally assessing what we thought the risk for this kid was for a dangerous arrhythmia. And I don't know about everyone else, but to me that number seemed quite high based on what you told me about the rest of his function and that EKG and, you know, 500 PVCs over 24 hours. And so I pulled it up and started messing around and trying to figure out, is there like one dominant force driving that? And I can't really find one particular one. I don't know if anybody has more experience with the data that goes into this risk strata calculator, and what are the dominant numbers? Because I put a pretty normal 16-year-old kid in with an RVEF of 45% and 500 PVCs, and it's like 20%, which still strikes me as pretty high.
Right. Cindy can definitely comment on this as well, because she's driven many of these. But I think it's definitely being driven by his young age and male gender, which are huge risk factors for fast, dangerous arrhythmias.
And then I should probably answer the question because our team led the derivation and validation, the whole series of studies there. So for real, the risks are high. Certainly, as Brittany says, youth, males, is going to drive it. Those eye-popping numbers are most likely almost like the case that would drive it for a teenager. I would also encourage you guys, particularly in a clinical cardiology setting, to keep in mind that this was derived from cohorts. I mean, it was international cohorts from 18 centers around the world, but these were tertiary cohorts. So I think probably there is an overrepresentation of more severe families, more severe cases. So if anything, I mean, I stand by the science, but it's worth keeping in mind where those cases came from. Does that make sense?
We've got, in the interest of time, we got two more questions. We can do that, but we have got two more questions, and I want to make sure we can have enough time for the last speaker too.
Yeah, so when I was young, I was very cynical about any comment that started with "in my experience," and here I go. But what I would say is there's a number of seasoned clinicians in the room, and I suspect all of them would share that when you face with this kind of patient, I've seen a bunch of patients like this where the proband is often the most athletic person in the family, and that's what brings the issue to light. That might be the case in this situation.
Yes.
And when you meet that person, exercise is definitely an addictive thing. It's not as much as your phone, but it's close for some people. And so what you have to do is you have to ask yourself, how long is it going to take to journey together towards the point of a reasonable exercise recommendation? Because if you come out with this, you'll lose most of them. And for me, I would say the journey's been anywhere from 1 to 5 years.
Great point.
And it's relationship shared decision making based to get there. And any idea to say you have to take your Entresto and you must not exercise will end the relationship.
I think Dominic's going to touch on that in the next talk. I think we had one more question, or?
Well, it's just, so the ECG, I think, screams arrhythmogenic cardiomyopathy, tiny complexes in a highly athletic young boy, no LVH, voltage, whatever, and T-wave inversion everywhere. It screams it. And that's the risk for VT, and the risk lower for sudden death in the calculator, just to give it its fair due. But also what it can't necessarily take into account is when you put in systematic lifestyle adjustments like stopping exercise, it is going to alter the outcomes because these are historical cohorts where you don't have that therapeutic intervention. It's the same problem with any risk calculator. Once you start intervening, the risks and the natural history start changing. And I think we've seen that with long QT and risk calculators as well, that once you're changing the risk, and particularly when it's exercise and changing the natural history, that's going to alter it. And so it may look horrific, and you may not have had therapy for years, or maybe because you're doing the right thing.
Thanks. The next speaker, thank you for those great comments, Dan.
All right, so we're going to continue talking about rhythmogenic cardiomyopathy, and Dr. Dominic Abrams, is going to talk to us about the emerging data and the nice science about differences based on genotype, desmoplakin, and PKP2.
Great, thank you very much, Brittany, and thank you to Greg and to Alice and all the organisers for the very kind invitation. As always, it's an absolute pleasure to be here and be part of this meeting. So this is a really interesting topic I've been given. DSP is not PKP2, and I think it's very timely to discuss that. So this is my disclosures on the left, and on the right was, many of us in the room recently attended this conference in Zurich, which was about arrhythmogenic cardiomyopathy. And I think it's important just to raise this because the theme of that meeting was very genotype based, and the consensus document that is going to come from that is also based on the genetics. So I think it's really timely that we're having this discussion because we need to think about things like plakophilin-2 and PKP2 very differently from how we think about DSP
and other left-sided diseases, and I'm going to hopefully convince you of that in the next 10 or so minutes. So just to start with the basic biology, this is something, a cardiac cell looks a bit like this, maybe not as pretty, but you can see the desmosome up on the top left, which is very important in intercellular mechanical communication and also force transmission. And if we focus on what is actually in the desmosome, there are 5 basic components. There's the cadarins, which join neighboring cells, which are desmoglin 2 and desmocolin 2. And we've got the armadillo proteins, plakoglobin and plakophilin 2, and then the plakin, which joins the intramembrane-bound portion of the desmosome to the intermediate filament, which in the case of the cardiomyocyte is desmin. So we're going to talk about DSP2 and TKP2. As you can see, the proteins that those genes encode are closely bound. They're spatiotemporally related, and but they do produce very, very different phenotypes. But I would argue that we've known about this actually for quite some time, but obviously as experience and the number of individuals identified has increased, that has become more robust. But these are 2 papers that were published in the same month in September 2000. The one on the left was from Naxos. This is the famous paper about Naxos disease. This is caused by a homozygous spliced variant in plakoglobin, and this gives rise to the classic cardiocutaneous syndrome associated with a right dominant ventricular phenotype, so classical ARVC associated with this disorder. On the left is the so-called Carvajal syndrome. Carvajal was a dermatologist in Ecuador, and this was a family that he first identified a few years before. And then David Keltel, who's a colleague of mine in London, did linkage analysis in this family that identified a homozygous 2 base pair deletion in DSP2. So David's a skin biologist and a PhD, and Carvajal's a dermatologist, so the cardiac investigations, you could argue, were a little bit light, and it was 2000 in Ecuador. But if you look at the papers, there's very clearly a left dominant phenotype in these individuals. This was dilated cardiomyopathy, and the arrhythmias that are shown are clearly coming from the left ventricle. So even from the very early genetic description, there was clear differentiation between right ventricular and left ventricular cardiomyopathy. Going forward a few years, this is Brenda Graw's paper in 2004 describing PKP2 as a heterozygous cause, again, of arrhythmogenic right ventricular cardiomyopathy, and that was the term that was uniformly used to describe anything of desmosomal etiology at the time. But there was a paper in 2005 from Mark Norman working with Bill McKenna at George's, where they demonstrated this family where there was a clear left ventricular predominance. You can see the T-wave inversion in the lateral leads. You can see the LGE in the left ventricular basin free wall there. And this was associated with a truncating DSP variant with pretty compelling segregation in this kindred. And so they sort of coined this phrase of left dominant arrhythmogenic cardiomyopathy, saying that actually not everything from the desmosome causes this classical right ventricular disease that we've known about for many years. So when they did a larger paper of their experience in 2007, they divided this into 3 basic groups. There's the classical ARVC, or right ventricular phenotype, and that's associated with the classical T-wave changes in the anterior precordial leads and right ventricular VT. The left dominant arrhythmogenic cardiomyopathy, and then those that affect both ventricles, right and left, are usually in equal proportion, which may evolve from either of the other 2, but may also seem to arise as the sort of first presentation of arrhythmogenic cardiomyopathy. And when we looked at this in 2019, we used those criteria to differentiate the 3 groups and found a reasonably consistent segregation between plakophilin 2 associating with the right ventricle, DSP and other things associating with the left ventricle, and then quite a wide range of different genetic etiologies causing biventricular disease. And obviously, the numbers were relatively small. And since that time, the genotyping has increased substantially. Our experience has grown. And these very large cohorts, and the most recent one, the Desperados cohort led by Alessio and Cindy, has really demonstrated this left dominant phenotype associated with DSP. So when we're thinking about investigations, it's very important to understand what is the phenotype you're looking for if you know the genotype first. And I would argue that plakophilin 2 is very much a disease of the ECG. I was taught many years ago that what you need is a family history and an ECG to diagnose this disease, and I don't think that has really changed much. And you can see from this patient who's now quite a bit older, He's 54. When I met him in 2009, he first presented with this rapid VT when he was 30, but with a relatively normal-looking ECG in 1985, and things evolved to give T-wave inversion, terminal activation delay, and then epsilon waves by 2009, and this much slower VT associated with scar-based reentry, where the earlier VT may be focal and transmit more rapidly across relatively unimpaired myocardium. And again, screening family members, it's very much the Holter that is the key to investigations. This is a 13-year-old girl. She was identified based on family screening from her mother. When we first met her in 2021, she had 323 isolated PVCs. And you could say, well, that falls below the number that we use for minor criteria, which is 500, but you could argue, well, what else actually is it? And then, of course, over the next few years, that ectopy burden and complexity has significantly increased. But really, her resting ECG remains relatively unremarkable. So the Holter is really the key early on, seeing those early ectopy, and is the best case, the best investigation, I believe, that the disease is expressing itself. And I think although we think the MRI is very useful, it's probably relatively late in terms of finding things. By the time you get to this stage where you've got clear disease on the MRI, you can see a very dilated and dysfunctional right ventricle. This patient's got broad T-wave inversion from V1 to V6, and he sort of had relatively advanced biventricular disease. So although the MRI is very useful at this stage, I don't think it's a particularly good screening tool, and the Holter is much, much better. In desmoplakin, we see a very different finding that the MRI is incredibly helpful earlier on. Again, the Holter is very useful. You can start to see the arrhythmias emerge. This is a patient who's now 14 years old. This is the sort of the first Holter that's shown any significant burden of ectopy, but you can see varying morphologies there, and relatively subtle LGE on the MRI. But you have to get the images to really look for it, but it can be there. But the first finding that you will often see is LGE on the MRI, while the ECG can look completely normal, the echo can look completely normal. But that's the thing you want to look for to see that the disease is expressing itself. And then, of course, there's all the cutaneous findings that we commonly see even in heterozygous disease. You also have to look for it. You have to ask for it. You have to get their shoes and socks off and look at their feet. And the parents are looking at you like you've gone absolutely mad. They come to see a cardiologist and you look like a podiatrist. But you really have to look for it. They call it foot eczema. The people will often have pedicures on a regular basis, and they don't really want to talk about it. And again, the hair is very classical for those of us who have it. And it's girls will often straighten their hair. You have to ask, are you a hair straightener? So it's important to ask that as well. But it can be subtle, but it's often there, and the families will often know who's got it. Those who have got, got an established history will know which of the kids have got it and which of them haven't. So look for these non-cardiac signals as well. You will not see that in TKP2. Now, the other things that we've also touched on, inflammation is extremely important. This is a young man who presented at the age of 14. He'd had a week of chest pain and presented with a cardiac arrest in the playground at school. And while he was being transported down to Boston from New Hampshire, had this episode of monomorphic left ventricular VT. He was thought to have had myocarditis. He was discharged. And he came back 5 years later and said, I've got this chest pain again, and I've had it before, and it didn't really go very well last time. I'm coming in. And he was admitted, and that, I kid you not, is his ECG from that night. So he was a very forward-thinking young man. He has actually remained incredibly well since, but again, a classic recurrent pattern of inflammation, troponin release, ECG changes, etc., that we associate now with about 20% of individuals with DSP. And heart failure is also important. This is a 12-year-old girl who presented with very significant left ventricular dysfunction. She's a family member. Her uncle is the proband. Her mother is mildly affected, but she presented with quite significant left ventricular disease and is now listed for transplant. So heart failure, a very important component of left-sided disease as well. And of course, exercise is the question that's already been touched on. We all know the benefits of exercise. I won't go into this in great detail, but they are myriad and sort of a very important aspect of many people's lives, probably significantly exacerbated by COVID. But when we're thinking about right ventricle versus left ventricular disease, we know the right ventricle is relatively susceptible to very intense or prolonged exercise. So these are some studies from a few years ago now where they looked at right ventricular ejection fraction and also troponin release in people performing incredibly intense exercise such as ultra triathlons and cycling through the Alps. And they could see an acute decrease in RV function and troponin release associated with this. And we know there's athletic remodeling associated with the right ventricle in people who undertake endurance sport. So as you can see from Andre Lagersh's editorial there, the right ventricle is the Achilles heel associated with exercise. So therefore, it potentially pertains if you have a genetic predisposition to right ventricular disease. Exercise may be an exacerbating feature for that. I think many good scientific inquiry comes from a quote. This is one of Bill McKenna's quotes back in the day. Ask the people in the waiting room of your ARVC clinic how many people have done a marathon, half the room stands up, and I think there's definitely an element of truth in that. And so, of course, we know now from Cindy's work and many others, the association between arrhythmogenic right ventricular cardiomyopathy and exercise. Obviously, from the previous slide, we can argue that this is an area of weakness in people who exercise because of the hemodynamics that the right ventricle is put under during times of exercise. But what about DSP in the left ventricle? We don't really have that evidence at all. And I would say that actually the people you meet in clinic really are not the exercisers. They're not the marathon runners, the triathletes. And this is some murine work from Ali Marian. Again, it's a mouse model, so it has to be taken in the context of that shows that in mice with DSP knockout, there was actually some upregulation of certain genes during exercise that may be beneficial. But I don't think we're really sort of seeing the pattern that we're seeing associated with PKP2 and exercise that we're seeing in DSP and exercise or with other forms of left-sided disease. So just to summarize, I'm trying to differentiate the two things, PKP2 and DSP. The cardiac phenotype in DSP is very much arrhythmogenic right ventricular cardiomyopathy, and really, when you think about ARVC, you really want to think about PKP2 as the sort of main genetic etiology of that disease. Much more common in men than females, and the penetrance is relatively low. We know from different studies, looking at research databases, et cetera, there are only a relatively small minority of individuals who have PKP2 truncating variants, have actually go on and get the disease. And the question is, why is that? And we really need to study that seemingly unaffected group to understand the disease better. Investigations is ECG and Holter to begin with. Inflammation is rare, no extra cardiac findings. And then for the risk score, using the ARVC risk is much better because that has been very much derived from a population associated with PKP2. And of course, on the right there, you've got the diversity, the difference with DSP. Interestingly, more common in females. The Holter and the MRI are your best investigations early. Think about inflammation, think about the cutaneous features, and now the DSP risk calculator is also out. Well, and again, the sort of influence of exercise remains uncertain in these individuals, but we don't have any evidence at present that it does in fact exacerbate the disease or make it more aggressive early on. Just my acknowledgements, and thank you again for the wonderful invitation. It's a pleasure to be here and look forward to the questions.
I want to thank the presenters before we get done. They did a great job correlating that disease with the patient face. I think that sticks in your mind more than just a bunch of data. So great presentations. I think Charlie's got a question.
Why is there a sex difference in the PKP versus DSP? Is it a difference in the frequency of the mutation, or is it a phenotype frequency difference?
So it's definitely sex-related in the phenotype. They're both autosomal dominant, and so you'd expect equal distribution. Most cardiomyopathies have a male predominance. So it's interesting that DSP is coming out much more on the female side. When we looked at our data between children in the Brigham, 66% were women, and the penetrance was higher in that group as well, which is kind of interesting. It's not entirely clear why that is at present. I'm sure there's an underlying mechanism in terms of biology, but I can't explain what it is. I don't know if anyone else has any thoughts as to what that might be.
So I recently had a kid with recurrent myocarditis in the hospital. Trope leak, chest pain, convinced that I was brilliant, did genetic testing, thinking, of course, we would get a DSP, and there's nothing. Are we missing something? Obviously, is there something else out there? When do I test him again? What would you do?
So they do exist for sure. We're seeing more patients, or I'm assuming there was a cardiomyopathy panel done, Or was it just, okay. Because we've started to see this with filament C now as well, which is kind of interesting, this inflammatory piece. But I guess the question is, if we think that the majority of DSP variants are truncating cause haploinsufficiency, are we missing the intronic ones? So we've got a girl, I could have put my mortgage on the fact she had PKP2, it all came back negative, so we're now doing a genome to see if there's anything intronic. So that would be my obvious thing, but maybe there is. Jeff Sappitz gave us a wonderful talk recently, and he's very interested in sort of this innate cellular immunity that drives the inflammation of these diseases. And yeah, we think about it starting with the desmosome. There's a whole pathway that's involved there. So maybe there's other components of that that we're not yet familiar with that we can test for that are also involved. Another explanation.
Dominic, thanks. And this weaves for all of them because I think it gets back to Frank and Andrew's point. We'll have data that we're presenting next week at American Heart to get at the question of this sport. So some will probably be shocked that we stopped disqualifying athletes with ACM about a decade ago in our program and started looking at them. So we're reporting our first 68 athletes out of our 800 athletes. And because what we need to know, because the data from Hopkins and Cindy is beautiful, we know, I think everybody can now say certain kind of sports training is a disease accelerator to certain kind of genotypes, particularly PKP2. But like you said, that may not be a one size fits all. So now you and I get the patient, Frank, you got the patient, and they were DSP positive or they were PKP positive and their tests are all normal. Do we give them a METS prescription? We've never mentioned METS to any of our patients ever because it translates not at all to real kids doing real things. So we just let them do their thing, whatever their sports is. We try to steer them away from endurance training for our PKP2 athletes. And so at least we're now going to start having data so we can show that in about 4 years, 4.5, 5 years of follow-up, the majority don't convert during that time span. So 80% still are phenotype negative. So those who convert, when you convert, you can really convert. And so of our 20% who are 12.5% converted, of those, 40% went to transplant. But this is what we need, is we need actually data to guide them rather than saying at age 12, we're going to shut you down. Because the community of ARVC families over there next door, they're catching on, and many of them are saying, so you mean if my genetic test comes back positive, you're going to shut me down, even if all my tests are normal? I got a good idea. I won't get the variant test anymore. I'll just come in annually for my surveillance test, and if all my tests are still normal, then I'm good to go because you don't know whether I have it or not. And I think we need to bring the community back to say we're actually working together because many of them have, I don't know how many, what percent are choosing that strategy, maybe you guys know, but it feels like a high percentage because almost all the families I see, they haven't been variant tested yet because they don't want to be tested. We work with them and then they all get tested and we say, you know, you're not being disqualified. It's just a fascinating area, but I'm curious if you're doing a similar approach of patient empowerment, if you're still more in the lockdown or what's your...
So we're fairly along your lines, certainly the ones who are unaffected. I do feel the halters are really good. You know, if you've got a completely clean halter, I'm pretty happy for them to continue. And I think, as I say to them, PKP2 to me is a fascinating disease because 1 in 1,000 of us have a truncating change in PKP2. It's not that uncommon. And yet what we see is a small minority of these individuals. So we really need to understand the population at large, and everyone's discussed this. But those are the people we really want to see, is the people who are unaffected. And what have you done? What haven't you done? You could spin it on its head and say, well, is there something in the right ventricle in people with plakophilin-2 variants that actually changes the right ventricle and actually makes them better at exercise? Therefore, they are naturally drawn into exercise because they're good at it, rather than because, so are we loading that end of the spectrum with athletes because they're good at it? And I've had this conversation with Arthur, and they've had similar thinking in Holland. So I think it's just really interesting as to what does that ventricle do, how does it perform, and is that why there's an imbalance? But certainly, as you say, there's an aggressive acceleration for some of them. And how this inflammation at a cellular level plays into it as well is really interesting, and Jeff's done a lot of work on that as well. So I totally agree with you. We understand a bit of it, but there's a lot of it as well that we don't understand, but that's a great thing for everyone to work on collectively and understand it together with the family.
I'll just throw in there as well, you mentioned that same topic in Zurich, Mike, and it's interesting because I don't see that in my clinic. I very rarely, if ever, have families declining variant testing or not uptaking it. And I think it's really what Andrew has been talking about, that, and I get back to in my clinic every day, exercise restriction is not what we're doing, and not all exercise is created equal. So it's a shared decision-making conversation about what exercise you want to do. What is it? Are you wanting to train for the New York Marathon? Well, we have a lot of data that endurance exercise like that is bad. Is it your high school baseball team? Well, you know, one of the jokes I have is that baseball players stand around the outfield a lot and don't do much. So it's a lot of that back and forth. And I find that if you have the expertise like you have, like we have in our clinic, families really get it and they get on board. So
yeah, I think a lot of them will, as you know, automatically decide themselves. And I do vividly remember 2 kids. It was long QT, not ARVC, but the kid who didn't have it was devastated that his brother didn't have to exercise anymore. This was a long time ago, because they didn't like exercise at all, and he didn't have an excuse to miss the cross country at school. So, but I do think, you know, families will, to some degree, as you say, self-select. So it's about finding the right prescription for all, but it's a great question.
Fascinating. I think we're just about done. Just one quick question. With all the data that's coming out, and I love the fact that, Mike, you want to change the guidelines in some sense, and that's what we've been doing with hypertrophic cardiomyopathy, long QT syndrome. But as we change these guidelines, how often do we update these risk calculators? Because there's great data coming out, and can we start individualizing these risk calculators a little more based upon the DSP versus plakophilin versus, you know, obviously TM, the transmembrane is a big risk factor, right? And so when are we going to get this updated? And we thank you for it. I think that'll wrap up the session. Thank you, guys.
How are you? How are you doing? I'm good. All right, everybody. We'll take another 5 minutes and we'll get the last session up and going at 3:30 in an attempt to keep everybody on time at the end of the day. Thank you all.
Just replacing some batteries.
Okay. I think we're ready. I mean, I think we're good.
I think, yeah, this is the other room.
Oh, okay. I don't think so. I got everything.
Is there a pointer function with like the laser? We use the laser pointer as part of PowerPoint.
Oh,
Is that working?
Yeah, it is right here. And then there. And then if you just click on the laser pointer,
It's usually down below.
where?
Yeah, it's not showing up. It's usually at light. Yeah, it's not showing up. There it is. There. Oh, it was there.
Yeah, it's gonna, let's see, because they launched it with Zoom, so it's just giving me a
there you go.
There it is, yeah, laser pointer, right.
And then I
Right.
think you need to turn it off to advance your slide to the next, or maybe not. Okay, there you go.
Keyboard.
Awesome.
But yeah, Elijah will give the first talk, of course. Are the slides all in one PowerPoint?
No, they're all,
Or just separate?
yeah, if you, yeah, so then, Eliza, George, Khan, Beach,
Okay.
in order.
Probably can figure it out.
You emailed me. Yeah. So, yeah, I have your latest presentation in there. I sent you, like.
Yeah.
Sorry.
Yeah, no, it's okay.
It'll take a while to get them to reset. To be expected.
It's not, yeah, I'm surprised that they got them in that early, right?
No, yeah, it was a cool meeting. It really was. I noticed early on, people were looking at questions from online. Is this a way to look at that, or it might not really happen in that school? Great. Oh, I agree. Oh, good. Yeah. The answer is, we're not responsible for that. No, he will, if there's questions that come in the chat, he'll let you guys know that directions are yours. Sounds good. Thank you.
Bring it home. I would be, yeah, I won't post it out. But if they do, I'll
Excuse me?
Here we go. Let me just quickly see if I can. There we go. It should go away now. Let's see if it does. There you go. It's gone.
It's gone. It's gone. We want to get rid of the taskbar. Do you want to stay here, wait here? Do you want to call me up, or should I wait?
You can say it.
Be faster.
Studies done, and now there's like 4 more projects planned, so that would be, I mean, I'm sure, based on our experience with other nuclear investigators, we're gonna have to execute a reassuring agreement, and that's gonna be started sooner rather than later.
Yeah, we've got them used, unfortunately, to, we've set up a biobank facilitator. So if we just wanted data, actually we can issue our own.
All right, I'm going to start bringing people into the room. This is our last session, so we can hopefully allow people to get over to the reception as well. Before our last session, I'm just going to say a couple of quick things as a reminder. One is if you did drive and you needed parking, there are parking vouchers out on the table, so feel free to pick it up. As I said at the beginning, you do not want to go scan your parking without a parking voucher alongside it. Number 2, after this talk, I'm going to kind of do a brief sum up, or after this session, I'm going to do a brief sum up, but I do know that people start to kind of meander out, and so I will say that after this, we do have Thrive Therapeutics sponsoring a reception, and everybody who's here at the conference is more than welcome to join us afterwards. That'll be immediately to follow this. I will kind of give a wrap up at the end, but I just want to thank everybody for being here and for filling the room, and for everyone online who have stayed and been at your computers listening to this. Thank you all for joining us, and I'll say it one more time at the end, but I'll hand things over. Thank you.
Hello all. Hello all. Hello. Hi, I'm Cindy James again, and I would like to welcome back our keynote speaker, Elijah Bear, who will talk to us about Brugada syndrome from fetal to 50.
Thanks, Cindy, and really enjoying the meeting, the quality of the talks, and all the toing and froing. And I'm sorry that I've been as vocal as I have been, but you're going to have to listen to me again for a bit longer. So Brugada from fetal to 50. So this is going to be a bit of a story about maybe the life course of it, trying to refer mainly to the pediatric aspects of it, given that the audience here is mainly pediatric. So not necessarily going to be about single gene disorders, as the title alludes to. I mean, Brugada we thought of as a primary electrical disorder, but those of you who know me will know that I don't believe that, and that it's got a subtle structural substrate underlying it. But we still know of it as a ECG diagnosis with this characteristic type 1 pattern that's persistent, transient, or provoked. The genetic associations are about 1 in 5 probands will have a likely pathogenic variant in SCN5A, although that's not always required, because we know that common genetic variation is incredibly important to the Brugada phenotype, and polygenic risk scores underlie the condition with or without a sodium channel variant, and also probably mediates penetrance and also drug provocation effects. So quite a complex genetic disorder. I'm going to briefly talk about diagnosis before we launch in, because it's something critical I think we need to really get to grips with, and will cause maybe more consternation from Andrew once I touch on it. But the ESC guidelines have recommended, as do the other international consensus documents, that if you see a spontaneous type 1 pattern, that it's Brugada syndrome. So we've been using drug provocation, and this is the Ashmolean test I showed you before, the sodium channel blocker test, that it's positive. But we know that in individuals with AVNRT, that there's a high rate of Ashmolean positivity, and even in healthy controls, in this particular Turkish population, these were actually just convenient people who came from the university, who had agreed to have it done in the university in Istanbul that Can has Demir around the project from. They all have their positive responses way and above the level of Brugada syndrome in the general population. And this Israeli study from Sami Viskin and colleagues showing that emergency department attendees with fever were much more likely than those without fever to show a type 1 pattern to the level of around 2%, which, again, is not consistent with the type 1 pattern being Brugada syndrome at all times without provocation. And we've recently published earlier this year a clinical trial in healthy subjects who underwent Ashmolean provocation testing. And these healthy subjects had I think I mentioned to you already, 3-generation family history clear of sudden death, normal ECG, normal echo, normal 12-lead Holter, normal MRI. We went through the full gamut of them. And they had type 1 patterns in 3 of them with sodium channel provocation. So these earlier data prompted the Shanghai consensus to define a point scoring system for Brugada syndrome. And you'll notice here that fever and drug induction of the type 1 pattern were given lower points than the 3.5 to actually score definite Brugada syndrome. I think they should probably be slightly lower on the fever as well as the sodium channel blocker challenge. And there are other factors that came in to this whole point scoring system, including the background clinical history and the family history. And indeed, you could also add in a small SCN5A variant half point as well for this scoring system. What we did in the ESC document is not to counter that, but on the basis that that was still a consensus statement with no actual data behind it, solid data behind it to back it up, and that it would evolve over time, we preferred to be a little bit more generic and downgrade the strength of the sodium channel blocker challenge-induced type 1 pattern as being significant, unless there were these associated other findings, and if not, then you may consider a type 1 pattern to be Brugada syndrome, but really trying to lower the threshold, and there's actually a consensus statement that should be coming out next year to give greater guidance about sodium channel blocker provocation testing that should be sponsored by all the societies, including HRS. In terms of prognosis across the population, the finger study data still probably holds to some extent, in that we know that asymptomatic carry the lowest risk. Those with syncope carry intermediate risk sufficient to consider ICD, and those who had resuscitated sudden death have the highest risk. And the ECG appearance, the type 1 pattern, drug-induced carries lower risk, asymptomatic the lowest risk. Spontaneous has higher risk, and if asymptomatic, a borderline risk. Is that really suitable for ICD or not? What about pediatric risk, though? Because the finger study was not based on young patients, on children. It was based on predominantly on adult patients having follow-up subsequently. These are data that came out from the Nantes group with a multi-center study, and showing that pediatric risk in particular was associated, like in the finger study, with syncope and with the type 1 pattern. And if you had both, you were at the highest risk possible. So the factors that are present in adults are also present in children in terms of risk. There was also more SCN5A-related disease and greater risk associated with that in the pediatric population of this initial study, and quinidine usage appeared to be useful, or hydroquinidine in the French experience particularly, appeared to be useful in mitigating risk. We've seen this diagram before from the earlier study, and that we had that high level of Brugada syndrome yield amongst unexpected sudden deaths when you investigate family members. But I wanted to just prompt you that you may think that's unbelievable yield in the pediatric group, but that's proportional, and that the absolute numbers at risk are still low because of what I showed you earlier as well, that the pediatric population in relation to the young adolescent and young adult population is still going to be at lower risk in general. So the actual absolute numbers of Brugada syndrome, young patients dying suddenly, is actually still low. It's just proportionately, we may be not recognizing the Brugada syndrome contributes. But from that study as well, what we did notice was that the younger the age of the decedent, the less strong the Shanghai score was in that decedent's first relative, the one that had the greatest indication of Brugada syndrome in their evaluation, which suggested to me that actually it was the young person that was presenting the strong proband, and that you don't actually necessarily have that much heritable risk, polygenic heritable risk in the parents. It's combined in those children for that significant risk. So children are a little bit of a challenge in trying to understand their risk with Brugada syndrome. And there have been some insights about risk in children from the Sabra survey. This is led by Anat Millman and Bernard Balhassan in Israel as well. They took data from multiple centers. I think it was around 40 or 50 centers in total, either aborted cardiac arrest or patients with ICD implants in for primary prevention that then had a first arrhythmic event. Sorry, it was 23 centers, apologies. 678 probands, of which the majority were male. They looked at the age at first arrhythmic event, and the Sabras patients were compared to a Brugada syndrome registry from about half of those major centers where they had large numbers of patients, and you'll see the age distribution of those with their first arrhythmic event compared to the registry is actually very similar, a very similar distribution. There are not a lot more young people presenting with arrhythmic events. They're similar to the general population distribution of Brugada syndrome in these registries, with the same peak in the middle. The age alone is not a predictive risk in a Brugada referral population. What about gender? So age is normally distributed in males. Those are the purple blocks over there. But in females, the distribution is bimodal. So in fact, female children seem to be at higher risk than male children, and elderly female individuals are at higher risk than elderly males, which is an interesting thing to think about when we consider the hormonal influences on risk in Brugada syndrome and the effect on sodium channel function. And in terms of other features of risk and gender and age, we seem to see that females have less type 1 Brugada patterns and less inducibility at EP study, yet still go on to have arrhythmic events. And so risk stratification in females needs to be different, and risk stratifications in children needs to be different. And also with ethnicity. Asian patients, usually more male adults. I don't know why it's going on by itself, but anyway, it's deciding to do that. Usually male adult patients, less pediatric patients in the Asian population. It really focuses on male adults, which I think is also typical of the presentations in Southeast Asia, and more often with aborted cardiac arrest and a spontaneous type 1 pattern in the male patients. And the intriguing aspect is also fever as well. Fever as a precipitating factor is much more common amongst children than amongst adults, and slightly more so amongst females than males, but these are very small numbers, so I wouldn't necessarily read that much more into this when you come. It's not that granular. The data, they're not that granular, these data. There's some very interesting pediatric differences as well. And if we look at a large French referral population with the age of diagnosis, here they have a cohort of 1,600 patients, the largest probably in the world. The majority male, the mean age 45, but here the 1 to 17 age group is obviously small, 52 patients, a third with a type 1 pattern, much like the adult group, but there were slightly more females than in the older adult group. More were diagnosed by family screening, as you would expect. More, however, presented with sudden cardiac arrest. There were also not only family screening patients in there, there were also those presenting with severe presentations of Brugada syndrome, more so than in the adult population, a much higher yield of SCN5A disease beyond even just from the family screening perspective you would expect in terms of predictive cascade testing in these children. And consequent to that, I think an association of that, more sinus node dysfunction. And they actually found a greater risk amongst children compared to, in follow-up compared to adults. Looking at this survival curve over 5 years, you could see a much more rapid recurrence of events, about a 2% event rate in the population compared to about 1% in the older groups. So in their experience, children were just not all at low risk as we may sometimes be lulled into thinking about Brugada syndrome in a pediatric setting. So in conclusion, Brugada syndrome relies upon the type 1 pattern. The provoked pattern alone does not mean Brugada syndrome. Risk really relies upon the presence of the type 1 pattern and syncope. And while childhood Brugada syndrome is rarer, its risk is not therefore lower. This may be related, as I said, to severe symptomatic presentation in probands, pediatric probands, a greater SCN5A burden in the pediatric setting, and a greater fever sensitivity as well. And so there's a focus really for pediatric patients on fever management, and maybe a low threshold for considering quinidine or hydroquinidine in order to prevent needing to leap to a defibrillator or to ablation therapy at a young age. And so I think we do really need specific age, gender, risk strategies that are appropriate to these patients. Thank you.
I think we're going to ask Cindy if I could introduce the next speaker, Al George. All know Al George as the current chair of pharmacology here at Northwestern. I knew him back in his Vanderbilt days when he was on my mentoring committee. And Al is a true ion channel scientist. He was actually the first person to sequence the gene we now call SCN5A. I think he tried to call it HH1, but that name didn't fly for some reason. He was also the person that first discovered the molecular mechanism of long QT3 being increased late sodium currents. So he's He's done a lot of legendary things, and so it's truly an honor to hear him talk about the many faces of SCN5A channelopathy.
Thank you, Prince. Very generous of you to say those kind words, and thank you for the organizers to invite me to walk across the street to Lurie Children's Hospital. I will need parking validation, sorry. Anyway, many faces of SCN5A channelopathy is the way I refer to it. I think this is an homage to faces meaning phenotypes, and as you'll see, as I'll cover briefly, is SCN5A is one of the more important congenital arrhythmia susceptibility genes, and it's responsible for really a dizzying array of different phenotypes that have over the years garnered different names. And so I'm going to start by just some disclosures. Most of these disclosures relate to our work on congenital brain diseases. But anyway, SCN5A is the cardiac voltage-gated sodium channel. It goes by the name NAV 1.5 or NAV 1.5. That's terminology I had nothing to do with. It's on the short arm of chromosome 3. It's made up of multiple exons. There's some alternative exons that are developmentally regulated, and the channel, the protein encodes a voltage-gated sodium permeating ion channel, and it's mainly the main subunit, the pore-forming subunit that we're talking about. And there's a number of structural features of this, and now we even have a three-dimensional atomic level resolution of the channel, thanks to the late, great Bill Catterall's work and others. There's a number of congenital and later onset phenotypes that I will just summarize in a couple of slides. Many of those phenotypes are associated with ventricular arrhythmia susceptibility and sudden cardiac death. The most well-studied are the congenital long QT syndrome type 3, which is probably about 10% or so of all long QT syndromes. Brugada syndrome, which we just heard about. There are cases of idiopathic ventricular fibrillation that can't be described cleanly as Brugada syndrome. There's also something referred to as sudden unexplained nocturnal death syndrome that's been described in South Asian males. And then we heard again this morning by Elijah during grand rounds, the sudden infant death syndrome or sudden unexplained death in infancy. Those have all been associated with pathogenic variants in SCN5A. So ventricular arrhythmias is one broad phenotype with multiple independent diagnostic categories. There are also individuals who simply have impaired cardiac conduction. One of the earliest designations of this was referred to as progressive cardiac conduction system disease, because as these individuals aged, the conduction system impairment got worse and worse. There are also familial cases of atrial ventricular block, which can be as severe as atrial standstill. And then many years ago, Woody Benson brought to my attention families that had what he called congenital sick sinus syndrome. Those turned out to be SCN5A channelopathies as well. So ventricular arrhythmias, impaired cardiac conduction are two of the broad categories associated with this gene. But there are others that have permeated the literature. Importantly, some individuals show features of more than one arrhythmia type. So there are overlap syndromes where individuals have long QT syndrome and Brugada syndrome together. It's always been confusing to me how you can have both, but they're well described. There are individuals who have conduction system disease overlaying one of the other phenotypes. So those are very well described and not particularly common. There's been a lot of interest in SCN5A as a gene for dilated cardiomyopathy. This began with some case reports and descriptions of some families who were segregating an SCN5A variant associated with multiple arrhythmia syndromes, atrial fibrillation, atrial tachycardia, ventricular arrhythmias, with eventual emergence of a cardiomyopathy. In some cases, those individuals were found to have a very heavy burden of premature ventricular contractions. And so a term involved called multifocal ectopic Purkinje-related premature contraction syndrome And those are probably related disorders. I'll show you a little more on the next slide. Atrial fibrillation has been tenuously associated with SCN5A. I think there's some debate about whether it's legitimate. And then very rarely, and also probably disputed, are cases of right ventricular cardiomyopathy. Now, draw your attention to these two forms of SCN5A channelopathy, dilated cardiomyopathy with arrhythmias, or this multifocal premature contraction syndrome. These two syndromes have gone by many names in the literature, and it's still a little bit fuzzy as to whether these are all the same thing or really a spectrum. But early reports of dilated cardiomyopathy with multiple arrhythmia phenotypes was described. There are some rare cases of peripartum cardiomyopathy that have been associated with SCN5A. And these are some other terms that, again, have been associated with this. And this last term, I think, is really the one that has stuck, which is MEP-PC. And I'll say a little more about that near the end in terms of how it's mechanistically perhaps different from the other phenotypes. So anyway, there you have it. You got a lot of faces of this one gene that can give rise to multiple phenotypes. This is just a sort of an illustration of this MEP-PC phenotype. This is a large family that was described, a series of French families that have the very heavy burden of premature ventricular contractions, and in some cases that leads to impaired cardiac contractility, which is reversible when you treat them with quinidine and potentially other antiarrhythmic drugs that could block the sodium channel. And I'll say maybe a little more about that later. So why is there such diverse phenotypes with this one gene? Well, I think there's a number of answers. One is the genetics, potentially. There's just some evidence just from the inheritance of the disease. Many of these phenotypes show, or some of these phenotypes, like long QT syndrome and some of the conduction system disorders, have clear autosomal dominant inheritance with some reasonably high penetrance. Others are autosomal dominant with incomplete penetrance. We heard about Brugada syndrome. MEP-PC is somewhat incomplete in that people have variable expression. It's not just incomplete penetrance, it's variable expressivity of the phenotype. There are also rare cases of autosomal recessive inheritance, where the heterozygous carriers of the variants are healthy without any detectable or overt cardiac signs, but the individuals who inherit homozygous or sometimes compound heterozygous mutations have severe conduction system disease. And this has been described, as I mentioned before, in a paper I did with Woody Benson many years ago as what we call congenital sick sinus syndrome. And others have very severe conduction system disease. And then lastly, there are a number of very well-established phenotypes associated with de novo mutations, particularly the very severe forms of long QT syndrome type 3 that appear in neonates and even perinatal SIDS and sudden unexplained death in infancy, and potentially others. And so I think there's some there's inheritable variability, and so that may explain some of the variation in the phenotype, but doesn't explain everything. Allelic heterogeneity is probably a lot to do with it. This is just some old maps of where the mutations are located in the sodium channel based on the phenotype, and it doesn't explain everything. The location of the mutation probably doesn't correlate very well with phenotype, but the fact that there are so many mutations located in different structural domains and functional domains of the sodium channel is a clue to that. Also, the type of mutation. Some mutations are truncating, leading to incomplete production of the protein, which would be equivalent to a complete loss of function. Others are missense variants, which could have variable functional effects. In ClinVar, we still are dealing with this large burden of variants of unknown significance, despite the fact that there's been a lot of effort to try to understand how to classify those variants in this channel. Another reason for the variable phenotype, which is probably as important as anything else, is the mechanism by which the sodium channel mutations affect the function of the channel. For years, we've understood that long QT syndrome is largely a defect affecting the inactivation gating of the channel. So normally sodium channels open and close rapidly, but in long QT syndrome 3, they have incomplete inactivation leading to late sodium current flowing at a time during the action potential when normally it should be quiescent. This leads to broadening of the action potential and impaired repolarization. Brugada syndrome is a loss of function disease. In most cases, this results in impaired conduction velocity, primarily in the right ventricular outflow tract. Conduction system disease, similarly, is due to lower sodium current, or lower sodium conductance by the channel, also leading to impaired conduction, but probably more widely affecting the heart. And then this unusual syndrome of multifocal Purkinje-related premature contractions has a different form of abnormal conduction. Instead of abnormalities affecting the canonical sodium pathway in the cell, the so-called pore domain or permeation pathway, these mutations seem to affect sodium or other ions flowing through the channel through an aberrant pathway that we call gating port current. And at the end of the day, there's been a lot of popularization of this spectrum between gain of function and loss of function. Loss of function, Brugada syndrome, conduction system disease, and gain of function, long QT syndrome, and this MEPPC phenotype. I always think that these are gross oversimplifications. Sodium channels and other ion channels have very unique and complicated functional properties, but these have been useful over time. And I think as we learn more and we study more, we realize there's probably some mixtures of gain and loss of function in many of these channel variants, and which one predominates to drive the phenotype is still, I think, an ongoing quest. Sodium channels open and close in response to depolarization, and we call the first phase of opening activation and the second phase inactivation. It's really the inactivation phase that's drawn a lot of attention from those of us who study channel biology, and really we've known for many years that long QT syndrome is largely due to abnormal inactivation of the channel, either subtle defects that lead to a persistence of the sodium current that leads to a persistent inward sodium movement, persistent depolarization of the myocyte, and a prolonged QT interval, a prolonged delayed or impaired repolarization in a prolonged QT interval. And this can be even very severe in some cases of neonatal onset long QT syndrome, where you have this really profound impairment of inactivation that can really be deleterious to a functioning myocyte. And then lastly, this unusual syndrome that has been labeled by multiple terms, arrhythmia with dilated cardiomyopathy, multifocal Purkinje-related premature contraction syndrome. This is a syndrome in which there's evidence now that the defect is not a defect in canonical sodium channel function, where sodium permeates the main ion pathway in the channel, but rather there's an aberrant voltage sensing domain that opens up a new pathway for ions to flow, and not necessarily sodium. It could be hydrogen ions and other ions that can flow into the cell through this aberrant pathway, and that leads to a depolarization of the myocyte in an aberrant way that is distinct from what we see in long QT syndrome. And this may lead to a disturbance in ion homeostasis in the cardiomyocyte that could lead to alterations in internal pH, altered balance in calcium, and disturbances that may impair contractility and lead to the arrhythmia phenotype. So a very unique aspect. So anyway, just summarizing the many faces or the many phenotypes associated with SCN5A, certainly a wide range of clinical phenotypes ranging from ventricular arrhythmias to atrial arrhythmias, impaired conduction, maybe impaired contractility. The phenotype diversity is probably due to a mixture of various genetic mechanisms, allelic heterogeneity, and probably the pathophysiological mechanism that underlies that. Underlying all of those things could be differences in genetic background, which we haven't explored, and it's one of the more challenging things to explore in human genetics. So with that, I will thank you very much for your attention.
Next, I'd like to welcome Andrew Cron to the podium to tell us about calcium release deficiency, the new kid on the block. Andrew is the recent past president of HRS.
Good afternoon. Good afternoon. Much better. Okay. So it's interesting. This has been a spectacular day. I have learned a lot. I feel like a physical giant in the context of a room full of intellectual giants. I realize I stand between you and alcohol, which is a dangerous place to be. Why am I looking at Susan? Yeah, okay. So I've changed my approach to giving talks. And so Elijah will laugh at this because I explained this once before. But what I used to do is I used to give, summary of the literature. Here's the recommendations, distill things for you. Here's the topic type of thing. 2 years ago came the sort of pedestrian use of large language models and ChatGPT. And so then when you said, give me a talk on this topic, I'd put that topic in and say, what are the top 5 considerations, recommendations that the audience needs to know? And the first one I did is something that's a pet peeve of mine, which is unexplained cardiac arrest and the evaluation and management of patients with unexplained cardiac arrest, at which point I almost submitted for retirement. It absolutely nailed it with 16 points, including multidisciplinary care, revisiting variants, conducting comprehensive genetic testing, thorough family evaluation, frequency of phenotype review, and so on. I was like, oh my. And then I put in another topic and it was sort of okay. And so then what I said is, okay, what I'm not going to do anymore is tell you what ChatGPT can tell you, because it can do all of this very well, not always, but generally. And so then I went through that exercise again for this talk. And then when I did this, ChatGPT basically said, no clue. Okay? And the reason is because of its recency. Okay, and that's one of the reasons I'm standing up here in front of you is the recency aspect of it. So anyway, so that's the background to this. So I'm looking for a different presentation on the taskbar. Okay, now you're talking to a Mac user. Okay. So one of the things that we do in Canada is something called the land acknowledgement, where we acknowledge that the land on which we live and meet and play and work was one that was, if you like, taken over or was originally inhabited by our Indigenous peoples. So one of the things I do in HERO, our Canadian Cardiogenetics Network, is I advocate for a family acknowledgement, where I say we start all our meetings to say, remember, we are here for patients and their families. Full stop, all of us. We're not here for that reason. Go drink now. Okay. So that I consider that actually part of the declaration of conflict of interest, is to declare what your interests are, not just your conflicts are. Okay, so here I think is a very interesting case. I got this from somebody I work with, and so this is a young guy who comes in and he has worrisome arrhythmic sounding presyncope. And he has a sibling with sudden death, and he has an aunt with sudden death, and he has a normal investigations, normal Holter, normal imaging and everything, but worrisome sounding event. And because of the family history, then he gets referred, and then but while he's awaiting evaluation by us and so on, he then has a loop recorder put in, and then has this recorded. Okay, so for people who look at EKGs all the time, you're absolutely fascinated. Elijah's all excited about the ST elevation, Mike's all excited about the QT prolongation, Susan's all excited about the whole constellation of things. Something's going on, right? Okay, and for the geneticists, I'll come back to what's so cool about this. Okay, don't forget about this case because it's teaching us something already. Okay, so this is just to give you an example. So the playground we're in is the Mendelian playground. Okay, good old half the people are affected kind of thing. Looks like an autosomal dominant Mendelian kind of family tree. So what am I doing wrong?
Nothing. I'm just thinking of a bar for you.
Okay, I thought they wanted to go to the bar.
Believe me, you won't miss when they go to the bar.
Okay. So, and even more simplified than what Al George said, I wanted to show this as an illustration of how to get your head around this. So at the top here, so this is Goldilocks, right? So I always, when I give talks to the public, I say, our channels are meant to be in balance. They're not too hot or not too cold. It's If it's overdoing it or underdoing it, it usually shows up as some kind of disease. And so what we probably are familiar with is what Al George just gave a beautiful summary of, which is that the sodium channel can be either gain or loss of function. And then as a result, you get what you see here, which is you get either Brugada on the loss of function, or you get long QT3 on the gain of function. So in the calcium business, okay, we all know that CPVT is, if you like, too much calcium, right? You have actually failure of reuptake, but it's too much calcium. So it's functionally a gain of function variant. And the question is, where's the loss of function variant? And that's in today's CRDS, okay? So the heritage to this starts with this guy. So I was on a translational grant panel in Canada, this is about probably 22 years ago. And this is Wayne Chen from Calgary. He has to be credited with a lot of the foundational work around this. And so this is our version of the NIH grant panel, where they had clinicians like me, and then they had basic science people like Wayne. And so we were sort of sitting together and shooting the breeze at dinner and stuff like this. And then he said to me, Andrew, you seem like the kind of person interested in calcium. And I said, well, this is when CPVT was pretty new. And I said, well, I think it's all very cool, but I don't understand too much about it. 3 hours later, I said, Wayne, I have to go to bed. Okay, so he's been obsessed with calcium all his life. And then he emails me on the way home, and he says, I gave you some light reading, just a sort of Calcium for Dummies briefing, which was a JPhys 84-page PDF. Okay, but one of the things I asked him over dinner is I said, you know, this whole new story of CPVT and calcium overload and so on, what happens when it's the other way around? And he goes, good question, I don't know. So then, in 2007, he then describes this, where there is this loss of function in RYR2, okay? And this is just sort of the beginning of the story. And so here's what you need to know. So these are the take-home messages. So the first is, this is a new syndrome. It's a risk of malignant ventricular arrhythmias. Those pedigrees, what they look like is they look like familial cardiac arrest and sudden death. It's, again, a loss of function, okay? And this is, if you like, concealed, because just like CPVT, there's no resting ECG abnormality, okay? For people taking notes, I give away slides, and at the end, you'll get my email address in case you want the stuff. No problem. I'm an open access person. And one of the reasons is it's very rare. Best I can tell, we've got more than 800 unexplained cardiac arrests in our national registry, and we have exome sequencing on about 500 of those, and probably 2 or 3 of those will turn out to be CRDS. So this is one of the reasons it's hard to discover, even though mechanistically you'd think we'd been looking for it for a long time. Okay, and then the other thing is, there may be, because it's so rare, it's not very thoroughly, and I'll show you a bit of data, but it's not very thoroughly characterized. There may be some fibrosis, there may be some seizures, there may be other organ systems and so on. But because of its rarity, we're really sort of compiling what it should look like in terms of phenotype. Okay, and it looks like, at least, even though you'd think, you know, we'd be throwing beta blockers at RYR2 variants, that beta blockers don't seem to have an effect, and maybe sodium channel blockers or complex drugs like quinidine and flecainide may be beneficial. So a little bit of credit to some of the people involved, because I realize I don't have too much time. So these are a couple of the sort of foundational papers in this area. So one of them is just this idea of introducing the idea of Mendelian inheritance. Okay, and this is 3 different families in one of those index ones. And when you look through the list of the number of patients, subjects, family members, and so on, what you see is that the asymptomatic people and the symptomatic people are different characteristics. It's a little small and hard to see, and my mouse sort of works down here. Okay. But the total N, look at this, total N is like 45. This is pretty new and pretty vaguely described. So this is Thomas Roston, who's the future of, or one of the stars in the future of our field, which appears to be in very good hands based on today's presentation. And Thomas' last paper in this area in JAMA Cardiology is basically compiling the international pediatric and adult CPVT registry, and then other large-scale cardiogenetic registries and so on, and trying to find these patients and the variants that are culprits for them, okay? And what you see in here is then, if we do what Al George does so well, which is look at expression, what you see here is, if you look on the left here, this is in terms of if you like, the calcium specific. On the left, you see the yellow ones, which are certain variants that seem to have one effect, and on the right, the blue ones, okay? So we've sort of polarized the gain and loss of function concepts. And I'm trying to keep this simple. There's a lot more to be read. So when you do a functional test and you try to provoke a phenotype, because you remember their ECGs are apparently normal, when you do a functional test like this in CPVT, exercise testing is a good but not a perfect test in that context. It often at least gives you some clues, okay? In CRDS, nada, nothing. Okay, it's not a particularly exertional thing. The clinical context of those numbers of fatal or arrest events that happen has a whole range of different contexts, so it's not a purely adrenergic kind of context at all. There's some exertional arrests and so on, but mostly not. Okay. But a couple interesting things happen. So you remember our little loop recorder thing where I said, you know, there were these sort of funny beats and there was ST elevation and somebody looked at the QT and it looked funny. So now I'm going to highlight that. So one of these things is not like the other. Look at the two red bar QRS T waves, one of which happens when things are running along normal on the left, and on the right what you see is you get this little fast heartbeat and a little pause, okay? And that little fast heartbeat and then a little pause, the T wave afterwards looks totally different, right? Okay? So for the geneticist, that's this little thing here. Okay? Okay, but I think it's fair to say it looks quite a bit different, okay? And then what you see is the beat after that, everything looks okay. Okay, and so that's the putative signature. That's the phenotypic signature of this. And putative, I say just because the scope of this is being worked out, okay? And if you do that, this is a slightly different mechanism to cause the same tachycardia, okay? But if you do that in a healthy person who has a different condition, all of the T waves look the same, okay? So that's, if you remember, that's what that Luke kid had, okay? Had a very funny, big, broad, long QT T wave after that little spontaneous burst, okay? So this leads to Jason Roberts, who is, Jason and Arthur and Thomas and a number of people are leading an international CRDS registry, trying to find these cases and partnering with a lot of the people in the room to try to find these cases. And so what he did is he has a series of these, and then if you look on the bottom here, there's four groups here. There's the CRDS patients, only 10, right? Work hard, international, only 10. Okay? And then with that comes SVT patients, unexplained cardiac arrest patients, and CPVT patients who are undergoing an EP study or are willing to have an EP study. And what you see here at the top is if you look at the QT intervals after that little pause, okay, the QTs are longer. Remember that, a very wide T wave, okay? But if you look at it, the CRDS patients, there's still a few kind of overlapping with where the normal people are. Whereas when you look at the T wave and the T wave amplitude, the most discriminating was in fact basically how much the T wave grew after the pause, okay? So we still have to figure out how accurate there is. There's something called, we're doing a CRDS provocation protocol in a bunch of controls and as many CRDSs as we can find to see what the best test is for it. But in a way, what you do is you just like you do a burst test for CPVT, you do a burst EP test for CRDS, okay? So in our young guy, if we were trying to provoke this and didn't, or we're waiting on the genetic information, what we would do in this situation is we would try to provoke adrenergic events with exercise or burst exercise protocol, or try to provoke that T wave change that you see with an EP study. So the take home. So this is new. For nerds like me, it's cool, okay? And it's loss of function, okay? So it's that gap in our 2x2 chart that we had about calcium and sodium and how that should work, okay? It's concealed in the sense we don't have a good phenotype test, but we have a potential provocative maneuver that requires validation to know what that means. The other thing, of course, is that people who have normal QTs are going to have abnormal T wave morphologies. We know that with heart rate changes, so there's lots of validation and work to do. And the other thing that I didn't go into in any detail is that the cascade of this requires some characterization, in vitro characterization of the impact of the RYR2 variant, because you can't look at the genetic information and assume you know whether it implies gain or loss of function. Okay, and we have much to learn about prevalence, phenotype, penetrance, screening, clinical management decisions, and so on, but that's part of what this community does so well over the last 25 years, and it's been a privilege to be part of it. Thank you.
Well, Alice and Greg have saved the best for last. The last talk is the very provocatively titled, Does J-Wave Syndrome Matter in Children? And our speaker is Cheyenne Beach.
I paid attention when you asked about the taskbar because I'm also a Mac person. My ears perked up. I shouldn't admit that. So I think that was the perfect end of day talk. I'm not sure why you put me after that talk at the end of the day, but I'm going to go with it. So thank you so much to everybody for the invitation to be here today. This has been really fun. So I am primarily a clinician. I'm a pediatric electrophysiologist, and when tasked with this really interesting question, does J-wave syndrome matter in children? I, started with trying to answer the question, and then I realized that I kept having to say, wait, I don't get it, I don't get it, I don't get it, and I had to back up and back up and back up. So I ended up at the beginning of stuff, and I'm gonna then go through things in the way that I had to think about it to actually understand what this question is. And then there are so many people in this room who are smarter than I am that I'd love to actually learn more. I have no pertinent disclosures. We'll talk about what J-wave syndromes are, very briefly about the arrhythmias in J-wave syndromes, specifically J-wave syndromes in pediatric patients, touching on some of the data that we have from the past few years. J-wave syndromes, so you can't talk about J-wave syndromes without talking about Brugada, and so that is infused into this talk, and I think it works really well at the end of the talks that we just listened to. So this J point, I think of it as the junction point, is where ventricular depolarization meets ventricular repolarization, so where your QRS complex meets your ST segment. And your J wave occurs when you have a J point with a dome shape, like we see here on the left. And really the definition of, we'll talk about early repolarization syndrome, which is this other J wave syndrome other than Brugada. The thought about early repolarization has moved away from ST segment elevation to this J wave. And so when we're reading on all our ECGs, mild ST segment elevation may be due to early repolarization, I don't mean early repolarization syndrome, J wave syndrome kind of thing. And so even in preparing this talk, I've had to kind of think about whether I should change some of my verbiage on all these ECG reads that I have. So this is where I had to really back up and make sure that I understood this. So our QRS complex is a result of phases 0 and 1 of our action potential. So phase 0 comes from the rapid influx of sodium ions, and then phase 1 is primarily driven by the transient outward potassium currents. You'll see that the action potential looks different in the endocardium compared to the epicardium. The epicardium is what's affected in these J-wave syndromes. And so when we're looking, you'll see A, B, and C down here. When we're looking at this transmembrane voltage gradient, we're looking at the voltage gradients within the region of where our ECG stickers are between the epicardium and the endocardium. You'll see that the endocardium remains relatively unchanged, and it's really the epicardium where there's a greater density of the transient outward potassium channels where this is affected. And so you can see, I'll show on the next slide, some of our specific genes that are, when mutated, result in J-wave syndromes. But you get this, the transmembrane, difference either by reduced influx, so your phase 0 is attenuated, or you could have an exaggerated phase 1, so you've got a gain of function, more potassium outward current. And so you can see it's a change in the balance of those calcium, the sodium, the potassium that are causing that change in the membrane potential, and that's what you're seeing on your ECG. So that dip where phase 1 turns into phase 2 is going to give you this, never mind that, is going to give you that J-wave elevation. And then what's so interesting is when you get more of an effect on the epicardium, the action potential lasts longer. You get that change in the transmembrane potential that flips your T wave. So that's how you get this negative T wave in the type 1 Brugada pattern here. So just looking specifically at some of our genes that are affected, this is our big gun here, right? This is SCN5A, and this goes for both Brugada syndrome and early repolarization syndrome. We've talked a lot about this. It was very well discussed how loss of function sodium channels can cause these syndromes for us. Same here with the calcium, right? It's the same thing. It's this diminished or attenuated inward positive ions that have loss of function and can result in these syndromes. And then it's the opposite for the outward ion currents. The gain of function in KCNJ8, ABCC9, KCND2, this is the one that can directly affect the transient outward potassium current. So it was interesting when we're thinking of both Brugada and early repolarization syndrome to keep in mind how it's actually happening, what we're seeing on ECG, when we're seeing it on ECG, and why these things might be happening in front of us. So here we have up top the Brugada pattern. Type 1 Brugada pattern is a coved ST segment elevation or a J-wave amplitude at least 2 millimeters in elevation, followed by a negative T wave in the rightward precordial lead. So as we've talked about, especially if we move those ECG stickers up a space or two, we're talking about the rightward precordial leads, this J-wave elevation, and then that negative T wave that I just talked about. Early repolarization pattern, on the other hand, is a J-point elevation, at least 1 millimeter in at least 2 contiguous inferior or lateral leads, because this is thought to affect the left ventricle more than the RV outflow tract. Again, I mentioned that it's really shifted towards that J-point, J-wave being the problem rather than the ST segment elevation, which we're finding out doesn't matter as much. So much overlap. I'm going to move through these points that I just talked about. So there's a lot of similarities, and there are also some differences that are important as we're thinking about Brugada syndrome and early repolarization syndrome. They both have male dominance. They both occur, meaning the syndrome occurs or these patients have clinical effects. They have a phenotype with arrhythmias in the young to middle age. Their VF trigger is these short-coupled PVCs. They have an ameliorative response to quinidine, and then I added isoproterenol also, because you can use that when you need to in an electrical storm situation. They both have bradycardia or pause-dependent accentuation. So this is important to think about when we're thinking of when episodes occur. They occur during sleep, right? They also occur with vagal tone here. That's similar. And it's more prominent in the early repolarization syndrome, more prominent when you have a more abnormal J-wave. So very clearly throughout the literature, the taller the amplitude of your J-wave, the more impressive that ECG is, the higher the risk of arrhythmia is in our patients. You also can have other mild conduction abnormalities. That's pretty common in these syndromes. You can also have short QT intervals. Things that are different, however. So Brugada is less common than an early repolarization pattern on an ECG, but Brugada syndrome is more malignant than having this early repolarization pattern, at least. Dynamic changes are, again, this is another similarity to some of the other stuff we've talked about. Dynamic changes are really common in Brugada. So we see this all the time. You see somebody who walks in the door one day, has a raging type 1 Brugada pattern. You see them again 6 months later, and their ECG is only mildly abnormal. And they were not sick either day. You have no idea why one ECG is so different from the other. The more malignant early repolarization syndromes are going to be more dynamic. So a dynamic pattern, one that changes day to day, month to month, is going to be overall a sign of a probably worse prognosis. So that's one of the things I look for in my patients. Here's an example of an early repolarization pattern here with this J wave. This is the patient's baseline in column A. And then here, very significant J wave that we have just before the onset of ventricular fibrillation here. A little different in the induction or augmentation by hypothermia, common in J wave or early repolarization. And then this induction or augmentation by fever, we talk about this all the time in Brugada, and it isn't a thing in early repolarization. So this is not a trigger in the patients who have early repolarization syndrome like it is in Brugada. Wanted to highlight a couple of these differences, the regional differences that we've talked about before. Brugada being more common in Southeast Asia. Early repolarization syndrome it doesn't have any regional differences except in those of African descent. It's found to be a more common ECG pattern. Response to sodium channel blocker testing too, right? We've talked about this a lot in Brugada, and it is not of any utility in early repolarization. VF occurrence in early repolarization syndrome, these events can happen in sleep, but not as often as we see them in Brugada. They also can happen with activity, and there's a little bit lower recurrence risk. In early repolarization, the recurrence risk of a ventricular arrhythmia is about 6 to 7% per year, which is less than the about 10% per year that we have in Brugada. There's a differential diagnosis that I'm not going to go through in detail, but is important for us to keep in mind. You look at this, hyponatremia one, for example, and there's no way that we'd be able to say, just looking at that is not Brugada. I think this example is really interesting too, this stroke that we have here and that really enormous J-wave elevation here. And then I wanted to point out again in red, we have things that really are specifically affecting the RB outflow tract. So these are things specifically that can cause that pattern in V1, V2, especially in the hypercordial leads, and in that way they really can mimic Brugada. J-wave syndrome diagnosis, I love how this has been presented today. So important to take these detailed personal family histories, especially over time. We all know this, that things come out over time if you keep your ears open. Assessment of potential underlying causes, to think about that list of differential diagnoses that I just presented. Multiple ECGs, especially high parasternal ones like we've talked about. So I like to see these patients a lot. I tend to see them every 6 months until I feel like I really kind of get what's happening, in part because things are so dynamic. And I do think differently about somebody who has a spontaneous type 1 Brugada pattern 80% of the time compared to somebody who has it 10% of the time. I don't really know if that's right for me to think of it differently or not, but I do. And there's also a lot of discussion. There are always questions for these patients, and I actually find that there can be more questions than there are in my long QT patients, for example. Things like, should I still wear a mask to school all the time? What should I do if there's somebody who has flu in the class? Should I stay home? Especially the fever avoidance thing in our pediatric patients. There are daily life questions that come up all the time in these patients. And I find that the anxiety level in families is actually lower over time as they become more comfortable with these questions that come up. And then the sodium channel blocker, I am not going to touch on this in detail because it's been done so nicely here, but I did want to include this table. And then I couldn't help but include the full stomach test. Anyone actually ever done a full stomach test for anybody? So, not on purpose? Right, maybe this is why somebody will have a Brugada pattern one day and not the other for me because they just ate a big meal. I don't know. I volunteer for any studies that are going to be done. But because of the vagal tone that you can get after a large meal, you can have exaggeration of either this early repolarization pattern or the Brugada pattern. So I've never done it either, but I'm interested. And then just touching on genetic testing. So really, this is so polygenic. We've got SCN5A that can cause early repolarization syndrome and or Brugada syndrome, and these couple other players that we're all familiar with here in the middle. There's really nothing that causes just early repolarization syndrome and hasn't been associated with Brugada, right? I'm open to somebody else knowing more than I do about that. But the one case I have of early repolarization that I'll show clearly early repolarization syndrome, as much as we've all ever seen it, and, you know, genetic testing is totally unrevealing. Arrhythmias and J-wave syndrome, so this is due to phase 2 reentry, taking one step back again to the action potential. If we have enough attenuation of that action potential, it is going to come low enough that the cell is functionally repolarized such that it can depolarize again. There's a lot of heterogeneity in this, and so what ends up happening is in the epicardium, you've got cells that are repolarized next to cells that are not repolarized, and so you can generate these re-entry circuits and ventricular arrhythmias as a result. Again, this is the mechanism, we think, of ventricular arrhythmias in both early repolarization syndrome and Brugada syndrome. We have triggers that we know about, bradycardia, high vagal tone, electrolyte abnormalities, medications or drugs that can exacerbate the action potential abnormalities, and then fever in patients with Brugada syndrome, because you get premature sodium channel inactivation that's accentuated at those higher temperatures. So this is a lot of the discussion that we have in clinic. So do J-wave syndromes matter in pediatric patients? Do they matter to this 14-year-old who came in with an influenza infection and syncope and had this Brugada pattern on his ECG? Then this during the same hospitalization when he was afebrile, and this when we put the leads in high parasternal position when he was afebrile. He was found to have a pathogenic SCN5A mutation. Do they matter in this patient, a 1-year-old who came in for evaluation of a murmur? And my non-EP cardiology partner picked up on this ECG abnormality and brought the ECG over to me and said, do I care about this? What is it? This patient, of course, has a pathogenic SCN5A mutation. Does it matter to her sister? This is her ECG. She's got PR prolongation, so she has that associated conduction abnormality. She also has a little bit of ST abnormality in V1 and V2 here, but it's really that PR interval that's impressive in her. Here's her brother, also PR prolongation, little bit of a conduction delay. Here's the mom, the most normal ECG of any of them. And then thankfully, I couldn't help but add here, there's one more little brother who on day of life 1 has a prolonged QT interval that ended up totally normalizing. None of us were concerned about that. So this is a normal ECG for an infant on day of life 1. And I was very happy to be able to tell them that their fourth child was not affected. And does it matter to this patient? This is a teenager who's having atrial pacing to try to get off of ECMO after being cannulated for a VF storm. You'll see here these very prominent J-waves. And it turns out his 26-year-old brother had had a fatal nocturnal cardiac arrest. This was the post-arrest ECG. And I pointed out right there that very impressive J-wave that we have in V3. It's dynamic. Even on this ECG, it looks different. And what I think is most amazing about this ECG, you could call this a left bundle. You could look at this and call this a left bundle. Maybe we wouldn't, especially with the repolarization abnormality there, but somebody might look at this ECG and say that. It's not immediately obvious. It doesn't scream out to you, maybe to us, but to most people, it doesn't scream out J-wave. So in pediatric patients, there's a low prevalence of Brugada, like we talked about. We talked about also how sodium channel blocker testing can be influenced by age. 23% of asymptomatic children less than 16 years old who had a negative Ashmolean test as part of Cascade screening then had a positive test at age 19. And we think that there's a higher risk of adverse events in sodium channel blocker testing in children. It's at least been purported that. I personally haven't had any adverse events with them, but we use them then less than in adult patients. In 2017, this is Cecilia's paper here. So 95 patients, pediatric patients with Brugada syndrome, median age 13 years, had a follow-up period of about 5 years. 9 of them experienced arrhythmic events for an event rate of 1.9% per year. So they came up with this clinical risk score that I think is helpful. You know, we're all still learning about this, and there's a lot of clinical judgment that we're using and a lot of shared decision-making that we're using in taking care of these patients, but it's a point of data that I think is really interesting for us to take into account. And then clinical characteristics and risk of arrhythmic events in patients younger than 12 diagnosed with Brugada. 43 children with spontaneous or drug or fever-induced type 1 Brugada pattern for a follow-up of 4 years, looked at malignant or non-malignant adverse events. Higher incidence of malignant events in those with syncope than in those without, consistent with the adult data we've talked about. SCN5A mutations are associated with a higher rate of malignant events. Spontaneous type 1 Brugada pattern was not associated with a higher rate of malignant events, non-malignant events, premature beats, PR prolongation, or syncope than a drug or fever-induced type 1 Brugada pattern. I think we could argue this, that conclusion a little bit, but I thought that was very interesting. And then sex was not associated with malignant adverse events or the others. And so one of the thoughts is that the hormonal changes that happen in puberty may be protective in females, harmful in males, and so we don't have that same male predominance of events in children that we have in adults. And then, almost done here. Genetic testing in children with Brugada syndrome results from a large prospective registry. The aim of this study was to define the yield and outcomes of SCN5A testing in pediatric versus adult Brugada patients over a 30-year period of time, with ventricular arrhythmias being the primary endpoint. 500 Brugada patients, including 63 pediatric patients, so this is a very large study relative to some of the other ones we have. They found a pathogenic or likely pathogenic variant in 46% of these pediatric patients. We could look at this and wonder if we're getting a different group of pediatric patients. Are they the ones who are more symptomatic, right? It might be a little bit different from the adult patients, but that's 46% is more than what I usually quote my patients. Whereas the adult patients in this study had a 17.2% of them had pathogenic or likely pathogenic variants. They found that these are all children less than 16 years of age, so defined as the pediatric age range, and those who were who did have an SCN5A mutation did more poorly than those without, and that stood over time. So the green is those without SCN5A mutation, and then the red and the blue are those younger and older with an SCN5A mutation. And so the SCN5A mutations were found to be associated with a worse outcome. And then finally, continuous rhythm monitoring with implanted loop recorders. I thought this was really interesting because my patients that I'm worried about in this category all have loop recorders. I don't have that many of them. And so the ones that I do have, I pay really close attention to. We have an aim to describe the prevalence of arrhythmias in pediatric Brugada syndrome and to better understand syncope causes, 147 patients, lots of pediatric patients, median follow-up of 3.6 years. So interestingly, those with recurrent syncope, this is not surprising, had a greater proportion of ventricular arrhythmias. But I thought this was neat in that it again emphasizes the overlap that we have here. So lots of bradyarrhythmias and lots of atrial arrhythmias. Some of this surprised me too. So here's the age range. Those bradyarrhythmias are quite impressive in our teenagers. Ventricular tachyarrhythmias stayed about the same over time. So the young children also affected by the ventricular tachyarrhythmias. And then the atrial tachyarrhythmias too. That was a nice reminder to me about how often that can come up in these patients. So overall, for these patients with, the pediatric patients with Brugada, the ones that I'm more concerned about, so the ones that I pay even more attention to are those, of course, with events or symptoms, those who have a type 1 pattern, either spontaneous or induced, those who have early repolarization pattern in other leads, so that has found to be riskier, those who have an SCN5A mutation, those who have short-coupled PVCs, and also the high-risk social medical situations, the people who find themselves with not really understanding the need to avoid certain medications, the ones who are using drugs despite our multiple conversations, those people too I worry more about. And then with early repolarization syndrome, it's pretty similar. The family history of events matters a lot to me because this phenotype, it can be hard to figure out. A horizontal or downsloping ST segment is more concerning than that more benign looking upsloping ST segment that we have. The tall J wave, the short coupled PVCs, and same thing with the high risk social or medical situation. So my conclusions are that yes, J wave syndromes matter in pediatric patients. We have to have a high appropriate index of suspicion to reach the diagnosis of Brugada syndrome and early repolarization syndrome. Lots of phenotypic and genotypic overlap between the two, and so I find myself having the same sort of approach to these two processes. Low prevalence of Brugada syndrome in pediatric patients, but it's just as malignant as it is in adults. A higher yield of SCN5A testing in pediatric patients, and that SCN5A pathogenic or likely pathogenic variants portend a higher risk of ventricular arrhythmias in pediatric patients. I took out some slides about ICDs, but we have a judicious use of ICDs in PD patients, and as always, it just leads to more interesting and useful questions. Thank you.
Come up. Do we still have time for a quick panel discussion? 10-minute panel discussion.
All right, so there's a question online that I actually had for Dr. Cron as well. How do you manage genotype positive, phenotype negative people in CRDS families?
I have no clue. I think, you know, practically speaking, what you do is you do what you usually do, is you phenotype them and you put them in research for something you don't understand. You know, these kinds of patients where you have some uncertainty, but you believe there's some hard to measure risk, I have a low threshold to put a loop in them just to catch something, recognizing that I'm presuming there'll be smoke before fire and that I know what's going on, which aren't.
So let me just follow up on that. So if you have a young asymptomatic patient who's genotype positive, are you doing an invasive EP study to do the burst spacing?
So we're proposing this for, but the primary reason is really to collect the data on a large enough scale to try to understand its applicability. But, you know, in any of these syndromes, an EP study for me is always a tiebreaker test when you're uncertain about risk or you think it'll influence your. But I think in this particular syndrome, because it's really unrecognized, and even the scope of family histories, like the idea of extreme phenotype bringing to attention these syndromes. Typically, the longer we look, the lower the risk, right? So, you know, I suspect that these family members are at very low risk in general, but I would offer them an EP study.
A question for Andrew, actually related to that. That's kind of a good lead-in. Hi, over here. Yeah, so, like, thinking about variant interpretation, one of the most powerful criteria, right, is like a loss of function variance in a gene that's known mechanism is loss of function, right? Right now, that's not really the case for RYR2, if in the annotation databases, but maybe it should be, right? I think, though, that has implications for, like, a secondary findings perspective, right? If suddenly, you know, you would be required to report loss of function variance in a secondary findings context, like you are for missense variants in RYR2 right now. Do you think the data is there right now to do so? And if not, what data would you need to maybe include loss of function variants in a secondary findings context?
That's a really good question. I think Elijah actually has some answers to that, or he'll certainly have some thoughts. What I would say for sure, are you comfortable under the bus now that you're jet lagged? Yeah. But what I would say for sure is that the existing research protocol for the CRDS registry involves characterization, which I think will enrich that gain versus loss kind of mindset, and then they are actually enrolled. So the first thing you do is some little background. So we have about 500 unexplained cardiac arrests. We have 10 variants of unknown significance in RYR2, which most new ones are, and they'll undergo this process of in vitro characterization followed by enrollment in the provocation protocol. That's the basics of guess is, of course, that most of them are not clear-cut loss of function. So it'll be the
You reversed over me as well. Yeah, so this is a fight I've had with the genetics lab about an RYR2 variant that Wayne characterized but hasn't published yet, so we can't really use the data. But it's a family where you basically have to gene test and have a reason to do EP studies in patients. I'm just a bit reluctant to go and do invasive EP studies in patients, and I haven't actually got a gene variant knowledge in them because it's just such an invasive bit of phenotyping to do that it's creating problems. But the other problem as well is that we picked up one variant in RYR2 that has some loss of function phenotype, but also has some activation kinetic abnormalities that makes it slightly different from CRDS, according to Wayne, and we're going to study it further. That's a recurrent variant causing BCM, sudden death.
Called Bear syndrome?
You can quote him.
Yeah, and I think that's one of the reasons why this is an easy thing to advocate in the ICD previous cardiac arrest population, because many of them are quite curious about any new clues. And having been told you have an indeterminate challenge is the invasiveness for FDRs.
Hey, question for Dr. George. I'm a pediatric cardiology fellow. I recently came across a question in board review about asking about lung QT and sick sinus syndrome, and it was SCNA5, so I know who to blame now.
I didn't write the question.
But I get the privilege of asking you, is there a suggested mechanism for sick sinus syndrome in this particular?
Yeah, it's a great question. The sick sinus syndrome you would think would have some abnormality linked to the sinoatrial node, but it's probably not it, because there's probably not sodium channels directly in the node itself, or the firing cells that are pacemaker cells. However, there's lots of myocardium around the SA node, and that beat has to get out. So the thought is it's probably just an escape problem, and ultimately that's consistent with a conduction, an impaired conduction in the myocardium. Why it's so focal in that area is not clear.
Block then? It should be exit block.
Right, exit block, right. I think that's the more conventional term.
I'm just going to quickly ask one of the online questions. So CRDS is a popular topic. Can you speak more, I suppose, Andrew, about the overlap between seizures and CRDS?
There is apparently one case where there's epilepsy, and the question is, could it be related, since we share channels with our brains and hearts? So not much more than that, and I'm not holding anything back.
There's another question for Dr. Cron and for CRDS patients.
Speaking of under the bus,
are there any thoughts as to why mutation in this channel leads to that T-wave amplitude response mechanistically in whatever pacing protocol you use?
That's a really good question for Dr. George.
Not my thing.
I'm sorry, I genuinely don't know. I think that's it's, you know, the long time observation. That's mechanistically unique to a specific channelopathy. With long QT. All see, especially in that cycle, if you would look at the long QT patient is long fine, and then they get a PVC, and then there's and then the QT after that looks ugly, and then other PVC, and then stabilize things until they go into that cycle. And this idea of restitution of QTs, heart rate changes, and all those things are much more complicated. They're very smart. Well, I know you have thoughts about this. I was about to throw you under the bus, but you threw yourself.
No, I think my understanding of it from Jason Roberts and Wayne and Julian Normrod as well, and they're studying it in Oxford as well. They joined the registry because it's a really interesting one to get into. Tachycardia causes overloading of the sarcoplasmic reticulum to a certain point where it exceeds the ability to hold the calcium, that overloads cytosol, cause prolonged intracellular calcium, prolonged repolarization. And that's the understanding of the mechanism of it. If you then introduce a VPB on that T wave, in those patients. So there is an alternative EP study. Then you do the drivetrain, the pause, and then a premature beat. If they go into VF, you prove it IDS, but it's a rather more aggressive approach than just driving. Yes, yeah. So it's about overload to the point where the sarcopassic reticulum can't cope, and it leaks dramatically. Am I right describing it?
I think you are. I'll say something complementary that's more related to long QT3, which is the arrhythmias tend to be more severe during sleep. We found a few years ago that the persistent current or late sodium current conducted by mutants in that disease, the magnitude of that current is worse with low calcium. So during sleep and slow heart rates, diastolic calcium is probably at the lowest level, and that may exacerbate persistent current and be more pro-arrhythmic.
As we're learning that some of these genes are in fact associated with some anybody.
I don't have a lot of thoughts on that. I do know that there are some abnormalities in ventricular morphology that seem to be more prevalent in some of these channelopathies. I'm blanking on the one I'm...
Association with conduction disease and sudden death, as well as developing maladies, but I mean, it's maybe not quite to the extent that congenital heart disease can drive. Complementing some of our...
Don't you also think our arrhythmia syndromes, there's a combination is like a perfect storm.
I think a lot of CHD is... great GWASs, so
I think that's a conversation worth continuing at the reception over wine. Thank you to the panel, and then I think we're ready for closing remarks.
Well, Andrew Cron has been smart enough to tell us there are drinks after, but I will beg your patience for just one more beat. We've had a lot to say today about the experts that are in the room, but looking around the room, many, if not most of the people here are trainees who are folks that are residents and folks that are fellows that have sat here throughout. Oftentimes when fellows come back from conferences, Mac Dick likes to do this to me in the hallway, they will say, I will say to them, hey, what did you hear? What was interesting? What did you learn? And I am always impressed at the answers I get. But I also think that you should practice what you preach. and as a model for the folks that I admire and learn from, the fellows and residents here, I'm just gonna take 1 minute to give you some of the things I heard today in an attempt to say, this is what I hear from you guys and I appreciate it, and part of the way to express appreciation is do the same thing that I ask you guys to do. So at grand rounds, we heard that 4% of pathogenic and likely pathogenic variants is probably about right in sudden infant death syndrome, but higher, 15 or 20% in the young. And the conversation afterward taught us that we need to be the people that are advocating for medical examiners and coroners' offices to be incorporating genetic testing into standard of care rather than just when someone thinks of it or someone's clever enough to have read the literature. In the long QT session, we heard that there are an increasing appreciation of the side effects of beta blockers, and we need to be thinking about other ways to treat these patients well, whether that's sympathectomy or whether that's the increasing understanding that exercise in long QT syndrome is good for you, and to think about how to communicate that with families. In the third session, they appropriately walked us through the challenges of interpreting variants of uncertain significance. But despite having conversations like this in many meetings, one of the things that was really unique here is people pivoted to talk about genes of uncertain significance and how important it is to understand not only the variant, but how important is the gene for the condition in the person you have sitting in front of you. Andrew Landstrom is right. The fourth session should have been titled The Central Dogma of Biology. And it helped underline why the genetic cardiology remains one of, if not the most exciting places to practice medicine. And if you think about all the things that people talked about in that session, they are just scratching the surface of where we're going to be in the next 20 years. And if you're thinking about a cool place to practice medicine for 20 years, this is one of them. Finally, in the fifth session, almost done, the AVC case presentations highlighted that the disease has progressed from a single phenotype, most typical of PKP2, into a diverse group of phenotypes, all of which have their own unique characteristics. And so far that now the risk calculators have diverged into two, one for classically right ventricular cardiomyopathies and one for more left ventricular cardiomyopathies. And then our closing session discussed pleiotropy. This idea that genes are complicated, this idea that phenotypes are complicated, and some of the people who are leading us forward into the new era of what genes can do helped us understand that patients matter. And in particular, when you think about a patient who has a weird EKG or an EKG that you or one of your partners brings to you, it may be an unusual presentation of a gene we know well, and there's a lot of experts that you met today that you can call and find out more. So everybody enjoy the reception. Thank you for coming. Thank you for staying. Thank you for attending. I'm honored to have been a part of this. Thanks, man. Phenomenal. Yeah, we're pleased you guys have been great. Great attendance. You really was. And you get people to come. I give them money. Good. Hey. Spot on. Thank you. Thank you for coming. Summarizing the whole day in 90 seconds. Well, if you ask your fellows to do it, maybe you ought to be willing to do it once in a while yourself. So I'm so glad you're here. Thank you for coming and joining.
Thank you. It's a really interesting meeting. And the whole structure of it is, I've never been to something that this way. Especially like first time I hear about. Thank you. You know, like somebody says, well, car accident.